तो ये जो भी क्या नाम मेडस्किल पे जो जो लिंक भेजा उसी से काम चल जाएगा, है ना?
ठीक है, हम back करते
अच्छा। यस, चल रहा है। मेरे व्हाट्सएप में भी चिपका दीजिए ना कॉपी, अपने में डाल लीजिए, या सबसे कोने में, हाँ, इसी पे डाल दीजिए। मैं भी और लोगों को भेज दूंगा। अपने सिस्टम पे चला के देखिए ना, क्योंकि मैं इस पे अपने मोबाइल पे चलाता हूँ। चल रहा है। चल रहा है ना? चलिए ठीक है, मैं इसको वे करता हूँ, बंद करता हूँ, ठीक है। Good morning, everybody. Dr. Sukita, am I audible?
Yes, yes, sir. Good morning, sir. You are
Okay.
audible.
Yes, yes. ठीक है. I'm just testing. We are making this our presentation live today on YouTube as well. I have shared
Okay,
the link. If you want to share with anybody of your acquaintance, friend, friendship, relative, anybody you can share. They can watch.
okay, okay, sir.
Yes. So, and then we are waiting for our first speaker, Dr. Rachna.
Speaker, Dr.
Yeah,
Rachna.
yes, yes. And others to join in a meeting room. Okay.
Yeah, we have time, sir.
Yes,
There's
yes.
5 minutes left. Huh?
Yeah, yeah. Okay. Okay. Dr. Suchita, Dr. Rachna, and Dr.
Yes.
Samishta is joining in a while. So
Okay,
as
sir.
soon as both are in the meeting room, we'll start our presentation.
Okay, okay, sir. Okay. Okay.
Dr. Suchita?
Huh.
Yeah, Dr. Kirti and Dr. Sarmishta is in meeting room. So we have the two speakers now. First, Dr. Rachna will talk, and then after that, Dr. Sarmishta will join. So both
Yes,
are
yes.
there in the meeting room, so we can
Okay.
start the program. Yeah.
Okay, okay, sir.
Over to you.
Yes, sir.
Mhm.
Okay. So, hello and a very warm good afternoon, everyone. I am Dr. Suchita Sinha, working as a senior lecturer in the Department of Oral Pathology, BIDSH, Patna. I extend a very warm welcome to each and everyone present here on the second day of the Pink Dental Conference organized by the National Health Academy 2023. So, this has been organized for the past 2 years, this conference, which gives a very good platform for the practicing women dentists to share their clinical experiences and knowledge with us. So yesterday was the first day of this conference, where very learned, eminent dental practitioners and academician lady dental practitioners, they experienced their clinical knowledge and experienced with us. So there was a very good and excellent opening presentation given by Dr. Neena Gupta on the role of personality development for the women dentist. And she gave a very good take home messages like we should practice the attitude of gratitude, we should not compare ourselves with others. So these messages have enlightened us so that we can improve our day-to-day practice and be a good dental practitioners. Followed by there were lectures by on pediatric oral pathology, importance of lasers in dentistry, and the various causes of orofacial pain and the management of TMD, temporomandibular disorders were also highlighted, followed by a very good lecture on the periodontal microsurgery. So all these lectures yesterday have added a very good knowledge, have added up to our knowledge, and we will inculcate these knowledge in our day-to-day practice. So today is the second day of this conference, where the topics which we are going to discuss are not clinical, but they are of very important significance for women practitioners. We'll be getting to know about the sensitive matters like the legal rights of women in India, like women empowerment, etc. So, which is of very utmost importance for a day to day. Being a woman, everyone should have the knowledge about these things. So, we'll be talking or listening to the lectures of very renowned sorry for the interruption, renowned lady law practitioners who will be sharing their depth of knowledge and experience and enlighten us on the aspects like each and every woman should be aware in the today's scenario. With this, I would like to introduce the first speaker of our session. Is Dr. Rachna available, sir, now?
Yeah, Dr. Rachna is there.
Okay, okay. So will I like to introduce Dr. Rachna Kaushal, who is the professor in the Department Human Rights in the Department of Political Science at the Aligarh Muslim University, India. Ma'am has the teaching experience and research of more than 20 years. She specializes in human rights and has a PhD degree on the topic terrorism and violation. She possesses the university gold medal, has MBA, and has qualified UGC and NET scholarship in the state of Kurukshetra, Haryana. She was awarded Ford Fellowship Foundation in the year of 2001, and she has got fellowships and several awards in the different national and international conferences. She has delivered talks and lectures and has shared multiple sessions and academic sessions in national and the international conferences and workshops. Presently, she is involved in upgrading the human right course in the department and has also engaged in research focused on the issues like women empowerment, consequences, and upsurge. So, with this, I would like to call upon Dr. Rachna Kaushal to take over this session and, explain to us about the legal rights of the women in India. Over to you, ma'am. We are looking forward to your talk.
Thank you, Dr. Suchita. Thank you for such an elaborate introduction of mine. Thank you so much. And
Thank you, ma'am.
It's really an honor for me to be part of this conference because
Yes,
we are
ma'am.
more often addressing the social scientists and scholars in the field of
Yes,
social
ma'am.
sciences, but it's very, very rare that we are interacting with people with this kind of background. Though my husband was
Yes,
also
ma'am.
in medical college, so not
Okay,
a
ma'am.
very new thing for me. I was often interacting with people belonging to this background. But
Yes,
yes,
ma'am.
as a human rights scholar and as a person who has taught this paper on gender issues and rights of women for over 20 years, whatever I have learned, I'm going to share with you.
Yes,
I'm
ma'am.
not a lawyer, but I am a human rights scholar.
Human rights
And
scholar, yes, ma'am.
yeah, and therefore I'll be looking upon the things from that perspective only. And since we have the larger chunk of the audience is from the dental college and the
Dental
medical
side.
college, I'll
Yes, ma'am.
be starting with very fundamental things. So you should be aware of all these, not as a doctor or not as an engineer, but as a human being, as a woman.
Yes, ma'am. Yes,
You
ma'am.
must know all these things. And I'll be starting with the constitution. So you see, we have a wonderful constitution. We were first of those countries, even before many, many Western nations, we recognized sex-based equality as a fundamental right. So you see that we are absolutely at par with men as far as our legal status is concerned. We are entitled to the same set of rights, and then there are special directives to the state by the constitution to work in favor of women, because women has been acknowledged as a historically subjugated group in our society.
Actually,
And
ma'am.
let us start with the constitution, but I'll specifically refer to those sections which deal with women. We have Article 14 to 16 that guarantees legal equality to all. So we all are legally equal. We are entitled to equality before law and equal protection by law. And we are and the state has been especially prohibited by the constitution from making any kinds of favors or discriminations on the basis of caste, creed, sex, and religion. But you see, then there are exceptions, like we have the provisions of affirmative actions or protective discrimination that empower state to make special provision for women and children. So you see, we have Article 15.3 and 16.3, which talks about affirmative action, and the 33% reservation that we see for women in local self-government. आपके पंचायत राज में और आपकी जो अर्बन लोकल बॉडीज हैं, आपके यहाँ वार्ड के इलेक्शंस होते हैं, मेयर के इलेक्शंस होते हैं, कहीं कहीं मेयर की सीट ही women के लिए रिजर्व कर दी गई है. Then पंचायत में we have 33% reservation for women in panchayats and local self-governing bodies. Then we have a number of directives which are called directive principles of state policy, which are not rights for which we can not approach the court if they are violated, but definitely they act as a directive or a guideline to the state कि state को किस दिशा में move करना है. And gender equality and women empowerment is one of the goals that has been assigned to the state by the constitution. Because जब constitution बना है, though in the making of the constitution there were about 13 women who played a very seminal role in the making of the constitution, and they made innumerable valuable contributions in the debates and discussions and in the making of the constitution जिसको हम अभी तक एक मेल हैंडीक्राफ्ट मानते हैं, ऐसा नहीं है कि उसमें women का रोल नहीं था. So there are a number of directive principles of state policy. The constitution makers were well aware कि women का जो status है वो हमारी society में बहुत low है. They are historically subjugated. High rate of illiteracy है, ignorance है, unemployment है, lack of resources हैं, and they are on the periphery of development in every society. So you see the key directive principles of state policy जो कि state के लिए guideline की तरह act करते हैं, और state को एक directive दिया है constitution ने that you have to ensure adequate means of livelihood, equal pay for equal work, जो बहुत prevalent है हमारे यहाँ. एक ही तरह के काम के लिए आदमी को एक salary मिल रही है, औरत को दूसरी salary मिल रही है. This is happening even in organized sector. Journalism में I was listening to Sabha Naqvi, who is a very prominent journalist, and she was saying कि journalism में ये जो gender divide है इतनी ज़्यादा prominent है कि same kind of work के लिए women are getting less lowly paid and men are getting higher salary. Just imagine what happens in unorganized sector. Unorganized sector वो है जो कि जिसके ऊपर कोई कानून नहीं चल रहा है, और हमारी सिर्फ 4.4 to 5% women are working in organized sectors. Our majority, यानी 95% of women are working in unorganized sectors. वहीं पर वेस्ट में अगर हम लें तो ऑर्गेनाइज सेक्टर में काम करने वाली औरतों की जो परसेंटेज है that is 70 to 75%. So you see that such a huge number of working women are out of any kind of legal protection in our country, and therefore an act was made. ये एक directive principle था, equal pay for equal work, जिसको कि एक act की शक्ल दी गई 1976 में equal remuneration act करके. तो अभी भी ठीक है, जहां बिल्कुल गवर्नमेंट की ऑफिसर्स हैं वहां तो हम इस चीज को स्ट्रिक्टली इम्प्लीमेंट कर रहे हैं कि इक्वल पे फॉर इक्वल वर्क, बट हमारे पास बहुत सारे प्राइवेट सेक्टर्स हैं, हमारे पास जर्नलिज्म है, हमारे पास और बहुत सारे ऐसे सेक्टर्स हैं जहां पर कि जेंडर डिवाइड एज फार एज द सैलरी इज कंसर्न अभी भी एग्जिस्ट करता है. एंड एज आई टोल्ड यू दैट ओनली 4 to 5% women work in organized sector. 95% of working women are working in unorganized sector. आपका एग्रीकल्चर, फिशरीज, डेयरी, और शहरों में बिल्डिंग एंड कंस्ट्रक्शन, वेयर मेजॉरिटी ऑफ वुमेन आर वर्किंग, वो अभी भी बाहर है लेबर लॉ से. एंड देयर आर नो फिक्स सैलरीज, नो वर्किंग आवर्स, नो मैटरनिटी बेनिफिट्स, नो चाइल्ड केयर लीव, ब्ला ब्ला. सो यू सी के अभी भी हम उस मामले में बहुत पीछे हैं वेस्ट से. मैटरनिटी रिलीफ ऑफ कोर्स अगेन आई वुड से कि हाँ, जो गवर्नमेंट एम्प्लॉयज हैं या जो ऑर्गेनाइज सेक्टर में काम कर रहे हैं उनको मैटरनिटी रिलीफ मिलता है, से 4 to 6 months उनको पेड सैलरी मिलती है, देन चाइल्ड केयर लीव की भी प्रोविजन है. बट द इशू इज कि वेयर मेजॉरिटी ऑफ आवर वुमेन आर वर्किंग, दे आर डिनाइड ऑफ ऑल दीज प्रोटेक्शंस एंड फैसिलिटीज. और उसमें भी आप देखिए कि मैटरनिटी रिलीफ का ये इम्पैक्ट होता है कि इनडायरेक्टली ज्यादातर जो प्राइवेट कंपनीज हैं या इवन इन ऑर्गेनाइज्ड सेक्टर, देयर इज अ क्लियर कट प्रेफरेंस फॉर अपॉइंटिंग और एम्प्लॉइंग मेल्स, बिकॉज देयर इज एन एटीट्यूड ऑन द पार्ट ऑफ द एम्प्लॉयर कि भाई इनको हम ये ज्वाइन करेंगे, फिर इनको मैटरनिटी लीव दो, इनको चाइल्ड केयर लीव दो और पूरा पेमेंट करो, और उसके बाद वी आर डिप्राइव्ड ऑफ अ वर्क फोर्स. तो ये मैटरनिटी रिलीफ एक तरह से बेनिफिट है, लेकिन इनडायरेक्टली वो एक नुकसान भी देता है, बिकॉज देन इवन इन गवर्नमेंट जॉब्स एक क्लियर कट डिनायल होता है, एक रिलेक्टेंस होता है वुमेन को अपॉइंट करने के लिए या एम्प्लॉयमेंट देने के लिए. So we have a number of directive principles of state policy and fundamental rights. Then we have a number of sections of IPC, Indian Penal Code, that says 304B, for example, deals with dowry debts, which is a penalized crime, जिसके लिए penalty मिलती है. 326A, जिसमें acid attacks हैं. Similarly, we have a very important section of CRPC, section 125, that guarantees lifelong maintenance to all destitute men, women and children, irrespective of their religious identity. और इसी रो में आपका फेमस शाहबानो केस था, जहां पर कि एक ऑलमोस्ट 60 इयर्स होने वाली औरत को जो कि रीमैरिज के चांसेस नहीं थे, जिसके पास कोई इमीडिएट सोर्स ऑफ इनकम नहीं था, उसको सिर्फ 200 रुपए की एक लाइफ लॉन्ग मेंटेनेंस कोर्ट ने दी थी, जिसको कि बेचारी ने कम्युनिटी के प्रेशर में कभी भी एक्सेप्ट नहीं किया, और उसको भी हमारी गवर्नमेंट ने, उस समय की राजीव गांधी की गवर्नमेंट ने अपसाइड डाउन कर दिया, उसको डिनाई कर दिया. सो यू सी दैट there are number of pro-women provisions in the Constitution, in IPC, CRPC, and there is no dearth of law. लेकिन मैं सिर्फ रेफर कर रही हूँ 5 important laws को. You have so many pro women laws. हमारे पास इतने सारे laws हैं जो कि women को crime and violence से प्रोटेक्ट करती है. लाइक फॉर एग्जांपल मैं आपको बताऊं कि क्राइम की इंटेंसिटी 2001 और 2018 तक 15 लाख रिपोर्टेड केसेस ऑफ रेप. नाउ व्हाट अबाउट अनरिपोर्टेड केसेस? You know, every year these cases of rape are increasing and they are becoming much more heinous. And till 1982 we were dealing with a very antique piece of rape law जो कि ब्रिटिश पीरियड में बनाया गया था. एंड ऑब्वियसली बिकॉज ड्यूरिंग द ब्रिटिश पीरियड जो लॉ बनेगा वहां पे जो मेन कल्प्रिट्स होते थे रेप के, दे वर ब्रिटिश ऑफिशियल्स और जमींदार्स एंड बिग लैंडलॉर्ड्स. सो obviously this law was full of loopholes to give all sorts of protection कि कैसे भी वो जो ब्रिटिश ऑफिशियल्स हैं या बिग लैंडलॉर्ड्स हैं उनको एक सेफ एस्केप मिल सके. In 1979 we got the famous मथुरा ट्राइबल रेप केस जहां पर जो जजमेंट आया था उसके बाद women activists were on the road. Now एक छोटा सा मैं कुछ पॉइंट्स बता रही हूँ कि 1979 में कोर्ट ने ये कहा कि since this girl 16-year-old girl ran away with her boyfriend, she cannot be raped. A woman who ran away with her boyfriend is a woman of loose character and therefore she cannot be raped. Secondly, there were no signs of agitation or resistance and there were no signs of physical injury on the part of, and she was raped in the police custody, you know. She was raped in the police custody. She ran away with her boyfriend, this tribal girl. She wanted to marry him, but she was caught by the policeman and she was raped in police custody. और कोर्ट का जो जजमेंट था वो ये था कि a girl who ran away with a boyfriend cannot be raped. There were no signs of physical injury on the part of the perpetrators, and therefore there was no sign of resistance. So there was a tacit approval by the victim, and safe acquittal हुआ, पुलिस वालों को छोड़ दिया गया. This created lot of agitation throughout the country, and for the first time the anti rape law was amended in 1982. And then Dowry Act जो कि 61 में मिला था, that was amended in 84 and again in 86, and therefore we can call 1980s as the decade of pro women legislations. बहुत सारे legislations उसके बाद सामने आए, बहुत सारे laws सामने आए, बहुत सारे existing laws were amended. So there are a number of laws, but I'll refer only to a few 5 important laws जो हमें जानने चाहिए. हाँ, because I'm referring to the rape law, और मैंने आपको एक ट्राइबल गर्ल के रेप केस में जजमेंट के ऊपर रिफ्लेक्शंस दिए हैं. That was in 1979 and 82 में rape law was amended. It was made more stringent. Over the years इस law को और stringent बनाया गया and come to 1997. 1997 में भवरी देवी, who was a volunteer working with a child marriage, working to stop child marriage in the villages of Rajasthan, was gang raped by the upper caste people of that village. कि अगर तुम child marriage रुकवाओगी तो child marriage is a part of our traditions, हम उसको करेंगे, और अगर तुम रुकवाओगी तो हम तुमको rape करेंगे. And she was raped, gang raped many times in her field. तो वहां पर कोर्ट ने फिर कहा कि since she was raped in fields, it was not a workplace. तो उसको वर्क करते समय रेप नहीं हुई. उसके अलावा कोर्ट की बड़ी स्ट्रेंज स्टेटमेंट्स थे, ऑब्जर्वेशंस थी कि भवरी देवी वाज अ दलित and the rape के जो perpetrators हैं, they were upper caste people. So upper caste people cannot rape lower caste women. Then Bhavri Devi is not so good looking to be raped by people, by men. Then thirdly, उस ग्रुप में कुछ रिलेटेड लोग भी थे, जैसे जिन्होंने गैंग रेप किया तो उसमें चाचा भतीजा. तो कोर्ट क्या कहना था, नो, हमारी संस्कृति अभी इतनी नीचे नहीं गई कि चाचा भतीजा एक औरत को रेप करे. नो, कुछ तो दीवारें रहती हैं. दिस वाज अ वेरी स्ट्रेंज जजमेंट 1997 में, यानी इतने सालों बाद. सो एन एनजीओ कॉल्ड विशाखा अप्रोच्ड द कोर्ट, और उसके बाद विशाखा गाइडलाइंस आई, फेमस विशाखा गाइडलाइंस आई, जिसको मैं बाद में रिफर करूंगी, अगेंस्ट सेक्सुअल हैरेसमेंट ऑफ वुमेन एट वर्क प्लेस. और फाइनली उसने 2013 में एक कानूनी शक्ल ली. सो यू सी देयर आर प्लेंटी ऑफ लॉज, बट आई विल रेफर ओनली टू 5 लॉज दैट वी मस्ट नो, नॉट ओनली एज अ वुमेन विक्टिम but as men and women, as perpetrators, as victims, समाज का हिस्सा होने के नाते हमें ये लॉ मालूम ही होने चाहिए. इसमें सबसे पहला लॉ जो मैं चाहूंगी कि सबको मालूम होना चाहिए, that is Protection of Women from Domestic Violence Act 2005. And this is perhaps one of the most wonderful pieces of legislations ever made in India to give protection to women. Now, for the first time, the definition of domestic violence was enhanced. It includes physical abuse, emotional abuse, verbal abuse, sexual abuse, economic abuse. You know, large number of working women, jinki ki their salaries are just snatched away by the husbands at the end of the month. And I know many working women who do not know what their basic salaries are, and who do not know how to operate their ATM cards. वो कभी अपने ATM का मशीन पे नहीं जाती हैं, वो कभी अपनी सैलरी ड्रॉ नहीं करती हैं, वो अपने अकाउंट से कभी पैसा विड्रॉ नहीं करती हैं. What is this? This is nothing but a kind of financial abuse, you know, that they are facing. And there are around 26% of reported cases of domestic violence. Now 26% reported hai. There are large number of unreported cases, because the biggest problem is with domestic violence is that more than 90% of women do not acknowledge it as a crime, as a kind of violence of their, you know, rights. और पहली बार इस एक्ट में perpetrators की जो definition है, जो list है, उसको बढ़ाया गया. So it is not only the husband and the in-laws, but both the members of the nuptial and natal family are included, can be the perpetrators. Even your boyfriend and your live-in partner can be persecuted under this particular act. और सबसे बड़ी चीज ये है domestic violence act की कि usually a woman doesn't fight against her husband and in-laws thinking कि where will I go if I fight against my own family? If I fight against my husband, if I sue my husband, my in-laws, मेरे को घर से निकाल दिया जाएगा और मेरे सर के ऊपर कोई छत नहीं है. So one of the important feature of this particular act is PWDA is कि right to residence जो है वो women के साथ रहता है, even if you are fighting against your in-laws and your husband. So उसके अलावा जो एक बहुत important act है जो we must know for our protection is Dowry Prohibition Act. Both giving and taking of dowry is a crime, and even abetment, you know, is a kind of crime जो कि punishable है, जिसमें कि penalty मिलती है, और it is basically to stop the practice of dowry. That the third important law that you must know is the Preconception and Prenatal Diagnostic Techniques Prohibition of Sex Selection Act 1994. I think ज़्यादातर since you people are from medicine and medical and dental background, you must be familiar with this. So this is basically to control female feticide, stop sex selection, to regulate this technology only for the use or diagnosis of, you know, congenital abnormalities, and to stop the misuse of this technique leading to female feticide, जहां पर की punishment है दोनों के लिए, जो डॉक्टर करता है उसके लिए भी और जो पेरेंट्स करवाते हैं उनके लिए भी. The next important act that you must know, because majority of us, I think जिन्होंने भी सब join कर रखा है इस conference को, we all are working women, and we must know the protection of women against, you know, sexual harassment at workplace, जो कि एक बहुत ही important act है. Sexual Harassment of Women at Workplace Prevention, Prohibition and Redressal Act of 2013. लेकिन इससे पहले बाबरी देवी के केस हुआ. बाबरी देवी के केस के बाद 1997 में विशाखा नाम की एनजीओ ने इस मैटर को कोर्ट में लेकर आए, एंड सुप्रीम कोर्ट, क्योंकि इट इज वेरी सरप्राइजिंग that even after, you know, 8 or almost 9 decades of our independence, 50s, 60s, 70s, 80s, 90s, almost 5 decades of our independence, और इतना large number of working women होने के बाद भी हमारे पास कोई एक्ट नहीं था जो women को at workplace harassment से protect कर सके. So Supreme Court gave certain guidelines in 1997 called Vishakha Guidelines, and during that judgment, Supreme Court said that sexual harassment at workplace constituted a violation of fundamental rights of gender equality and right to live with dignity. Women dignity और gender equality दोनों का violation है. It is a violation of your right to equality before law and equal protection by law, and it is violating the dignity of women or dignity of women या equality of both the sex anywhere, चाहे वो वर्किंग प्लेस हो चाहे नॉन वर्किंग प्लेस है, इट इज अ फंडामेंटल राइट. सो ये जो गाइडलाइंस हैं ये बहुत इंपॉर्टेंट है बिकॉज ये पहली बार डिफाइन करती हैं इसमें हमें क्या जानना चाहिए, व्हाट वी नीड टू नो. इसमें सबसे पहले ये है कि टर्म सेक्सुअल हैरेसमेंट क्या है. एंड इट इंक्लूड्स बोथ फिजिकल एंड वर्बल हैरेसमेंट, अनवेलकम एक्ट्स, बिहेवियर्स, मेकिंग सेक्सुअली कलर्ड रिमार्क्स, showing pornography, any other unwelcoming physical, verbal or non-verbal conduct of a sexual nature, and the list is non-exhaustive. It may include anything. और ये जो sexual harassment cell है, बहुत सारी चीजें जो यहाँ listed नहीं है, इनको जो है वो करती है कि for example repeatedly asking for dates, sexist remarks, commenting on your body appearance, offering employment benefits in return for sexual favors. ये सारी चीजें जो हैं वो sexual harassment की definition में आती हैं. और इसमें एक बहुत बड़ी जो important चीज है वो वर्क प्लेस क्या है, क्योंकि भवरी देवी के केस में कहा गया कि इसको एनजीओ के जिस एनजीओ के साथ वो काम कर रही थी वहां उनको नहीं रेप किया गया, उनको फील्ड्स में रेप किया गया. तो फील्ड्स तो उसकी अपनी थी, उसके अपने खेत थे, तो वो वर्क प्लेस नहीं थी. बट यहाँ पर इस एक्ट में पहली बार हमने वर्क प्लेस की डेफिनेशन को एक्सपेंड किया. तो इट इज नॉट जस्ट द फिजिकल कन्फाइंस ऑफ योर ऑफिस. इफ यू गो एनीवेयर ऑन अ वर्क रिलेटेड असाइनमेंट इंक्लूडिंग while in transportation arranged by the employer or even office related meetings in a restaurant, या ये सारी चीजें जो हैं वो आती हैं आपकी वर्क प्लेस में. तो भवरी देवी को जो रेप किया गया था वो चाइल्ड मैरिज रोकने के कॉन्टेक्स्ट में किया गया था, इसलिए वो कहीं भी हो वो ऑफिस के काम की जिम्मेदारी निभाते हुए उनका हुआ था गैंग रेप, तो इसीलिए वो वर्क प्लेस में आएगी. इवन इन कोविड टाइम्स जब हम ऑनलाइन वर्क कर रहे हैं, डिजिटली वर्क कर रहे हैं घर से, तो केसेस ऑफ सेक्सुअल हैरेसमेंट आर they are committed through Zoom or other online media and can be brought under the purview of the act. Then you need not you being an employer in the traditional sense also to be protected by this act. Even आप एक domestic work हैं, आप एक part time worker हैं, अगर आप एक घर में भी काम कर रही हैं तो भी आप domestic violence से जो है इस act के तहत जो है वो कवर अप होते हैं. और इसमें जहां पर कि 10 से ज्यादा लोग काम कर रहे हैं वहां पे इंटरनल कंप्लेंट्स कमेटी बनेगी और उसमें जो है कम से कम 4 मेंबर्स होंगे. उसमें 50% मेंबर्स जो हैं वो विमेन होंगी, प्रेसिडेंट होंगी सीनियर विमेन एम्प्लॉय, 2 एम्प्लॉयज होंगे. और उसके अलावा अगर आप लेस देन 10 मेंबर यानी अनऑर्गेनाइज सेक्टर में काम कर रहे हैं या वहां काम कर रही हैं 10 से कम लोग काम करते हैं, तो वहां पर आपकी एक लोकल कमिटी होगी जहां पर कि जैसे कि डोमेस्टिक वर्कर्स हैं, मेड्स हैं, उनके लिए जो है एक दूसरा प्रोविजन है. लोकल कमिटी होती है डिस्ट्रिक्ट लेवल पे, फिर नोडल ऑफिसर होता है तहसील या वार्ड लेवल पे, और कंप्लेंट का एक प्रोसीजर होता है जहां आपको रिटन कंप्लेंट डालनी होती है. तो यहाँ पर जब कंप्लेंट जाएगी आईसीसी में तो इंक्वायरी होगी, और अगर प्राइमा फेसाई कोई केस जो है सेक्सुअल हैरेसमेंट का साबित होता है तो फिर उसको पुलिस को पास ऑन कर दिया जाएगा और ड्यू सेक्शंस के अंडर रजिस्टर होगा सेक्शन 509 ऑफ आईपीसी में, और वहां पर मॉडेस्टी या रेप की कोशिश या थ्रेट करना का केस जो है वो रजिस्टर होगा. और ड्यूरिंग एन इंक्वायरी अगर विक्टिम अनकंफर्टेबल फील करता है और अगर ये पॉसिबल है कि उसका दूसरे डिपार्टमेंट में ट्रांसफर किया जा सके तो वो भी किया जा सकता है, लेकिन अगर वो छुट्टी पे जाना चाहें तो वो छुट्टी पे जा सकते हैं. अब वंस द इंक्वायरी इज डन और अगर ये साबित हो जाता है कि हाँ प्राइमा फेसाई केस जो है वो एग्जिस्ट करता है सेक्सुअल हैरेसमेंट का, तो फिर ये मर्जी है विक्टिम की कि वो कॉम्प्रोमाइज करता है और एक तरह से वार्निंग दी जाती है उस कॉम्प्रोमाइज में परपिट्रेटर को कि यू शुड रिफ्रेन फ्रॉम ऑल सच थिंग्स, ऑल सच एक्टिविटीज इन द ईयर्स टू कम या फ्यूचर में या फिर उसकी जो प्रोसीडिंग्स है वो कोर्ट पुलिस के थ्रू जो है वो चलती है और फिर वो मामला वहां पे डिसाइड होता है। द इशू इज कि हमारे यहाँ जिस चीज को मैं एम्फसाइज करना चाहूंगी वो ये कि देखिए कानून की कोई कमी नहीं है यहाँ पर, लेकिन अब मैं आपको एक वर्ल्ड बैंक की रिपोर्ट बताना चाहूंगी। यहाँ पर 2017 में एक वर्ल्ड बैंक की रिपोर्ट आई थी जिसका ये कहना था कि इकोसिस्टम वेयरइन women can prosper and develop is missing in our country। हमारे यहाँ वो इकोसिस्टम मिस करता है, वो सारी कंड्यूसिव सिचुएशंस मिस करती हैं जिसमें कि वुमेन अपना
हेलो मैम,
yes,
सॉरी टू इंटरप्ट,
yeah,
kindly conclude your lecture. We are
yeah,
falling
I'm just
short of
concluding,
time.
yeah,
Yes,
just give me
ma'am.
2 minutes, I'm just
Sorry to
concluding,
interrupt, ma'am, but
yeah,
kindly
yeah, it's
conclude.
okay। So
Yes,
that ecosystem जो है वो मिस करता है, और वो इकोसिस्टम क्यों मिस करता है? बिकॉज ऑफ आवर माइंडसेट। हमारे पास कानून है पहली बात, बट हाई रेट ऑफ लिटरेसी विमेन में होने की वजह से लीगल एजुकेशन की कमी है। जहां विमेन एजुकेटेड है वहां पर भी दे डू नॉट डेयर टू गो टू द कोर्ट, उनको एक स्टिग्मेटाइजेशन का डर होता है। एंड देन वी हैव अ कम्बरसम लीगल प्रोसेस, जस्टिस डिलीवरी सिस्टम बहुत कम्बरसम है, टाइम टेकिंग है, बार बार कोर्ट जाना लड़ना, उसमें बहुत सारा पैसा, और एंड देन स्टिग्मेटाइजेशन एज आई टोल्ड यू। सेक्सुअल हैरेसमेंट में अगर कोई औरत जा रही है, नहीं नहीं ये तो खुद ही ऐसी है, रेप में कोई औरत जा रही है, नहीं नहीं ये यहाँ इनके भी कैरेक्टर की कोई कमी रही होगी। एंड आई रिमेम्बर एसिड अटैक विक्टिम लक्ष्मी का ये कहना था कि जो एसिड है दैट लाइज इन द माइंड्स। आप कितने भी कानून बना लें, अगर पीपल डू नॉट हैव अ रिस्पेक्ट फॉर वुमेन, उसकी डिग्निटी को हम रिस्पेक्ट नहीं कर रहे हैं, हम उसको घर में औरत को रिस्पेक्ट नहीं कर रहे हैं। डोमेस्टिक वायलेंस आप कितना भी कानून बना लें, अगर हम डॉटर इन लॉ को डॉटर की बराबर नहीं समझेंगे, एंड वी डू नॉट चेंज आवर माइंडसेट कि वो घर की नौकर नहीं, बट शी इज अ रिस्पेक्टेबल पार्ट ऑफ द फैमिली, शी इज अ डिग्निफाइड पार्ट ऑफ द फैमिली, शी डिजर्व सम डिग्निफाइड बिहेवियर, तब तक हम डोमेस्टिक वायलेंस को खत्म ही नहीं कर सकते। If the mother-in-law and sister-in-law are with the daughter-in-law, there cannot be any bride burning. So what we need is more than the law is कि लॉ की एक डिटरेंस वैल्यू होती है। अनफॉर्चुनेटली वो डिटरेंस वैल्यू हमारे यहाँ नहीं एग्जिस्ट करती। कितने हीनियस क्राइम्स हो रहे हैं, रेप का जो परसेंटेज है वो दिन पे दिन बढ़ रहा है। रिपोर्टेड केसेस को छोड़िए, अनरिपोर्टेड इतने केसेस होते हैं। इट्स ऑल बिकॉज वी नीड टू स्ट्रेंथन आवर वैल्यू बेस। We need to, because state is nothing but individual writ large. Individual constitute family and then we constitute a state. So state becomes patriarchal if we are patriarchal. If we are patriarchal, we will not respect our daughters and our sisters and the daughter-in-law as well. और फिर कानून कुछ नहीं कर सकता। रोजाना आप कानून के लिए नहीं जाएंगे, रोजाना हम कोर्ट पे नहीं जाएंगे। Since I'm not left with any more time, so thank you so much for giving me this opportunity to share my views with you, and I'll be joining you in the evening also. I hope जो यहाँ रह गया वो मैं वहाँ
yes, I'm sure. Thank you, ma'am, for such an enlightening and informative presentation for your lecture. So will be very helpful. It will be helpful for us in the future. If any unrightful thing, God forbids, if it happens with us, we will be aware that there are certain laws in our constitution which will be helpful and will be able to live the life of dignity. This will be a very helpful thing for us. Thank you, ma'am. Thank you so much. Thank you for your lecture, ma'am. So I'll introduce our next speaker, Dr. Sarmishta Ghosh, Assistant Professor. Ma'am, are you there?
Yes, I'm there.
Okay, ma'am. So Assistant Professor in the Department of Commerce, Sri Siksha Yatan College, Kolkata. Ma'am has a master degrees in commerce and postgraduate degree in business administration with a specialization in accounting and finance, along with a doctoral degree in the area of finance from the University of Calcutta. With present experience of more than 10 decades in teaching, both undergraduate and postgraduate programs, her primary area of interest is related to investment management, portfolio management, investment products, and finance markets. She has many publications to her credit in various peer-reviewed national and international journals, which include St. Petersburg Management Journal, Russia. She has also authored several books named Investment Management and Alchemy of Portfolio in India. She was recognized for her scholarly work and received Best Paper Award in one of the international conferences. She is a life member of Indian Accounting Association Research Foundation and is also associated with All India Radio as a speaker for different financial marketing programs. So, ma'am, over to you for your lecture on finances in dentistry. We are looking forward to your lecture. Over to you, ma'am.
Thank you so much, Dr. Suchita. Thank you for
Thank
a
you.
nice introduction. And first of all, I would like to thank National Health Academy for inviting me on this particular occasion. And I really feel privileged to be a part of this occasion, this celebration of Women's Day.
Women's Day.
And I am sharing this platform with such eminent persons all across. So it's really a new kind of feeling. This is the first time I'm addressing an audience who, like all of whom are doctors, and especially all are women dentists. So like, it's really a pleasure on my part. And I have a presentation. I would like to share that with you.
Yes, please.
Yeah, just a moment. Just let me know whether the screen is visible.
Yes, ma'am. Yes, ma'am, your screen is visible.
Okay. Thank you so much for your feedback. Right. So as I have already been introduced and my topic has also been introduced to everyone, the topic is finances in dentistry. So the structure of the dental profession, it provides unique opportunities for both the men and women to exercise high degree of autonomy and flexibility, and at the same time, enjoy the status awards associated with being a healthcare provider. Now, worldwide, we are seeing an upward trend in women dentists. As studies have shown, presently the number of women in dentistry is increasing significantly. Now, the career choices for women dentists mainly vary from private practice to government sector or academic institutions. Now, since most of us here, and as I have an understanding from Dr. Anwar, that all will be women doctors here, and most of you are already on job, you are with some government hospitals, or you are into academic institutions, or maybe you have already started your own private practice. Now, if you are not already into private practice, then I have certain things to share with you. Like, what are the things you should consider before starting a private practice? Now, if you are going to open and run your own dental business, you must be comfortable with working independently. Because as an employee of an existing practice, you are working fixed hours, you have nights and weekends to yourself, you are drawing a salary. But going out on your own means that you will have more responsibility. You will work longer hours and may not have the same freedom that you did before. It may be difficult to predict your income on a weekly or monthly basis. And that said, you will also reap the rewards of setting up the practice the way you want, creating a welcoming environment for your patients, and ultimately, if you are successful, earning more money than you would if you were working for someone else. Now, as long as you are comfortable with the idea of being the one who calls the shots and you are willing to put in the time and effort required to build your new dentist office from scratch, then you are on the right track. Now, the next question which you can ask yourself is, am I prepared to do the work? Now, one of the biggest surprises about starting a new dental office is how much work it is. Am I audible?
Yes, ma'am, you are audible.
Okay, thank you. Now, Since it's a huge lot of work, in addition to the money, you are also required to make a big investment of your time, energy, and creativity to attract new patients and be successful. Now, it's also important to be realistic about the investment you will be making and be sure that you are at a place in your life where you can accept these challenges with striking out, associated with striking out on your own. Now, the next question should be, do I have a business plan? Now, the only way to be successful with a new venture is to create a roadmap. Because business plans serve as templates to help entrepreneurs navigate the challenges of their new ventures. You will need to understand how you plan to meet the challenges you will face before you get started. So your plan should include the details of your budget, the services you plan to provide, your fees for each service, payment policies, which insurance plans you will accept, who your competitors are, and your marketing plans and strategies. Then the next question which comes is, have I researched the local market? Because market research is very much necessary for a business plan, but it deserves a separate question because of its importance. It's essential to know about the local market where you plan to set up your office. And before you go ahead with that, you need to ask yourself these three questions. What is the population of the area? How many other dentists are practicing there? What services do they offer? So, whatever be it, you will need a different strategy in an area with only one competitor, and than in a location where multiple competitors include national dental care chains. So you need to take all these into account beforehand. Next question is, have I reviewed my employment contract? Now, unless you just graduated from dental school, you probably have an existing employment contract. Before you go out on your own, you should review your contract with a lawyer if necessary to make sure you are not in violation of any non-compete clause. Now, what are these non-compete clauses? Non-compete clauses can prevent you from opening a new practice within a specified time frame after you leave your existing job or within a certain geographical area. They may also impede your ability to bring existing patients with you to your new dental office. Hence, it's very important to understand your legal obligations before you finalize your plans. Next, and the most important question, do I have the working capital? Now, if you are going to start your dental practice, often as much you require at the beginning is rupees around 5 lakhs. Now, you will either need to have that cash on hand or the credit and collateral so that it qualifies for your loan or line of credit. Because you need money to rent or buy office space, invest in equipment and supplies, hire and pay the employees, and provide benefits for them and advertise to attract new patients. If you don't have the money you need or the means to finance your new venture, then you may need to put your plans on hold until you do so. Now, since we have come to the part of working capital or finance, let us take a look at what are the different kinds of finance available to us. The first one being the Pradhan Mantri Mudra Yojana. Now, this one is the government plan. I'll come to its explanation a little later. Now, apart from this Pradhan Mantri Mudra Yojana, we have several other plans given by different banks. These are actually loans like the Cent Dentist by Central Bank of India, the SBI Dental Doctor Plus Scheme, HDFC Loan for Professionals, Bank of India Doctors Loan, so on and so forth. You can just see the list there are a lot of doctors' loan which are provided. Now, coming to this Pradhan Mantri Mudra Yojana, there are 3 different schemes under which they are allowing you the loan or the credit. The first one is the Shishu scheme, where up to rupees 50,000 is allowed as loan. That means you can ask for a loan up to rupees 50,000. The second one is the Kishore scheme, that is from 50,000 till 5 lakhs, you can opt for a loan. And the Tarun scheme involves rupees 5 lakhs to rupees 10 lakhs if you are going for the Tarun scheme. I have given the link here. If you want, you can take it down. It will give you the entire eligibility condition and the entire detail about Pradhan Mantri Mudra Yojana. Now, coming to the taxability part. Now, dentist, whether he or she is employed or self-employed, need to pay tax as per the prescribed tax slab rate. Now, there are few differences between tax paid by an employed dentist and tax paid by a self-employed dentist. Now, what are the points you should consider while paying taxes? First of all, you first check which income slab do you fall in. Now, if you are a dentist below 60 years old, now this slab is applicable if you are opting for the old regime. If you are not going for the new regime, then this slab is applicable. And for the new regime, as the latest budget has already declared, till 3 lakh, there is no tax for an individual who is below 60 years old, if you are going for the new regime. Now, as an accountant or as a finance professional, my advice for those who are already having some kind of home loan or a certain kind of EMI which they are paying, which is tax deductible. If you are having such kind of expenses already, then you should opt for the old regime rather than the new regime, so that you can claim the deductions which are available. Because the new regime do not allow you to claim any kind of deduction. Okay, even if till 3 lakh, you are not paying any taxes. Okay. Now coming to the old regime, if you are earning till 2 lakh 50, then there's no tax. After 2 lakh 50 to 5 lakh, there's 5% and so on and so forth. This is the tax slab rate. Now, based on the number of years, like your age, the applicable tax slab rate will apply. Now, along with this tax or the calculation of tax, there is the rebate, which is under section 87A. This is applicable to dentist with income up to rupees 3,50,000. Now, the maximum amount of rebate allowed is rupees 2,500. Then you have a surcharge. What is that? If you are earning between rupees 50 lakhs to 1 crore, then you have to pay 10% of the tax as surcharge. If your income exceeds rupees 1 crore, the surcharge rate will be 15% on the tax. However, there is a marginal relief. What is the relief? If your income exceeds rupees 1 crore, the applicable tax plus surcharge should not exceed the part of income which is in excess to rupees 1 crore. That means, suppose you have an income of 1 crore 50,000. Okay, so 50,000 is over and above 1 crore. Now, when you are calculating the tax, your tax is coming to 55,000 inclusive of the 15% surcharge. Mind it, it is 15% surcharge because the slab is if you are in your income is greater than 1 crore. Okay, so now if your tax including surcharge is coming to rupees 55,000 and your excess income over 1 crore is only 50,000, then your tax applicable will be till 50,000 only and not 55,000. So that is the marginal relief which is allowed. Okay. Along with this, you have the health and education cess at the rate of 4% on the amount of tax computed on the inclusive of the surcharge. Okay. Now, based on your type of employment, you have to think about paying your taxes. If you are employed, your employer deducts TDS and he submits it to the government, and you will be provided with the Form 16 at the end of the financial year. And from the Form 16 itself, it will be easier for you to file your returns. Now, if you are self-employed, then what happens? Then you have to follow the provisions of Section 44AA of the IT Act. If your gross receipts from your profession exceed rupees 1,50,000 in any of the 3 years immediately preceding the current previous year, or is likely to exceed rupees 1,50,000 in the current previous year. Now, suppose the current previous year is 2022-23, right? Till March 23rd, it will be 2022 till 23. If you find that during this previous year only, your income is going to exceed 1,50,000 or maybe it will be 1,50,000, then you have to follow 44AA. If you find it is not 1,50,000 in this particular financial year, maybe excluding this 22-23, the previous 3 financial year, taking all the income together, if it exceeds 1,50,000, then also you will have to follow 44AA of the IT Act. Now, this 44AA of the IT Act means you have to maintain your books of accounts in a detailed manner. Now, what are the books of accounts you need to maintain? First of all, it's the cash book. That means it's a books of accounts to record the day-to-day cash transactions. Then you have the journal. Of course, the journal has to be prepared by a certified accountant who knows the double entry system of bookkeeping. Then you have, then you have the ledger. Then the photocopies of bills, whatever you have, if it exceeds rupees 25 in value. Then the original bills and the list of like all the expenses and the income. If your expense bill exceed rupees 50 and you were not issued any bill or receipt, then you should have a payment voucher. You should get payment vouchers prepared and signed by the concerned person. Okay, so these are the books of accounts which you need to maintain under Section 44AA of the IT Act if your income exceeds rupees 1,50,000 in a particular financial year or preceding the current financial year in the last 3 financial years. Now there is another provision for presumptive taxation. What is that? Now suppose it is a very cumbersome task for a doctor to like along with his practice, if he needs to maintain all sorts of books of accounts and he needs to take care of all these things. It's really a cumbersome practice. So there is another provision of presumptive taxation for the doctors. What is that? Presumptive taxation has been explained under Section 44ADA of the IT Act. Here, even if your income exceeds 1,50,000, but if it does not exceed rupees 50 lakhs annually, then you can opt for Section 44ADA of the IT Act. And this act states that you can tax or provide like pay tax on 50% of the gross receipts. That means rest of the 50% of gross receipts is admissible as your deduction by default. So you are not required to maintain any books of accounts, no maintenance of bills or something. Straight away, whatever is your gross receipt, 50% of the gross receipt is taxed, rest 50% is admissible as your expenses. Hope I am clear. If not, I'll invite questions at the end of my session. So the dental professionals who opt for presumptive tax scheme need not maintain the accounts books. So how filing of income tax return helps then? Because this filing of income tax return helps the dentist to avail of many kind of deductions which are available to them by filing tax return. As a doctor, there are few additional ways in which dentists can save taxes. There are various expenses on which tax deductions can be claimed. Now, these are like expenses like salaries paid to assistant dentist, dental chair, site assistants, and other helpers, expenses related to attending conferences for continued education, expenses incurred on consumables and materials used during dental treatment, money spent on general repairs and maintenance of the dental chairs and other equipment, maintenance expenditures related to housekeeping, indirect expenditures such as administrative staff salaries and rent of the dental office if the shop or space is taken on lease. You can claim deductions on various bills like rent, electricity, and maintenance of your dental office, dental lab bills, etc. Along with it, if you are filing your returns regularly, you can also avail easy loans for your further expansion. Now, what are the penalties for non-compliance with the IT rules? First of all, penalty for non-maintenance of books of accounts is rupees 25,000 under section 271A of the Income Tax Act. Penalty for non-complying with tax audit is rupees 1,50,000 or 0.5% of the gross receipt, whichever is lower, as per section 271B of the Income Tax Act. What are the due dates for doctors to file income tax return? If it is a non-audit case, then it is 31st July of the year. If it is an audit case, then 30th September of the year. Now, these are certain tax savers which can help you to save your taxes, along with that to have your investment, because investment is necessary for your future always. The first one being contribution towards employees' provident fund scheme. So this is very much known to everybody. Sometimes we have employers' contribution also. So those who are working, those who are salaried employees, our employer deducts a certain amount from our salary and deposits it in the provident fund. So that is tax deductible item. Next, we have contribution towards public provident fund. So if you are not employed somewhere else, if you are self-employed, this account you can open with any banks. This will give you a risk-free interest of 8%. Till 60 years of age, you can have this account. And after that, whatever earnings you generate, that is tax-free. So this is one risk-free source of investment, which I feel everybody should have at least for a part of their investment, because a huge amount of corpus can be accumulated with a flat rate of risk-free interest. Next, you have subscription towards Sukanya Samriddhi account scheme. If you have a single daughter, if you have opened an account in her name, so in that case, you can claim deduction on that amount of subscription which you have paid there. Next, subscription towards National Savings Certificate. This is known to us already. Contribution to unit-linked insurance plans. So there are certain insurance policies or insurance plans which are market-linked. So if you have invested in any of such, so that contribution is tax deductible. Next, term deposits with a lock-in period of at least 5 years. So if you have taken any term deposit with a bank or post office, which you have to mention that I want to have a term deposit with tax benefit. So there will be a lock-in period of 5 years. And with that amount, you can claim your deduction in tax under 80C. Investment in bonds issued by NABARD, tax savings mutual funds. These are also known as equity-linked savings scheme. These are market-linked because the income generated will be based on the market performance. And there is a lock-in period of 3 years if you are investing in tax savings mutual funds, which are known as ELSs. Then you have life insurance premium, term plan, deposit in senior citizen savings scheme rules. This is only applicable to those who are senior citizen, of course. And last but not the least, the new addition is the National Pension Scheme. Under section 80 CCD 1B, you can claim an additional deduction of 50,000 if you are investing in NPS. So NPS is admissible under section 80C till 1.5 lakh. Like if you are investing entire 1.5 lakh under 80C in NPS, then you can claim deduction under 80C. If you are investing 2 lakhs only in NPS, not in any other kind of investment, then 1.5 lakh you can show as deduction under Section 80C, and rest 50,000 under Section 80 CCD 1B you can claim as deduction. So this additional 50,000 deduction anyone can claim if you are investing in NPS. I'll come to details of NPS a little later. And apart from this, additional claims under 80C are tuition fees for up to 2 children, principal repayment amount on loan, amount paid towards stamp duty and registration of property. Suppose you have taken a house this year, you have got it registered, whatever registration charges and stamp duty you have paid, that is admissible as a deduction under Section 80C. Okay. And whatever home loan you have taken, if you are paying the EMI, the principal amount of that EMI is admissible as a deduction. So taking all these together, your deduction should not exceed 1.5 lakhs. You can invest more than 1.5 lakh. That is not a problem, but you will get a deduction till 1.5 lakhs. Hope I am clear. Next, deductions under Section 80D. This is for Mediclaim or the medical insurance. Now, for payments up to rupees 25,000 for insurance premiums paid on paid on self, your spouse, or in the name of your dependent children. So till 25,000 is tax deductible. Additional deduction for insurance premium paid for parents' medical insurance. Maximum rupees 25,000 is admissible if they are less than 60 years of age, or rupees 50,000 if they are aged above 60 years. Along with this, additional deduction for preventive health checkup of up to rupees 5,000 can also be claimed as deduction under Section 80D. This generally do not require any document to be submitted, but you should keep a note, or it's better if you have the receipts with you. If you have gone through any preventive health checkup during a particular year, and whatever amount it consists of, till 5,000 you can claim as a deduction. Next, deductions under Section 80G. You can either claim 100% or 50% of what you donate by check to recognized institutions or organizations that has already been listed by the government. Donation up to rupees 2,000 in cash is allowed as deduction. But if you have donated in kind, like in clothes, through clothes, groceries, or anything, then you won't be getting any deduction for that. There is no cap on the upper limit of claim for donations made towards valid enterprises and organizations specified by the Indian government. Now let us see that the donations to which fund can help you with 100% deduction to be claimed. So these are certain funds for which you can claim 100% deduction, that whatever you donate, entire amount, you can claim as deduction. And these are the funds for which you can claim 50% deduction. So if you are donating 1,000 to Jawaharlal Nehru Memorial Fund, you can claim 500 as deduction. So likewise, these are certain funds to be like organizations or funds where you can donate. Next, saving for your retirement through National Pension Scheme. Now, we know planning for retirement is a challenge, and it's tricky to know exactly how much you will need to sail through your retirement. Now, there are several tools to estimate the corpus, which use either an income replacement or an expense replacement technique. Ideally, you assume the number of years you may live in retirement and multiply that by the annual expense or annual income that you have just before retirement. But things aren't as simple, because you also need to factor inflation, unexpected expenses arising out of emergencies, or a health ailment that costs more than the insurance you have. What you can do is to opt for NPS and make it your core retirement savings and supplement it with other available instruments to build a retirement corpus which complements your financial needs. So what is a national pension system? It's a voluntary retirement scheme through which you can create a retirement corpus or your old age pension, which is available to all the Indian citizens between 18 to 65 years of age. And if you have not yet joined, you can also join in late as like when you are 60 years old, and you can continue to contribute until you are 70. So this NPS is useful for employees, employers, and also the self-employed. There are two different kinds of accounts to consider under NPS. One is tier 1 and second is tier 2. The tier 1 account is the retirement account and comes with a host of tax benefits. But you cannot withdraw your contributions till you reach the age of 60. The tier 2 account has no restrictions and you can take out money anytime you want. Now, this tier 1 account is mandatory. And when opening an NPS account, it is automatically functional. In contrast, tier 2 can be opened only when one already has a tier 1 account and can be opened with an additional application form. So although tier 1 has restrictions, there are conditions under which partial withdrawal is allowed earlier, such as cases when the subscriber has a critical illness or needs money for children's education, wedding expenses, buying or constructing a house, and so on. Now, as an NPS subscriber, you are required to make an initial minimum contribution of rupees 500.
Hello, ma'am.
Yes.
Ma'am, we are falling short of time, so kindly
sure. I'll
conclude
just
the
finish up
presentation.
in-
Yes, ma'am, please.
Just
Please,
allow
ma'am. We are requesting you to
Sure, sure,
conclude. Yes,
Sure.
ma'am.
So your tier 1 account needs an initial minimum contribution of rupees 500, while for tier 2, it is 1,000. And annual minimum contribution for tier 1 is 1,000 and for tier 2 is 250. And this investment in NPS are all market linked, and they invest in different asset classes like equity, then corporate bond, government securities, and alternative investment funds. There are two choices you can make with the NPS. One is the active choice, another one is the automatic choice. If you are going for the active choice, you have to make your choices like how you want your funds to be deployed. And if you are going for the automatic choice, based on your age, it will be automatically allocated to different funds. Okay. And for tier 1, as I already mentioned, you are allowed 1.5 lakh deduction under section 80C, additional rupees 50,000 deduction under section 80CC D1B. For tier 2, there is no tax benefit. Now, when you reach the maturity age, which is 60 years, you can withdraw the entire corpus from tier 1, which only 60% is tax exempt. For the remaining 40%, you have to purchase an annuity mandatorily. Okay. And for that rest of the annuity part, whatever will be your income based on your slab rate, you have to pay your taxes. 60% is tax exempted. And for tier 2, entire income is taxable. Okay. So to conclude, what are the key takeaways from the session? First of all, if you want a proper financial management, you have to develop a good business plan. Proper financial planning is to be done to support both the present and the future times. You have to plan your taxes properly. You have to select the right loan or source of finance and the correct alternative of investment to support your future, as well as during your time of retirement. So that's all I have for today. If you have any question, I am glad to answer. Thank you, everybody.
Sure. Okay. Thank you, ma'am. Thank you for your presentation. Being dental practitioners, we are every one of us has our independent setup, or we are planning to do our setup in the future. So your presentation will be helpful. I got to know about the various loan schemes that are available for doctors and the various schemes of tax deductions, because I'm planning to set up my own clinic in very near future. So ma'am, I'll contact you if I need any suggestions regarding the finances or anything that is that any suggestion or any help that I'll need in future. Thank you,
Sure.
ma'am.
Absolutely.
Thank you, ma'am. Thank you for
Thank
your
you very much.
presentation.
Thank you.
Thank you, ma'am.
Any questions from audience to Dr. Sarmishta? Ma'am, if there is any question, we'll connect you through phone or we'll email you.
Okay, sure.
And you will, pass the same the answer to those who are asking the questions.
Okay, sure.
So, okay. Thanks, Dr. Sarmishta, for joining us and
Thank
spending
you,
your
Dr.
precious
Anwar.
time.
It was really a good experience.
Yeah. Okay.
So should I?
Yes, ma'am. You can be stay there or you can leave. It's up to you.
No, that's
The show will go on till late evening today by 6 or 7
fine.
p.m. Yeah.
So best of luck for the rest of the session. I hope you already had a great one day and the next day is today and will
Yes.
end up successful.
Okay. Okay.
Thank you very much.
Thanks.
I'll take it.
Yes. So, Dr. Suchita, now we
Yes.
are, the paper presenters are there in the meeting room. So
Yes, sir.
I'm inviting one by one, and you can stay with us or you can leave because there are some 7, 8 paper presenters who will be
Okay, sir.
presenting their papers. All are the designated faculties, academicians, and all. So they will be presenting their papers. They are the senior
So
guys.
I'll have to join back for the presentation of.
So there are 9, so 1.5 hour at least.
1.5 hour. Okay,
Hmm.
okay, sir. So I have one patient to see in the clinic. I'll come back in this
Yes,
time.
Yes,
Okay.
you take care. Yeah.
Okay. Okay.
And among the audience, those who are senior, as I am looking at Dr. Aarti is there, then Dr. Aparna is there. So
Yes.
anybody want to ask question, they can ask the question to these faculties who are going to present their papers. So I'm inviting one by one. Okay. Thanks, Dr. Suchita. You can come
Thank
again
you,
after 90 minutes. Yeah.
Okay, sir.
Yeah. You can keep this on a muted and keep your
Ha,
camera
yeah,
off.
ha.
And
I'll
stay
keep it.
with us. Yeah.
Yes, sure. I'll be connected.
Yes. Okay. Thank you. So, Dr. Swati, are you there in the room, Dr. Swati?
Yes, sir. Yes, sir. Yeah.
Okay, so Dr. Swati, we are late by say 20-30 minutes. So we are allotting 10 minutes to each. So try to finish in 8 minutes so that we have 2 minutes for Q&A. So please share your slide and start your presentation.
Sure. Yeah. I hope it's visible.
Yes, visible.
Yeah. So a very good afternoon. In today's scientific session, I'm here to present my diagnostic accuracy study on the combination of light-based detection system and vital staining for the early diagnosis of dysplasia in tobacco-associated oral lesions. I would like to begin with this quote: "Yesterday is not ours to recover, but tomorrow is ours to win or lose." Let me walk you through the presentation to understand the crux of the quote towards the end. As Dennis Parsons Burkitt, the man who advocated the Burkitt's lymphoma, rightly said, diseases can rarely be eliminated through early diagnosis or good treatment, but prevention can totally eliminate the disease. So I'm going to talk about this. I'm going to emphasize his statement here. We all know that the majority of oral cancers are caused due to tobacco because India stands 6th among the oral cancer. So the intervention can be at the right stage by use of simple light-based detection adjuncts, which can substitute biopsy for the early diagnosis of oral cancer. So now, what is this chemiluminescence? Luminescence is nothing but the property of emission of light when a molecule is not in thermal equilibrium with its surrounding environment. And so chemiluminescence is nothing but the property of emission of light as a result of chemical reaction. So according to the history, the first person who experimented this chemiluminescence was Mr. Henning Brand through his accidental discovery of phosphorus, and the term chemiluminescence was brought into the scientific forum by Eilhard Weidemann. So my diagnostic intervention is going to be the combination of vital staining by the usage of dyes and a chemiluminescent light source. It is actually an optical detection system for early diagnosis of oral cancer. So there are various commercially available dyes for early marker for oral cancer. And again, light-based detection system work on the tissue absorbing and reflecting properties. So according to literature, there have been individual studies where they've explored the use of vital staining and optical-based detection system. So I'm going to combine the use of a dye and a light-based detection system in all tobacco-associated oral lesions. So we had 84 patients, initial tobacco history, they were evaluated, the case history was taken and documented. They were initially screened under incandescent light, and they were divided into two groups of 42 each. Group A was subjected to a stain of Lugol's iodine followed by chemiluminescence, and Group B was toluidine blue staining followed by chemiluminescence. So as you can see, we have used two groups of stains with chemiluminescent combination, and the most representative site was chosen for the biopsy, and the histopath was chosen as the gold standard, as the reference standard to validate the study. So this was the armamentarium. Initially, the patients were subjected to an acetic acid mouth rinse, which works as a cytoplasmic dehydrant. And as I said, they were randomly assigned to either Group A and Group B. Group A they were subjected to Lugol's iodine staining, and Group B they were subjected to toluidine blue staining. And then they were visualized under chemiluminescent light source. So it's actually a battery-operated device that I used. It emits a blue-white light of wavelength 454 nanometers. So to show you an example, so initially we documented the case history of a patient. The demographic details and the habit history was noted, followed by examination under incandescent light. So here, this is a case of oral submucous fibrosis with extensive blanching of both the upper and lower labial mucosa. Palpable fibrotic bands were evident. So this patient was subjected to an initial acetic acid mouth rinse, followed by toluidine blue staining, and then he was visualized under chemiluminescent light source. As you can see, there's a color change, and this area was chosen for biopsy, and the biopsy was shown as moderate dysplasia. So as I told you, two groups, Lugol's iodine group and toluidine blue group. So we had four types of inference patterns. The color changes were observed. So in the group A, when there was dark brown kind of stain with no asto-white, it correlated to a no dysplasia. This was Lugol's iodine group. A brown stain with a mild asto-white hue correlated to a mild dysplasia. And then a light brown stain with a moderate asto-white hue correlated to a moderate dysplasia. And when there was no uptake of the stain with an enhanced asto-white degree, was correlated to a severe dysplasia. So this was a case of severe dysplasia of the tongue with microinvasion. So this was a reverse in case of toluidine blue. In toluidine blue, when there was no uptake of the stain with no asto-white, it correlated to a negative dysplasia on biopsy report. When there was a light blue stain with mild asto-white, it correlated to a mild dysplasia. A dark blue uptake of the toluidine blue stain with a moderate asto-white hue correlated to a moderate dysplasia, and a royal navy blue stain with an enhanced asto-white hue from the chemiluminescent light source correlated to a severe dysplasia with a microinvasion. So this was a cancer of the right lateral border of the tongue. So as you can see, toluidine blue works on the nuclear affinity of the cell. So in normal cells, there'll be no uptake of the stain, whereas abnormal or dysplastic cells, there'll be uptake of the stain. Whereas Lugol's iodine works on the glycogen content of the cell, where normal cells, there will be uptake of the stain. Abnormal cell or dysplastic cell, there'll be no uptake of the stain. So coming to the statistical analysis, so we had a 96% of male distribution and a 4% of female. And among the tobacco-associated lesions, the major group was oral submucous fibrosis. So we also included groups such as smokers, melanosis, and tobacco pouch keratosis that have been thought to have a least malignant potential. So this was the cross tabulation of the diagnostic test group A along with the reference standard, which was the biopsy. So as you can see, there was a 91.7% of sensitivity and a 66.7% of specificity. So all the results were statistically significant. So this was the ROC curve for group A. And coming to the cross tabulation of group B, which was the toluidine blue group, the sensitivity was again 100%, but specificity was 60%. Again, the results were statistically significant. So we had a good sensitivity of 90 to 100% in both the groups, because the major disease state was a true positive state. So again, the ROC curve of group B was also statistically significant. So this is just a summary to show the results of the non-invasive light-based test with the invasive biopsy. We had a good sensitivity in both the groups. Specificity was low because the major state was a true positive state. So coming to the strength and limitations of my study, I would say that this is a very non-invasive procedure. It's a very easy chairside procedure. So a mass screening of the patients could be done. So even patients who are not willing for biopsy, they cooperated better because we were able to educate the patient better to stop the habit at the right time. Some of the limitations, of course, because we had a low specificity, because inflammatory lesions also had a false positive state. So we also, to overcome this challenge, we also devised a nomogram we wanted to quantify the risk prediction based on the results from this simple diagnostic test. So I would like to come back to my initial quote. Yesterday is not ours to recover, but tomorrow is ours to win or lose. So it is in our hands to win against cancer. So since this is a very non-invasive test, it can be used for mass screening. It can be taken in rural settings when an immediate biopsy is not feasible, and also as a routine step in primary healthcare centers, so that we can save a lot of lives. Thank you. And these are some of my references.
Nice presentation, Dr. Swati. Anyone
sir.
among audience can ask a question to Dr. Swati. Dr. Swati, can you introduce yourself? You haven't given your introduction with the beginning of your presentation.
Yes, sir.
You are working where?
Yes, sir. I'm a senior lecturer. I'm currently working in SRM Dental College, Ramapuram, Chennai.
Okay. Okay. So, you just said that, it is good for, community, diagnostics and all. So have
Yes,
you
sir.
ever made, or organized any camp for detection of this? Have you any experience of doing that?
Yes, sir. But we have not organized before, but we are in the process of coordinating with the public health department. So we thought of taking this into many rural centers, especially where you cannot perform an immediate biopsy. So
Okay.
actually, the patient education was also better with this because it's a very non-invasive procedure.
Yes.
Yeah.
Okay. Okay. Nice presentation. Anyone, even presenters can ask a question if you have, because this is the platform where we are learning and we are interacting each other. So even
Yes,
the
sir.
presenters can ask the questions. We haven't kept the faculty's presentation for judgment and all. So there is no any judge at all. So we are just allowing all the presenters or the audience who are there in the meeting room can ask a question.
Yes, glad to answer. Yes.
Myself, Dr. Asha Rathi from Aligarh.
Yes, Dr. Asha. How are you, ma'am?
I'm having severe viral today.
Oh.
Actually, I want to ask her this Tolden Blue is where is available?
Yes, ma'am. It is available in it is available in all the dental labs and also some medical pharmacological centers. Also, they it's because it's been used in oral pathology extensively.
Actually, in the cancer cervix, we used to diagnose for this simple iodine solution for the differentiation of this dysplastic cell and normal cells.
Yes, ma'am.
This we can try in that also, CS cervix also.
Sure, sure. Yes, ma'am.
Really, it's very good. And in our country, as it is a developing and there's a vast population, we can use this one technique
Yes,
for the diagnosis and rest. If there is any demarcation is more, we can refer.
Because patients are not agreed always for a biopsy and also this is a good way to, at least detect early. Yes.
Yes.
So nice presentation, Dr. KV Swati. We are moving to the next presenter.
Thank
Dr.
you, sir.
Minerva. Dr. Minerva, are you there?
Yes, sir. Yes, sir. I'm here.
Yeah. Could you please share
Should
your
I?
slide? Yeah.
Yes.
Give your a brief introduction and then you start your presentation.
Yes, sir. Is my screen visible?
It's showing, but it's not coming as of now. Just, yeah, it's visible now.
Okay, so very good afternoon to all of you. I'm Dr. Minerva Singh, working as senior lecturer at SGT University, Gurugram, Haryana, in the Department of Oral and Maxillofacial Surgery. So I'll be presenting the bizarre case of primary tuberculosis of mandibular condyle. So as we all know, tuberculosis is caused by airborne Bacillus mycobacterium tuberculosis, and it is one of the most challenging systemic disease in developing countries like India. So it can be of two types: pulmonary, where the primary site of infection is lungs, and extrapulmonary, when any other organs than the lungs is the primary site. So extrapulmonary TB basically comprises to 15 to 20% of the total cases, of which 10% is formed by the maxillofacial manifestation. So it
You are not audible, Dr. Minerva.
is osteomyelitis or any other chronic joint disease, which basically leads to suppression and erosion. There are no pathognomic signs and symptoms as well. Late or improper diagnosis can further lead to osteolytic changes in the condyle, which basically leads to disruption of TMJ and thus disturbance in the whole masticatory system. The aim of this paper is basically to emphasize on the importance of considering tuberculosis as a differential diagnosis in infective TMJ diseases. So 40 years old female. She presented with a 2 into 1 centimeter square solitary diffuse swelling in the left preauricular region since 4 months. On examination, it was found that the overlying skin was normal in color with no sinus formation. Ear lobule was not elevated, eliminating the ruling out any parotid related diseases. And palpation, we found out that the swelling was firm, tender, non-fluctuant with no localized rise in temperature. There was no head and neck lymphadenopathy. However, the mouth opening was diffuse and occlusion was satisfactory. Few weeks back, she had taken normal antibiotics like amoxicillin and all, and analgesics in the past, but there was no relief for the patient. So we subjected the patient to CBC, ESR, and rheumatoid factor to rule out any rheumatoid arthritic like disease involving the condyle. But all these reports came out to be normal. Then we sent the patient for ENT examination to rule out any middle ear infection leading to TMJ infection, but it was ruled out as well. So the patient was sent to us by OMR department with cone beam computed tomography. So you can see in the coronal section, the whole cortical surface of the condyle is destroyed by the disease. There is massive destruction involving the trabeculae of the and the spongiosa of the condyle as well. Seems to be eaten out by the disease, and it is quite visible in the 3D reconstruction as well. So we subjected the patient to FNAC examination, and we were able to aspirate a very little blood tinged purulent aspirate, which was inflammatory exudate basically. And we suggested CECT for the patient, and which was suggestive of osteomyelitis with soft tissue thickening extending into the joint space with formation of left preauricular abscess. So we came down to the diagnosis of chronic suppurative osteomyelitis of left mandibular condyle, and then subjected the patient to excisional biopsy under general anesthesia. So we gave a preauricular incision to access the joint space, and we basically excised almost 8 mm of the condylar head region. So in the gross specimen, you can see the whole head has lost his normal anatomical shape, and there is some soft grayish gel-like material deposition on the condylar head. So this excised condyle was then sent for histopathological examination, and patient was prescribed normal routine antibiotics like amoxicillin, metronidazole. First 3 days she was administered IV drugs and then was shifted to oral drugs on discharge. So this was the post-operative OPG of the patient. Here you can see the infected condyle has been removed. So initially patient had some occlusion discrepancies, but we reinforced physiotherapy for the patient, and now she is able to maintain her normal occlusion like before. So what happened when 1 week after post-op, the patient came to us. There was no reduction in the size of the swelling, as well as patient was complaining of pain again. At the same time, we received the histopathological report as well, and it was something which shocked us all. So the features of the histopathological report, they are suggestive of caseating necrosis, granulomatosis, and inflammatory lesion with osteomyelitis, indicating tuberculosis of the joint. So as we were not suspecting TB as such at the time of surgery, there was no suitable specimen available for Ziehl-Neelsen staining, which is basically used for detection of acid-fast bacteria, because we sent the specimen in the formalin. So then we referred the patient to pulmonology department to rule out any primary source of infection, maybe in lungs or any of the organ. Mantouk's text was done, CBNAT was done, but everything came out to be negative. Chest radiograph showed no signs of pulmonary TB. So we came to the diagnosis that this is actually the primary site for the tuberculosis only, and this is extrapulmonary primary tubercular osteomyelitis of the left temporomandibular joint. So we put the patient on the anti-tubercular drug therapy for 6 months and kept her for regular follow-up. So within like 1 week of starting the anti-tubercular drugs, the swelling was reduced. And this is the 1 month post-op picture of the patient. You can see there is considerable reduction in the swelling, and mouth opening is quite nice, that is 45 millimeter. So As we all know, head and neck tuberculosis forms nearly 10% of all extrapulmonary manifestations of tuberculosis. These infections generally somewhere else in the body, but in our case, the primary source is the TMJ itself. Tubercular osteomyelitis is uncommon and accounts for only less than 2% of all the TB cases. The problem is that the clinical appearance of TB infection, the signs and symptoms are unspecific, which resemble other diseases as well, like arthritis and osteomyelitis. Very few cases have been described, secondary TB infections of the TMJ originating from a fistulous communication from a middle layer, which was not seen in our case. Rigero et al. Suggested that histological evidence of granulomatous changes in bone or joint tissue provides an added insight into atypical infection, prompting the clinician to consider a mycobacterial process. So basically, it's a diagnosis of exclusion. That is, even if you're getting a granulomatous change in your histopathological, you have to start with your anti-tubercular regime. C.A. Helbling et al. Presented a case of 22-year-old female similar to ours and suggested that only 6 cases were reported in literature at that time. So this is the article basically from 2010. Complications which basically involving this disease are destruction of the temporal bone, middle ear, mandible, and the parotid gland involvement. Meera Patel et al. Stated that most of the previously described cases in the TMG have been in women, mean age being 33.7 years. And all these cases she included in a systemic review affected the left side with similar presenting features of swelling, pain, trismus, pyrexia, and preauricular swelling. And the radiological features were bony destruction of the TMJ. Aswan C. et al. Suggested preauricular swelling is the predominant functional sign, which was seen in our case as well, often without fever or change in the health status of the patient. And biological and radiological abnormalities, as I already said, are non-specific for this disease. So treatment options are pharmacological and surgical. If the disease is diagnosed earlier, 90 to 95% cure of the disease can be achieved and patient can achieve normal function. But if the diagnosis is missed or delayed, then there can be osteoarthritic changes and severe joint destruction. And in late stages, we are supposed to take the patient under general anesthesia and do surgical debridement with anti-tubercular treatment. So to conclude, I would like to say that primary tuberculosis of TMJ is still considered to be a diagnostic dilemma owing to its rareness and lack of awareness. Missed or delayed diagnosis can basically result in osteoarthritic changes leading to severe joint destruction and misbalancing of the whole masticatory complex. In advanced stages, the disease can spread to systemic organs as well and further worsen the prognosis. Hence, it is of utmost importance to include TB as a differential diagnosis in infectious TMJ diseases. These are the references I considered for this paper, and thank you so much.
Good presentation, Dr. Minerva. This is the rare disease you find yourself in your clinic?
Yes, sir. At my department only, this patient presented.
And apart from that, any of your senior or anyone who diagnosed or kept in a DD about this TMJ tuberculosis? And any other cases apart from which you have detected?
So in our department, like if I talk about my head of the department, he has an experience of like 30-35 years. So he said that this is the first kind of case he has seen in his career.
Okay.
Like TMJ as the primary site of tuberculosis. It can be a secondary site, but primary site tuberculosis is something he said is very rare.
And what about the complaint or the symptoms he is talking? Any fever, weight loss, or loss of appetite? Have you inquired about that? No.
Sir, there was no fever, no loss of appetite. The health status of the patient was
weight
normal.
loss was there? No.
Nothing. Even all the blood reports were normal. That's why I quoted one study there where the author is saying that there can be a case where there are no pathognomic features, no fever, nothing.
Okay.
But still, we have to, rely on the radiological and histopathological.
And there is a correlation of TMJ. This TB is related to female sex actually, which you have shown that most
Yes,
of
sir,
the
yes,
cases
sir.
are in females only.
Yes,
So,
sir.
Dr.
Yes,
Asha, you can ask question. Dr. Asha is a gynecologist. So she can ask a question.
Is
Yeah.
there any family history of tuberculosis? Family
No,
history
ma'am.
of tuberculosis, active tuberculosis.
No, ma'am.
There must be there. Because as you said, diagnosis by exclusion. This is a very right thing which we are facing in the private practice. If there is all where the diagnosis fails, we have to give the trial. In that, so many cases we succeeded in it. Because in private, we don't have so many diagnostic facilities and patient cannot afford even. In that case also, we have to give the therapeutic trial. And if the patient gets a response, because miraculously patient gets a response after that.
Yes.
And
yes, ma'am.
Yeah, patient responds, then we have to give the continuous treatment at least for 1 year. In the Bose tuberculosis, it should be given 1 year, and even it can be extended up to 1.5 years.
Yes, ma'am.
But in that case, if you have a little bit in the mind,
Hello.
I think her internet connection she get disconnected. Okay, let her join again. A nice presentation, and you have shared a rare condition. So I think all oral and maxillofacial surgeons and all oral physicians. Yes, when you were saying something, your net I think get disconnected.
Okay, thank you.
Yes.
Nice sharing. Okay.
Thank you, ma'am. Thank you, sir.
Okay, so we are moving on to the next presenter, Dr. Chetna Joshi. Are you there, Dr. Chetna? I think she is not here. The next one is Dr. Shikha Jaiswal. Dr. Shikha, are you there?
Yes, I'm there. Am I audible?
Yes, you are audible. Please share your slide.
You have to allow me screen share because
No,
I'm not.
You are co-host. You can share your slide. We have made you co-host, so you just.
Okay. Actually, what I'm getting on my screen is when I'm pressing the share screen, that one participant can share at a time. Multiple participants can. What should I do?
Okay, just hold on. Before that, please try once again. There's in the bottom. There's a green icon. Is there? Share screen. Yeah. You just click it.
Okay. Okay. Yeah. Is it visible? Is the slide visible?
Yes, visible.
Okay. Good afternoon, everyone. I'm Dr. Shikha Jaiswal. I'm a professor in Sabati Dental College in the Department of Conservative Dentistry and Endodontics. And my paper is on utilizing of novel techniques and instruments for predictable management of extreme root canal curvature. So it's a case series. I'll be showing few of my cases. Well, this is a very well-known fact that straight root canals and single foramens are more of an exception rather than rule. So what we mostly get in our practices are curved canals. And that is there's a slight bend in the linear relationship of the canal to its long axis. And Snyder had classified these curved canals based on the degree of angle of curvature as straight, moderate, and severe. And those canals which exhibited a degree of angle of curvature to be 25 to 70 degree, he classified them into severe and extreme curvatures. And also the term dilaceration has been given to these severely curved canals or roots. Now, whenever we go for root canal treatment of such severe curvatures, we often end up in mishaps, maybe a ledge formation or a apical transportation or perforation. So as to avoid all these, So as for proper management of these curvatures, there are certain prerequisites like the previous knowledge of internal root canal anatomy or good diagnostic radiographs, but this is not sufficient. What we have to utilize is the novel armamentarium or the newer techniques or maybe the newer devices which we have like apex locators, newer files, or maybe some software so as to predictably manage these particular canals. Whenever we utilize these new technologies, there's always a learning curve before you actually could use them very predictably in your cases. So I'll be showing a few cases of severely curved or dilacerated canals, especially third molars, which are difficult to deal with. The first case is that of apical peritonitis in 3/8. This was meant for root canal treatment. You can see in the preoperative radiograph the severe curvature in the distal root. And the working length radiograph shows that the distal root approximately 90-degree curvature was there and was measured through Snyder's method of measurement of the angle of curvature. And similarly, in the mesial root, there was 45-degree curvature. Now, to manage these particular cases, initially patency, of course, is necessary with the pre-curve files, but micro glide path preparation with rotary glide path files are a must before you actually go for the instrumentation or the shaping. And this is done at a slow speed of 250 RPM at 1.8 Newton centimeter torque. And this special technique which has been used in all the cases, which is a tactile control activation technique. Till the point of curvature, crown down had been used, and apical to the curvature tactile control activation technique was used with the help of a high flex EDM 24% and 25% files. And after finishing of the apical preparation with hand files, you can see in the post-obturation radiograph, the match GP cones were used for the obturation, which was done very successfully, maintaining the original anatomy of the canal. This is another case of a non-vital 4/8. The preoperative radiograph shows that there are 3 roots, and the working length radiograph, you can see the technical difficulty. There was a reverse apical curvature in the mesial root and the approximately 90-degree curvature in the distal root and the mesobuccal root. The instrumentation method was again a hybrid technique. Tactile control activation technique was used and high flex EDM files were used, 24% files, and obturation was finally done utilizing down packing with calamus for 3D obturation. And you can see that even the lateral canals are adequately filled in all the roots. There's another case of pulp necrosis in 3/8. This is a C-shaped canal you can see in the preoperative radiograph. The working length radiograph shows that severe distal curvature was there in the mesial root and mesial curvature in the distal root. So whenever such things happen, it becomes all the more difficult to prepare, especially with the rotary file. Again, tactile control activation technique was used, but here the files, true anatomy files were used, small and prime files, 24%, 26.4% to prepare these canals, which were approximately 85 to 90-degree angle of curvature, which showed. And again, obturation was done with the matched taper cones. And this is a post-obturation radiograph, and you can see that they have been very well obturated. Again, this is another case of symptomatic irreversible pulpitis in 2/8. It was a caries exposed 2/8 with severe apical curvature in the distobuccal root as well as the palatal root. So in the post-obturation radiograph, you can see approximately 90-degree curvature was there in the distobuccal root and 80 to 90-degree curvature in the palatal root. Both of them, they were prepared with the true anatomy files, and subsequently matched GP cones were used for obturating. There's another case of double curvature in the or an S-shaped curvature was there in non-vital 3/8. And although it is not very much visible in the preoperative radiograph, in the post-obturation radiograph, you can see, appreciate both the points of curvature in the distal root of the 8. And the technique of obturation here was not single cone because it's wider canal at the coronal part. So down packing was used, down packing backfilling with the calamus used for post-obturation. Now, we all encounter these cases in the daily practice, and to predictably manage them, we need to plan ahead. As has been rightly said by Benjamin Franklin, that by failing to plan, we are planning to fail. The first thing which we can do is the preoperative risk assessment, and this is done by the Snyder's method. So we have to predetermine the curvature or the angle of the curvature. If we have a 2D radiograph, we can do it with the help of only the mesodistal plane, whereas If we have a CBCT, it can be done in the mesodistal and buccolingual plane. Why is it necessary? So that we can choose the appropriate instrumentation technique for most challenging cases. Apart from that, in the market, we also have 3D endo softwares. Now, it's not available everywhere, but this is CBCT based software, and this is very peculiar because it not only tells about the angle and the height of curvature, it also helps the clinician to select which file is going to suit which particular case. So it's a great advantage to the operator. Apart from that, we cannot even imagine doing endodontic cases like this without the use of apex locators. They have an accuracy of more than 99%, the newer generation ones. And nowadays we have endomotors along with this apex locators, which make the work faster and more convenient for the operator. Again, for initial canal exploration, we can use the stainless steel files, but these cases cannot be managed without the use of the path files. Nowadays in the market, the path files of all sizes are available, 13, 16, 19, and they have very less tape of 2% and 3%. And these small tape of files, they help in creating a glide path, which actually minimizes the procedural error. And they're very flexible files, and they help in preparation of the curved canal for further instrumentation and shaping. Now, in most of the cases, I've used true anatomy and high-plex EDM files because they have a special metallurgy. They are made from M wire or the CM wire, and these are the heat-treated nitrile files. They have a control memory, high flexibility, high cyclic resistance, and very good strength. All these properties are ideal for the management of curved canal. They do not break so easily unless and until we really want them to break. Again, the EDM files, they have got 3 particular cross sections at different levels. So this helps in increasing the flexibility and adapting them to the for shaping of the particular canal. One thing which I've done in all the cases, which is just you cannot do curved canals without this, is coronal pre-flaring. And on the left side, you can see that what do we achieve by coronal pre-flaring? We are increasing the radius of curvature. And on the right side, you can see by pre-flaring, we are decreasing the canal axis angle and the height of curvature, thus relocating the curvature more apically, which helps in putting less stress on the instruments. Now, whenever we use these new instruments, we do have to use new instrumentation techniques. So it's not the usual step back and the crown down only which we're using, which we've been taught earlier. So these 3 techniques are there. The first one is a zone technique. This is actually a mathematical calculation. It's used by a Mex pattern. And by this particular technique, we can calculate the length of the file, which can be projected beyond the curvature. However, it is a little tedious, and that's why it's not so much in use. Next is the reciprocating technique. Nowadays in the market, we have the endomotors which work on the reciprocating motion also. We have 2 particular motions of instrument, that is counterclockwise and clockwise. And this actually removes the stress from the instrument and prevents the separation of the instrument. Also, periapical extrusion of the debris is less. So this can also be tried for the curved canals. It has been seen that when we use these reciprocating files, the shaping of the canals and the maintenance of original anatomy is much better. What I have used in all the cases is the tactile control activation technique, which works on stationary phase for passive file insertion. In stroke phase, we actively push the file slightly apically, and outstroke phase where we withdraw the file while pushing towards a bulkier route. This was given by Anthony Chaniotis in the year 2016, and we do this till the file reaches the working length. So this helps in the maintenance of the original anatomy. It puts less pressure on the instrument, hence the breakage is not there. And it has been seen that by using tactile control activation, even the most severe curvatures can be maintained very properly. So in the end, on the conclusion, I would like to say that when we embrace these new technologies, new techniques for shaping a canals, we are actually not only shaping the canal, but we are shaping the future of a dental practice, because good endo is required as a foundation for further prosthetic rehabilitation. And whenever we embrace new technologies, we should always remember that for mastering them, there are 4 P's, which is planning, patience, practice, and perseverance to get good outcome of our cases. Thank you. And these are the references. Thank you.
Very nice presentation, Dr. Sita. You have, shown light that, you have came across a very, curved roots of, a very, clear anatomy, and you are able to, obturate and all. So a post of, we have a very nice radiograph we have seen. Anyone who can ask questions from the group? So highly expertise domain actually. So one thing in a curiosity, Dr. Shikha, what is the difference of the prognosis of the treatment you are doing for somehow curved and the 90-degree curved root RCT treatments?
See, if you are the prognosis is the same for the straight as well as the curve route. It all depends upon if we are performing the root canal treatment adequately. Adequately means that there's no mishap, like there should be no fire separation or ledge formation, because any mishap is there. To treat that, we have to put in much more efforts. So actually our effort should be more while we are preparing the root canals. At that time, oral effort should be directed towards very patiently preparing it. Jahan pe curved canal aati hai, wahan pe what happens is that we lose our patience.
Patience, yeah. Patience planning practice, what you have just told, yeah. Perseverance, yes, of course. Okay.
So that is what is needed, and that actually with every case that increases the prognosis of the case.
These 4-5 cases you have discussed, when did you do these procedures? Means have you followed up with these patients?
Yes, these patients are actually all these patients, most of them, they had to be given a prosthesis. That means it was serving as an abutment, because usually what happens is that the patients do not want to save the third molars. So it was done in those cases where the accessibility was there, because to use rotary, we need to have some sort of accessibility also. Otherwise, it is difficult to use rotary instrument. And it was meant for some of the cases were there where it was needed for as an abutment for an FPD. So that's why we had to save it.
Okay, nice presentation, Dr. Shikha.
Thank you so much.
So we are moving to the next presenter, Dr. Prachi B. Dr. Prachi, are you there?
Yes, sir, I'm here.
Yeah. Could you please share your slide?
Yes. Sir, I hope my screen is visible now.
It's visible.
Okay. So very good afternoon, one and all. I'm Dr. Prachi Bhandare from Department of Oral Pathology at Dr. G. D. Paul Foundation's Vanti Dental College and Hospital, Navi Mumbai. So keeping in with the theme of the conference, I would like to present my paper today, Vital Phases in Women's Oral Health. What if I told you there is a gender inequality in oral health? One might ask, how is this possible? And the answer lies here, in the hormones that the women experience during their lifetime. Women are more susceptible to oral health problems because of these hormones that they experience during their lifetime. They not only affect the blood supply to the gingival tissues, but also they affect how the body responds to the toxins that result during the development of plaque buildup. So why is this important? Because the oral health, as you know, is very much important for the overall oral health. We say that oral cavity, oral health is the mirror of the body's health, because it is directly related to not only heart diseases, stroke, diabetes, respiratory problems, but also to pregnancy outcomes, very importantly. So there are 5 stages that have been seen and studied extensively in the literature, right from puberty, menstruation, pregnancy, the use of oral contraceptives, and also menopause causing oral health problems. Starting with the first one, puberty, which is the most important and the stage where the sex hormones come up, and there are surging levels of estrogen and progesterone during puberty. Because of this, the oral environment is most commonly affected, and the adolescents which face this have puberty gingivitis and can lead to periodontal problems as well. increased bacterial colonization is another important factor that happens in puberty in the girls. As we already know that teenagers are very nuisance seekers, and whenever they are hungry, once they have food, enough food, high calorie food, sweeteners, etc., they are calm after food. So they are also increased to decay or caries, as we know. So as healthcare providers, we should perform oral health examination in adolescents and girls who are at puberty properly and refer them for further follow-up whenever necessary. The next phase, vital phase, is menstruation, which comes with puberty. There is an increase in progesterone and during the monthly menstrual cycle. And this is when the females may experience canker sores, swollen gums, swollen salivary glands as well, and bleeding gums as well. The menstruation associated gingivitis, menstruation gingivitis is very much common, and the females do experience this. Some females do experience this shortly after their period starts. Now the menstruation related gingivitis does go away, but this is something interesting that I came up in my literature search. The change in women's eating habits during menstrual cycle. And this is something that I myself experienced. So I can relate and others as well. The food intake and food craving do change during the menstrual cycle. And this is a very interesting questionnaire study that I came up across. And as you can see in the results, the desire for foods rich in sugar, salt, fat, and most importantly, chocolate, pastries, snacks, dessert is higher in females during the menstrual cycle. So it is very important that females do take care of, and the dental practitioner is very much aware that the person who is under the menstrual stress is very much going through all these food changes as well, other than the hormonal changes. The next important vital phase is birth control. Now, birth control being accessible to all, women do take oral hormonal contraceptives. They could be oral, transdermal, or they may be implanted as well. And this is something that makes the women susceptible and vulnerable to oral health problems. Why is this important? Is because the state of pregnancy is mimicked when the female is taking the birth control pills. And because of the increased level of estrogen and progesterone due to these pill intakes, there is increase in the bacterial colonization. And the females who are taking these birth control pills, they experience changes in composition of saliva. There is xerostomia in certain patients, and also the periodontal status of the patients taking birth control pills can range from gingivitis to aggressive periodontitis. And so it is very, very important to give the history to the dentist if the female is on oral contraceptive pills. Now, the pills that contain progesterone may cause gingival inflammation and gingivitis, and there is a heightened body's response to plaque and hence the gingivitis. So it is very important that the women who are taking these pills inform their dentist in the history taken. This is important, especially if I give an example, during tooth extraction, this history plays a very major important role because the females who are on birth control pills may experience a painful condition known as dry socket. And this changes the picture altogether. The next important vital phase in a woman's life is pregnancy. Now, it is important to give importance not only to pregnancy, but the phase before, during, and after pregnancy to the female. Now, pregnancy comes with it, brings with it hormone levels which change significantly during the pregnancy. The well-being of a pregnant woman and that of her fetus is very much linked directly to the woman's oral health, as a ton of literature suggests us. So dental care during pregnancy is often delayed because there may be fear on part of three people. Either the woman who is pregnant or the healthcare provider may be fearful of treating the patient, or the dentist himself as to how to treat the pregnant female. So poor maternal oral hygiene can have significant consequences on pregnancy and their outcomes. if the pregnant women are not accessing the dental care that they need. It can not only affect their own oral health, but the health of the fetus as well. So what are the oral health concerns that we should be concerned about in the pregnant women? Not only caries occurring in these patients, but periodontal diseases are a very much important part that they play. Pregnancy related gingivitis is very much common, and because of this, the periodontal diseases are directly linked to premature birth and low birth weight babies. So it is of very much importance, and the dentist should be aware of this. Another very much important factor other than pregnancy gingivitis is the development of pregnancy tumor during the phase of the pregnancy. Now they are very much aggressive looking, but they may resolve on their own once the pregnancy is done. But it is very much important that we give a very close follow-up with these lesions. The CDC itself says that in pregnancy and oral health, one way to prevent caries in young children is to improve the health of the pregnant women. And hence, postpartum is very much important. Postpartum care is very much important because there is vertical transmission of Streptococcus mutans from the mother to child. As we know, the baby is not born with Streptococcus mutans, but there is a vertical transmission, and women with high rate of caries will pass on those oral bacteria to the newborns, okay, by saliva sharing activities, and hence the baby is affected with caries. Now, the baby may be affected with the presence of Streptococcus mutans in their oral cavity by the saliva sharing activities between the mother and the child, even before the teeth have erupted. And it is a very conducive environment for the Streptococcus mutants to destroy the teeth once they are erupted, as soon as they erupt. So it is very much important for the oral health care of the expectant mothers, taking proper care before, during, and after pregnancy. In case of morning sickness, especially because of acidic vomiting, it is important to rinse and clean their mouth after the vomiting. High sugar snacks, which the pregnant women crave, should be limited and should be substituted with appropriate alternatives. The pregnant women and their dentist should take care of the gum diseases and inform the dentist whenever they are pregnant before any dental procedure being taken up with. And it is very much important to keep a close watch on the baby's dental health as well. So it is very much important, very much important phase in a woman's life, pregnancy and oral health. And because it may affect not only the health of the pregnant women, but also the baby, it is very much important to seek routine and emergency dental care whenever at any stage of pregnancy. And we need to make the pregnant women aware that it is perfectly all right to at least consult and then go ahead with whatever the dentist is suggesting as a treatment option. Coming to the next important and vital phase of oral health in women, menopause, which comes with all sorts of symptoms in a woman's life. Cessation of menses meaning menopause results in a decrease in the amount of systemic estrogen, and aging can also present not only with change in hormones, but also comes with oral health complications, and the patients may be on different medications for the same. And hence there are many oral systemic changes that these women are susceptible to. Causing periodontal diseases, not only periodontal diseases, but also diseases related to bones such as osteoporosis, which can cause problem in the bones and cause early tooth loss. So oral pain, discomfort, burning sensation, that is the burning mouth syndrome, is very much seen in postmenopausal women. Another important factor is increase in the rate of xerostomia, okay, and which can directly increase the risk of caries in menopausal and postmenopausal women. So it is very much important to of women's health and its association to overall systemic health, and this cannot be overemphasized enough. Poor oral health can have several detrimental effects on a woman's health across her lifespan, and we should be aware of it. So, keeping in with the tagline of our conference here, we as women oral health crusaders should know the way forward here. It starts by raising awareness of the link between women's hormones and their oral health problems. Proper dental examination should be an integral part of a woman's health. Also, the healthcare providers, other than dentists, should have an understanding of hormonal changes that a woman goes through. And not only here in the dental clinic, but also the dental examination, the oral examinations of a woman at different stages should be incorporated into the physical examination, which barely takes 2 minutes to do. Okay. So the healthcare provider should ask, look, decide, act, and document the changes in the women that they are checking physically as well as dentally. So other than the dental practitioners and oral healthcare provider and healthcare providers, how can women help themselves? As a woman, it is important to pay extra attention to oral health during the 5 stages that we discussed just now. Taking care of good oral health care, brushing twice daily, flossing, and referring and seeking the dental help whenever necessary, talking to the dentist if they have any questions, asking the dentist and letting the dentist and the dental staff know if they're pregnant, always telling the dentist about any medications they are on, especially the birth control pills. So by doing this, we as women health crusaders and women ourselves can raise enough awareness about the dental health problems that the women face in the 5 vital stages in their life, and we can promote oral health for women. Thank you. These are my references. I thank all the organizers for the chance to present.
Nice presentation, Dr. Prachi. You have, comprehensively, given all the stages and, what are the effect of their hormonal changes on oral health and all.
Yes.
Dr. Asha, would you like to ask questions?
Yes, I want to ask you what precautions or what advice one should give for the as a whole female, puberty, pregnancy, perimenopause, menopause.
Yes, ma'am. So, ma'am, as oral healthcare providers, regular dental checkups should be an integral part of women's healthcare during all these vital stages to catch the changes, oral changes early, and which are attributed to these hormonal changes. Not
frequency?
Sorry, ma'am.
How frequently one should go for the dental checkup?
Ma'am, once in 6 months is what we suggest, that the patient should come and visit the dental clinic, have a routine dental scaling and prophylaxis done, so that the oral healthcare, so that the oral cavity is examined, and thereby if we come across any of these conditions that the patient is going through, we can address to them as well.
Okay. And what this oral disinfectant solutions which you were prescribing, are they helpful for this prevention part?
Yes, ma'am. As I suggested here, taking care of their own oral health, not only brushing and flossing as you're suggesting, the oral health, oral rinses can also be a part of the daily routine. If they are fluoridated, more than good.
Okay.
Thank you, ma'am.
And one thing, this actually dietitian used to say one should not have 3 principal meals but small meals. So every time it is not possible to brush after meals or clean teeth after meals. Then how we can prevent it? Proper this kulla will suffice these things?
Ma'am, brushing twice daily is what we suggest generally.
Yeah.
But
After
but
meals, no? After
after
principal
each
meals.
meal, yes. So after each principal meal, having a good oral mouth rinse, if it is coupled with a oral, of course, when we are outside the house, it is not feasible to
Yeah,
brush
yeah,
our teeth.
that's true.
So
That's true,
yeah,
no?
yes, ma'am. Yes,
But
ma'am.
now you should have it. You should discover this brush, no? When a pocket brush, small brush.
Yeah.
One
Ma'am,
should
they
not
are
see
available. Yes, ma'am, they are available. Also,
Ah,
interdental brushes we do have, which are
अच्छा,
small enough.
to keep in the pocket.
Yeah.
Nice presentation, Dr. Prachi. We are moving to
Thank you, sir.
our next
Thank
presenter,
you.
Dr. Vandana Reddy. Dr. Vandana, are you there?
Am I audible?
Yeah, you are audible,
Hello?
Dr. Vandana. Yes.
Okay, I'm just starting sharing my screen. So is my screen visible?
I'm just waiting, just hold on. It's not visible yet. Yes, it's visible.
Okay. A
Give
very
your
good
brief
afternoon.
introduction and then start with the presentation. Yes.
Yeah. A very good afternoon to all the senior faculty and one and all attending this Pink Dental Congress Conference 2023, organized by National Health Academy. I'm Dr. Vandana Reddy, professor in the Department of Oral Pathology and Oral Microbiology, Bharati Dental College, Meerut. The topic of my presentation is Herbal Therapy for Oral Cancer, Review on Current Status and Future Prospective. Oral cancer, it's one of the most common and deadliest diseases all over the world with a 5-year survival rate of only 50%. And it is estimated that 4 lakh people worldwide are newly diagnosed with oral cancer annually. Coming to India, there are 3 million prevalent cases of cancer, though the real number is likely to be much larger as many cases left undetected and unreported. And it is also projected in India that 1.23 million new cases are there a year, with a 20% increase in 2020, leading to 1.7 million new cases a year by 2035. And majority of these patients have late-stage incurable diseases when first diagnosed, calling for a longer duration of treatment involving surgery, chemotherapy, and radiotherapy besides the medication and the checkups. It's currently recognized that modern cancer therapies have demonstrated their limitation in terms of their inability to completely eliminate the tumor cells, drug resistance, and other adverse effects. So given these drawbacks, there is a growing interest in the traditional medicine, particularly the herbal medicine, which is used by 80% of the population in the developing countries for treatment of various diseases, including even cancer. To the best of my knowledge, a comprehensive review that considers the role of plant extracts and their constituents in treating oral cancer has not been presented to the Indian healthcare community. So we all should have a scientifically validated knowledge in order to integrate this alternative medicine as part of the National Cancer Management Strategy. WHO identified main causes behind development of cancer or somatic mutation. The ionizing radiation, which disrupt the hydrogen bonds between the nucleic acid, which will alter the normal DNA expression and regulation of the tumor cells. Even the bacterial, viral, fungal infection can elicit some toxins which are cytotoxic, which will promote the cell proliferation. And the major chemical carcinogens, which can include the hydrocarbons or the nitrosamines in the tobacco or the alcohol, can also cause cell proliferation. Not to forget the reactive oxygen species, which can damage the cell membrane, lipids, and the DNA. Whatever may be the reason for the cancer to occur, the conventional cancer therapy, including chemo, radio, and surgery, are mostly the treatments taken. But they do have side effects when taken for a long time. When 164 patients were interviewed to know the motive behind their decision for alternative therapy to this conventional therapy, financial difficulties and treatment failure were 2 major reasons they quoted. But still, they did have a faith on this alternative therapy. So this has pushed the researchers to look for innovative sources of this anti-cancer compounds in the natural resources. Those are the herbal plants. Herbs, which are defined as the crude drugs of vegetable origin, utilized for treatment of disease states, often of chronic nature, or to attain or maintain a condition of improved health. Earliest reported literature on practice of Indian system of medicine was during the Vedic period, which was 5,000 years old, which recommends treatment with specific drugs and minerals to cure the various diseases. The literature even suggests that several plant extracts to be more effective than synthetic ones, which will have limited or no side effects. In India, 860 billion worth export of herbal raw materials and formulated drugs are then done to the various developed countries. And even the government of India has reported that there are more than 8,000 medicinal and aromatic plants available in India. In 1997, Export-Import Bank of India reported a trade of medicinal plants about 5.5 billion, and now it is growing sharp exponentially. But still, a very little literature is available regarding the cause, validation, and quantification of their biological activity. How actually are these anti-cancer drugs developed? After identification of the bioactive compounds and purified, they are tested on preclinical studies in vitro and in vivo, and then on the clinical studies, and then on the humans. It has been proven that these herbal medicines do have anti-tumor capacity by apoptotic mechanism, or anti-angiogenesis, or anti-proliferative mechanism, autophagy, or antioxidants, or as immunomodulators. Though we have thousands of medicinal plants used for the cancer treatment, the normal dietary supplements like the fruits and vegetables, which are rich in phytochemicals like vitamin A, C, E, or even that green tea or the lycopene in the tomato, all can be acted as antioxidants to kill the free radicals. These antioxidants will kill the free radicals by scavenging them, which will have an immunomodulating mechanism which can inhibit the mutagenesis and inhibit the carcinogenesis. We can know about that there are many types of cancer alternatives that are very popular in India and very old. And one of them is this chemotherapy, which was advocated by the Ayurvedic Vaidya, Dr. S.M. Atik of Lucknow, where he included 6 herbal plants and treated different types of cancer, even the oral cancer. A best case series review process has been used at US National Cancer Institute to assess the available case report documentation of unconventional cancer approaches, and the experience that was gained from this exercise was that there is enough objective evidence to support the idea that this alternative therapy works for some cancer patients. Another alternative therapy is the charcoal therapy, which was again developed by an Indian, Dr. Nandalal Tiwari. He includes 8 different types of herbal medicine, and he said during radiotherapy and chemotherapy, they prevent patients from becoming neutropenic. In other parts of the world, other treatments like Isaac therapy are also used for other cancers, but still not used on oral cancer. Very few case reports of the alternative herbal plants were used along with chemotherapy, saying that this can increase the success of therapy and reduce the side effects of chemotherapy. Another original study said the herbs ginger, curcumin, saffron, and cinnamon had anti-cancer effects on oral squamous cell carcinoma cell line, and amongst these, saffron had the strongest effect compared to that of other studied herbs. That is, mainly it restores the detoxifier enzymes, lipid peroxidation suppliers, and antioxidants to the normal level. And some clinical trials are still going on, registered in the international databases for the treatment of head and neck squamous cell carcinoma, which include different bioactive compounds, the herbal plants, and there are different phases, and it has been proved that, yes, they do have an effect over the head and neck squamous cell carcinoma, including the oral squamous cell carcinoma. And a systematic review also proves that this Asian red ginseng, a herbal plant, is consumed as a dietary supplement in the Western countries known to reduce the risk of cancer, which is even recommended for oral cancer. It acts as an adjuvant to chemotherapy, to reduce the symptoms of carcinoma and to enhance the efficacy of the chemotherapeutic agents, and also to reduce the risk of recurrence in such patients, that is, by cell cycle arrest, induction of apoptosis, and inhibition of angiogenesis. And also, it inhibits inflammation and enhances the antioxidant capacity so that it can reduce the bacterial count and also prevent the progress of carcinoma. The medicinal herbs are a gift from nature to humanity. So I conclude that herbal drugs hold a great potential as chemopreventive and chemotherapeutic agents. But still, it is important to also highlight that clinical evidence on herbal plants in treatment of oral cancer is very limited. So there is an urgent need for further studies to explore the promising phytochemicals from plants to assess their potential uses, mechanism of action, their metabolism, toxicities, drug-drug interactions, and dosage regimes for use as standard herbal medicines. So large-scale, well-controlled, multi-center clinical trials are required to evaluate their efficacies, side effects, and safety in this ongoing fight against cancer. Thank you, one and all. Thank you so much.
Very nice presentation, Dr. Vandana.
Thank you, sir.
So, you have, have you, planned to, do some research with collaboration or with any Vaidya or any, Ayurvedic or
Yes.
college?
Yes, we do. Actually, we are planning, and few studies are already going on, not in our department, in the Department of Oral Medicine. Yes, but in future, yes, I would surely like to take up from this review to an original study.
Okay, because ultimately, because there is very few, papers are not there actually.
Yes, yes,
So
yes.
it's a
Very few are there.
difficult
Not,
that those who
even
are
the literature, it's very limited. So that's what when I searched. Yeah.
So it can be used alongside with surgical or chemo or radio, but
Yes,
we
sir.
have a better
Even some
literature.
studies are going on along with chemo with herbal. Yeah, some original studies are going on.
So it's a demand of the hour actually, because the burden is increasing, and two things is very important. One is that prevention is very important, and with the herbs we can
prevention as well as treatment, both,
and the
right?
treatment,
And the side effects if they go for
Hmm.
the conventional treatment as well.
Yes, of course, of course. Yes. Anybody else want to ask question to Dr. Vandana? Anybody among audience? Okay, there is no question. So thanks, Dr.
Yeah.
There is one question. Yeah.
Hello, this is Dr. Aparna. Dr. Vandana, your presentation was excellent. And
Thank you so
this
much,
is a
ma'am.
very good topic. Actually, I also used to think about it, but you have presented very well. And probably there are lots of studies which can come out from your presentation.
Thank you, ma'am. Thank you.
Okay.
Thank you for your presentation.
Thank you.
So,
Thank you.
yeah, thanks, Dr. Vandana. We are moving to our next presenter, Dr. Rajshree Gurav. Dr. Rajshree, are you there? Yes. Dr. Gurav? Dr. Rajshree? She's there in the meeting room, but she's not responding. So I'm moving to the next presenter, Dr. Huma Iftikhar. Dr. Huma, are you there?
Yes, sir.
Could you please share your slide and give your brief introduction, and you start your presentation?
Am I visible?
Yeah, your slide is visible. Yeah.
So, good afternoon, everyone. I'm Dr. Huma, and I'm working as assistant professor in the Department of Conservative Dentistry and Endodontics, Aligarh Muslim University. And I extend my warm greetings to all the participants who are present over here. And today, the topic of my presentation is basically a clinical guide to the endodontic treatment of non-vital, immature, permanent teeth. So actually, dental trauma is very common in young children. and it is the most frequent cause of pulp non-vitality, which causes immature permanent teeth. And we all know that area of oral region comprises 1% of the body, and this accounts for 5% of all bodily injuries. And in preschool children, oral injuries make up as much as 17% of all bodily injuries. And fall is the most common cause of injury, and most commonly affected teeth are central incisor, which is predominantly in the aesthetic zone. So we should, as a clinician, we should be very prompt in treating them so that the patient does not have any long-term psychological pain on himself. So why the tooth becomes non-vital? The most common cause, as I've already discussed, is trauma. And apart from trauma, dental caries, presence of certain dental anomalies like dens invaginatus and evaginatus also causes the tooth to become non-vital. And according to Andreasen et al., in the literature, it has been reported that 30% of injuries in permanent teeth occurs before the completion of root. So here we will encounter majority of immature tooth, whether root development has ceased, there is no apical stop. So there are a variety of treatment challenges when we treat such cases, because wide open apex lead to apical extrusion of irrigant and filling material. The dentinal wall is thin, which limits the biomechanical instrumentation. And if we aggressively do biomechanical instrumentation in such cases, there are treatment of fracture of such teeth. And if we give large amount of condensing forces during obturation, it may also lead to root fracture. And there is, of course, decreased crown root ratio, which makes our further treatment options either difficult. So there are a variety of interventions when we come across, and while treating these immature teeth, that is multi-step apexification technique, which is basically induction of calcific barrier at the apex, apical plug technique with the help of mineral trioxide aggregate, and root strengthening intervention, that is regenerative endodontic procedures. Because in multi-step apexification technique and in apical plug technique, we introduce apical plug at the apex, but there is no further root maturation. That is, the diameter of the root is not increasing. But in cases of regenerative endodontic procedure, the diameter of the root increases both lengthwise as well as in diameter. So these are the newer techniques which we should opt. And immature teeth can also be treated. Certain cases can be done by endodontic surgeries. And in worst cases, extraction is indicated. So I'll discuss these treatment interventions one by one, coming to apexification. So basically, apexification is the method of treatment of non-vital immature permanent teeth. And it can be achieved in two ways. Basically, we can use either calcium hydroxide dressing, but it is a long-term procedure. Patient has to report to the dental clinic multiple times, and there is chances of washout of calcium hydroxide dressings. And basically, patient compliance is needed in such cases. And calcium hydroxide long-term contact to the dentinal wall can also cause brittleness of the root canal. And if the patient experiences further trauma, there are chances of tooth breakage and tooth loss. So a short-term procedure is opted nowadays, that is MTA apical plug technique, in which MTA is mixed and it is placed in the apical third, and patient is recalled next day for obturation. So these are some of my cases which I have done. This is apexification with calcium hydroxide, and we can see a very good healing of the patient is achieved after 12 months. These are the preoperative and postoperative radiographs. This is again my second case, which was treated with apexification with calcium hydroxide. Either these cases, you can compare the preoperative and postoperative radiograph. A very good periapical healing of the area is achieved, as well as calcific barrier was introduced in the patient. These are again some of the cases which were treated. Now, these are the cases in which I have done a single step apexification technique by MTA. MTA is basically mineral trioxide aggregate, and endodontists have to thank a lot to MTA, because before its appearance, many of the complicated situations which had much fewer possibilities to work and treat. Now we can treat a multiple of cases with the use of MTA. And you can see a very good result is obtained again. This is again a 6th case which was done with MTA. These are some of the cases. Basically, MTA is composed of 3 major oxides, that is calcium oxide, aluminum oxide, silicon oxide, and it was recommended for endodontic application in 1998. So coming to what are the advantages and disadvantages of MTA use? MTA reduce, there is a basic reduction in treatment time. As we have said and as we have discussed, when we do apexification with calcium hydroxide, patient has to report to the dental clinic multiple times. There are chances of washout of the calcium hydroxide dressing, and many times we can encounter that the brittleness of the dentinal wall, which remains thin. But in cases of MTA, we have reduced the treatment time. We can complete the treatment in a single visit. But the main drawback of MTA includes discoloration potential and its difficult handling characteristic, long-term setting, long setting time, because you cannot obturate the patient immediately. The setting time of MTA is 2 hours 45 minutes, and you have to recall the patient next day for obturation. Of course, material is costly as compared to calcium hydroxide, and in very blunderbuss canal, the placement of MTA is difficult. So now we have moved to regenerative endodontic procedures. So what is regenerative endodontic procedure? Regenerative endodontic procedure are defined as biologically based procedure, which are designed to predictably replace structures, including dentine, root structure, and cells of pulp dentine complex. And unlike apexification, apical barrier technique, which is achieved by MTA, it allows for complete root maturation in the sense that the root is increasing lengthwise as well as in diameter-wise. So what are the goals of regenerative endodontic procedure as described by American Association of Endodontics? The primary goal of regenerative endodontic procedure is elimination of any symptoms and signs and symptoms of bone healing. Secondary goal is that the root should mature lengthwise and there is increase in root wall thickness. And tertiary goal is positive response to vitality testing. Now, these are some of the components of regenerative endodontic procedure. All these work synergistically to achieve our goal. These are stem cells, delivery system, growth factors, and scaffolds. Some of the stem cells which are important in regenerative endodontic procedure are stem cells of apical papilla, which remains viable even in very severe necrotic cases, dental pulp stem cells, and periodontal ligament stem cells, and bone marrow derived mesenchymal stem cells. And growth factors, it also plays a critical role in the recruitment of dental stem cells, migration, proliferation, and differentiation. And they are basically cytokines which are secreted by the odontoblast during primary dentinogenesis, and it becomes entrapped and fossilized into dentine after mineralization. And these fossilized and entrapped growth factors can be reactivated and released through the dentine demineralization by the action of endodontic irrigants and organic acids, that is EDTA and sodium hypochlorite. So the growth factors which play pivotal role in regenerative endodontic procedures are platelet-derived growth factors, which enhances collagen synthesis, and also it helps in neurogenesis, transforming growth factor beta family, vascular endothelial growth factor, insulin-like growth factor, and fibroblast-like growth factor. Now coming to scaffolds, which is the third major component in regenerative endodontic procedures. They provide a physiochemical and biological three-dimensional microenvironment for growth and differentiation and promoting cell adhesion and migration. And tissues are organized as three-dimensional structures, and appropriate scaffolding is necessary to provide a spatially correct position for cell location and for the differentiation, proliferation, and metabolism of cells. So basically, scaffolds can be natural or artificial scaffolds. Natural scaffolds such as blood clot, platelet-rich plasma, platelet-rich fibrin. These are the natural scaffolds, and artificial scaffolds which we use in regenerative endodontic procedures are polymers like polylactic acid, polyglycolic acid, and various bioceramics. So here the question arises, are every case suitable for regenerative procedures? So we have to select our case very carefully. Tooth with necrotic pulp and immature apex are the cases for regenerative, they are the prime candidate for regenerative cases. Pulp space should not be needed further for post and core for final restoration. Patient should be compliant. Patient should not be allergic to any of the medications like minocycline, metronidazole, and ciprofloxacin. And based on the available evidence, it is advisable to perform regenerative endodontic procedures in children younger than 8 years or older than 16 years of age. It is not advisable. Also, regenerative endodontic treatment should not be performed on deciduous teeth because of the possibility of impairing the eruption of permanent teeth. Now, what we do in phase 1 is we assess the non-vital pulp under SS opening is done of the non-vital pulp under local anesthesia and aseptic techniques. Minimal mechanical disturbance of the pulp tissue is done. That is, we should do minimal instrumentation. Disinfection is carried out with the help of needle with closed end, side vents like endovac, and disinfection is done with the help of triple antibiotic paste, which is kept in the canal for 2 to 4 weeks. And we provide a coronal seal in the phase 1 visit. When the patient is recalled after 2 to 4 weeks for phase 2, we have to confirm for the success of phase 1. If it is unsuccessful, then again phase 1 is repeated. And if it is successful, then we have to assess the pulp again under local anesthesia without any vasoconstrictor. Then we have to irrigate the canal with 17% EDTA solution, which is a chelating agent. And we have to induce bleeding. And we have to place a collagen matrix above the blood clot and seal with MTA followed by composite resin. So the main aim of phase 1 is to create a disinfected environment within the root canal. And the phase 2 aim is to recruit stem cells of apical papilla in the root canal. So these are some of the cases which were done successfully in my department. And we can see a 10-year-old, this was the X-ray of a 10-year-old patient who sustained a traumatic injury. And after doing regenerative procedure and post follow-up 18 months, you can see a very good result. This is one of the second case in which PRF was used as a scaffold. And we can see a very good result after 12 months. One of the study has been done in our department, in which we have assessed the possibility of regaining of pulp sensibility in immature permanent teeth when we did regenerative endodontic procedure using 2 different intracanal medicament, and to our surprise, pulp regaining of sensibility was noted in almost 30% of the patients. So this was the case and the thesis which was done under me, and you can see a very good result. So what is the level of evidence for regenerative endodontic procedure? Because a systematic review of the literature indicates that regenerative endodontic technique lack adequate high level of evidence. And most of the regenerative technique are case reports and case series with very few retrospective and prospective cohort studies with short period of follow-up. So a need for long-term and well-conducted randomized clinical trial with large sample size and following standardized criteria for outcome for evaluation of the cases are required for high level of evidence. Now, these are some of the cases which were managed by periapical surgery to manage non-vital immature teeth. So to conclude, it is basically initially we as clinicians are very hesitant in adopting regenerative endodontic procedures for treating non-vital immature teeth, but it's very exciting to see something new happening and to give happiness to the patient. So it's my advice that we should in our day-to-day practice, we should apply these regenerative techniques to achieve a very good result. So at the end of the day, when your patient is happy, you are happy. Thank you. These are my references.
Nice presentation, Dr. Uma. Dr. Uma, you have presented 4-5 cases, and the radiographs are showing a nice, recovery and good healing of the apical region and all.
Thank you, sir.
But let me know that why the endodontists are hesitant. Are we not getting the results in all the cases which we are attempting?
Yes, sir. Basically, actually, we are hesitant because when such patients come, maybe it's lack of time because there is a patient load which we face in the clinic. These cases we have achieved, and I must say that when we do regenerative endodontic in a proper manner, in following all the phases and all the treatment modalities which we follow, and if we do in a aseptic way, results are very good and we achieve it. So my advice is that we should not be hesitant, and whether such cases, when we see such cases in a young teeth, we should attempt it because the results are very good, and as you can see that the maturation, the actual root maturation is seen only in this treatment.
And you are saying that the 30% of cases we are getting the sensitivity back.
Yes.
Good, nice. So just as a curiosity, any cases which you attempted and you are not getting the result which you are expecting?
Yes, sir. Okay. Many of the cases when there is lack of coronal seal, or when we have not done it properly, and when the patient has not came for the follow-up, or whether there was majority of 20, you can assume that 10 to 15% of the cases we have not got the result, but majority of the cases we have got a very good result.
Okay, great. Good presentation, Dr. Uma.
Thank you, sir.
Yeah. Now we are moving to the next presenter, Dr. Parveen Lone. Dr. Rashri, we have running short of time. You are not at your turn. So could you, we are not able to allow you to talk because we are running short of time. All speakers are waiting in the waiting room. So we are moving to the next presenter, Dr. Parveen Lone. Dr. Lone, are you there?
Yes, sir. Yes, sir, I am here.
Could you please share your slide? Yeah.
Yes, sir. Sir, it is host disabled participant screen sharing.
By Dr. Parveen, just hold on. You have came with the 2-3 names, no, actually.
Sir, actually, my laptop is not working. Okay, okay.
I'm just making you co-host. You just try to from this one.
Okay, sir.
You are the co-host on the both of your device. You can attempt any of your device. Meanwhile, Dr. Rashri, apology for we are running short of time. We'll take you later on. We'll talk about this.
Time when you are calling me, but when I was sharing my screen, it's showing only the host can share the screen. And already, sir, the next presenter started this presentation.
Please talk to me on my phone. Actually, let just finish them and please connect me on my phone. Dr. Parveen, are you sharing your slide?
Yes, sir. Sir, is my
we are hearing echo as well, and it's not your presentation is not visible.
Sir, is my screen visible?
Not visible yet. I'm waiting for that.
Sir, is my screen visible?
No, not at all.
Hello,
I'm waiting for that. Could you please try to attempt with the other device? I think you have.
Sir, is my screen visible?
No, it's not visible.
Sir, is my screen visible,
coming.
sir?
Yeah, it's visible. Yes. Visible. Yeah, you can start your presentation, Dr. Parveen. We are running short of time. Yeah, time is precious. Yeah.
Sir, is my screen visible?
Yeah, your skin is visible. Topical 5-fluorouracil application of management of visible.
Hello?
Yes, of course. Yeah, your skin is visible, Dr. Parveen.
Thank you, sir.
Mhm.
Good afternoon, sir. My topic of presentation is topical application of 5-fluorouracil in management of odontogenic keratocyst. Odontogenic keratocyst is an aggressive cystic lesion of the jaw which arises from dental lamina with high growth and recurrence rate. It was first described by Philipson in 1956 and it constitutes between 1.8 and 21.5% of odontogenic cysts, and the age ranges from 7 to 83 years with the peak incidence of between 10 and 30 years. Signs and symptoms: patients are usually asymptomatic and are detected accidentally during the routine radiographic investigations. But if a patient comes, reports he has swelling in mandible, third molar region, which is commonly seen, swelling, pain, facial asymmetry, infection, paresthesia are the presenting features. Radiographically, it presents as unilateral or unilocular or multilocular cyst lesion. The management, because of the high recurrence rate, the management is quite controversial. Literature has reported different surgical treatment methods, which include enucleation, marsupialization, curettage, peripheral ostectomy, segmental resection, and adjunctive chemical chemical solution application. The treatment modality depends on size of lesion, location, proximity of the lesion to the vital structures like inferior alveolar nerve, maxillary sinus, and nasal cavity. The aims and objective of the treatment is to develop a method that will minimize morbidity, maintain vitality of the surrounding structure, and reduce the chances of the recurrence. The aim of this study was to evaluate the efficacy of the topical application of 5-fluorouracil after peripheral ostectomy and compare it with the other treatment modalities in the management of OKC. Now, 5-fluorouracil, it is a basically anti-cancer drug, which is mixed with the non-steroidal anti-inflammatory drug. It is anti-neoplastic and is used topically to treat actinic keratosis. It was first proposed by Nichols and on the present understanding of the molecular genetics of the OKC. Now, what we did, because the treatment is controversial because of the recurrence, we were actually first treating the patients with the Cornoy solution and with the resection for the aggressive lesions. Now, in literature, there was one article regarding 5-fluorouracil, and it is basically anti-cancer drug which was given for the skin, this superficial basal cell carcinoma, topical application. So we also tried this medication in the OKC. We were already treating the patients with the Cornoy solution and the resection. Now, taking those patients into study in this group, the third group, we treated the third group with the peripheral ostectomy, and instead of Cornoy solution, we applied the topical this 5-fluorouracil, which was dipped in the gauze. Then this is the one case which I am going to present. This is the patient, the radiograph of a patient with the multilocular lesion, and then this is the peripheral ostectomy which we did. And after the peripheral ostectomy, this is the wound after post-surgical wound. Then 5-fluorouracil 5-fluorouracil, which was this gauze was dipped in 5-fluorouracil and it was packed into the patient's cavity. This is the post-operative 6 months radiograph of a patient, which is showing the lesion which has healed radiographically. Now, while comparing the different methods, different treatment methods, we can see we have done osteotomy in this, we have done mandibulectomy, partial mandibulectomy in this patient, and these patients later on they come with functional impairment, not only functional, along with the aesthetic impairment. We did partial mandibulectomy in these cases, and then a reconstruction plate was given. Half of the mandible was removed. You can see the lesion here with the disease. Now, when we compare all the three treatment modalities, in Cornoy solution, number one, recurrence was there. Then nerve injuries were noted in many patients, which of course were in only 2 patients. Nerve was not, nerve did not regenerate. But in rest of the cases, it took 6 to 9 months to regenerate the nerve. Whereas in resection cases, there was functional as well as aesthetic impairment, disability, and patient were disabled. Whereas with the 5-fluorouracil cases, in cases with the 5-fluorouracil, there was no nerve injury. Nerve injury was not reported. There was no functional and aesthetic disability also, and healing was very good. So the majority of the studies in literature have reported this neurosensory deficit with Cornoy solution, whereas in 3 minutes protocol also in Cornoy solution, there were some necrosis, bone necrosis was reported, the nerve injury was reported, whereas in the most aggressive cases where we did resection, functional and patients were unable to chew on that side, and there was aesthetic disability also. In case of this the 5-fluorouracil, it was found more effective. It was found more effective and more advantageous than Cornoy solution. There was no recurrence rate even after 3 years in these patients, and patients were functionally and aesthetically, they were not compromised. So what we conclude with this study is that there is no universal protocol for the management of odontogenic keratocyst, and the advantage of conservative management is low morbidity than resection, because in young patients resection is not indicated because of their functional and aesthetic problems. So 5-fluorouracil has been considered as more useful in treatment of OKC than Cornoy solution due to its short operating time, availability in the market, and at low cost, technically simple, reduced morbidity with no or low recurrence rate, thereby decreasing the need of second surgery. However, there are only few cases which has been reported in the literature, and also we have also done 11-12 cases with good results. However, larger clinical trials are required to generate the evidence on use of 5-FU as a novel technique for management of the OKC. Thank you.
Nice presentation, Dr. Parveen Lone, coming from the state Jammu and Kashmir.
Actually, sir, I have here some internet problem, so okay. I was not able to show.
From which college you are from, Jammu?
I am from GDC Jammu, Indira Gandhi Government Dental College, Jammu.
Achha, Jammu. So, this is the main dental college, government dental college in Jammu.
This is the only dental college in Jammu. Okay. And there is one government dental college in Kashmir, and there are 2, one in Jammu and one in Kashmir. Both are government colleges.
And the Sher-e-Kashmir Institute of Medical Sciences, they don't have dental surgery department or the college associated.
They have, sir, they have medical college where there is Department of Dentistry.
Okay.
In Srinagar. In Jammu, there is a private college also, which is in periphery of the Jammu.
Oh, great. A nice presentation, Dr. Parveen. Anybody want to ask question? Any oral physician or oral pathologist in the meeting room can unmute and ask question to Dr. Parveen. Otherwise, we'll pass it to Dr. Suchita, and she will continue with the other presentation. Okay. Thanks, Dr. Parveen.
Thank you, sir.
We are moving to the next presentation. Dr. Suchita will take from here, and you will be getting the certificates and all next week for all the presenters who presented in a faculty category. Over to you, Dr. Suchita.
Yes, sir.
Please continue.
Yes, sir. So in continuation with the today's conference, our next speaker is Dr. Aarti S. Kapila, a dental health professional by education and the senior entrepreneur. Dr. Aarti Kapila ma'am is a co-founder and a board member for OsteoSkill India Private Limited, a health tech startup which is creating 3D printed precision customized medical and dental implants, and Cocoon to Single Silk Global Partners LLP, a boutique consulting house. Dr. Aarti Sharma Kapila is a former government dental officer and founding member of India's largest private dental chain, labs, mobile clinics, and recipient of Dr. Hari Prakash Merit Award for Community Dentistry in the Asia Pacific region by the ICD, and Outstanding Leadership in Healthcare Award Health 2.0. Notable among Dr. Kapila's achievements is creating the trademark sterilization and pain management process and the first kind of patent pending real-time clinical quality review process for all clinical procedures during her tenure at Kuklov Dental. So she'll be giving the lecture on entrepreneur in dentistry. So over to you, madam, for your lecture. Ma'am, are you there?
Dr. Aarti, she is there.
Can I
Yes.
share my screen now?
Yes, ma'am, you can share.
Is it visible?
Yes, ma'am, your screen is visible.
All right. Thank you everyone for inviting me to speak on this conference. It's a great honor to be addressing the women entrepreneurs or women dentists and healthcare professionals in this in our country. My presentation today is on entrepreneurship in dentistry. Entrepreneurship, what is entrepreneurship? Would anybody like to answer that question? What in their mind is entrepreneurship? All right. We all know that being a dentist in itself is a successful dentist is a very achievable, is not a very easy feat to achieve, right? We have to work really hard. We have to be innovative. We have to be able to bring in something unique, which your next door dental surgeon is not already providing to the people for you to be able to have an edge over the others, right? There was a study that was conducted by one of our former presidents of the Dental Council of India, which showed that the number of graduates that were coming out of a dental school vis-a-vis the number of job opportunities that they had outside was severely lacking. The government was able to absorb only 2% of the graduates that were coming out, while the private sector, which included your corporate dental chains, your dental material companies, dental equipment companies, the insurance sector, all of these were accounting for about 5 to 7% of graduates that they were absorbing. The rest were left on their own to figure out what could be done with their lives. Either they were looking to set up their own practices, or some of them were teaching in various various private teaching colleges that are in our country, and not really getting the kind of remunerations that they would like to see for the amount of effort they've put in to become dental surgeons. Not the monies, but at least the amount of effort that has gone on, the amount of study, the amount of time that you spent to become a good dental surgeon. The monies being offered vis-a-vis that was not commensurate to each other. So the best option that they all seem to have was to set up their own practices. Before considering to what an entrepreneurship means is designing and managing a profitable business, which involves a lot of innovation, creativity, and risk-taking. And entrepreneurs need to be self-motivated, resilient, and adaptable with a strong business acumen and leadership skills. We may not be born with all of this, but these things are something that can be taught, that can be learned over a period of time. However, before we consider becoming entrepreneurs, we have to be able to understand the risks and rewards of becoming one, right? By definition of what an entrepreneurship is, we know that we could be, every dentist who sets up a dental clinic becomes an entrepreneur. But do they really understand what it takes to be an entrepreneur? To become an entrepreneur is someone who sets up a business or businesses taking a financial risk in the hope of profit. Going by this definition, entrepreneurship, every dentist who sets up a clinic is an entrepreneur. But the problem lies in the fact that many dentists are unaware of the basic qualities, such as leadership, initiative, management abilities, business team building, financial understanding of our P&Ls and our books and the monies that we are earning. These attribute to acquiring manpower, developing a business, or being able to build a workable business plan and other resources. In reality, entrepreneurship is an art which requires finding gaps and filling it with solutions. For example, if a clinic doesn't have sufficient patient flow, instead of blaming the system, a dentist has to adopt an entrepreneurial mindset to seek solutions. Obviously, the risks associated with investment of capital and time, there are also rewards as well as more control over the business comes in itself. So what are the qualities that are required? Leadership, business team building, management abilities, and initiatives. Why should a dentist become an entrepreneur? In our present status in India, we do see that dentistry, even healthcare for that matter, though healthcare is better organized than dental industry is. So the opportunity to be your own boss is much higher. What are the benefits of becoming an entrepreneur? You have greater autonomy and control over yourself. You have the potential to increase your income. You have the opportunity to be innovative, to introduce newer treatment modalities, to introduce equipment that you have trained on, which may be very new in the market. It gives you a personal fulfillment because it is your baby that you are nurturing, not somebody else's. Plus, it's your own job security. You know that as long as you work in that clinic, money is going to come in. And nobody can throw you out of your clinic. So the job security is always there. To become a successful entrepreneur, what are the things that are required? You need to have great communication skills. You have to put in persistent effort. Without effort, nothing comes. Risk-taking ability has to be there. You have to constantly update your knowledge and make sure You are aware of the new trends in the market, nationally as well as internationally. You have to be mastering your treatment skills. Because that is what is bringing in the money. You should be able to, manage your staff, which is your dental assistants, your lab technicians, your front office staff, your janitorial staff, your CA who is taking care of your books. All of those people, you should be able to manage it and be able to understand the needs and wants of each person. Patient satisfaction or customer service, as it is called in the corporate world, is a huge factor in the success of your business. If your patient is happy, he will bring back 10 more people. If a patient is unhappy, he will take 50 away from you. Remember that always. So patient satisfaction is very high in terms of for any entrepreneur to know. Financial viability of your business. You may be putting in a lot of money, but are you getting the returns on that money or not? Are you, let's say you've bought in a laser, are you able to sell your laser treatments? Are you able to convince your patients to get that laser treatment done by you? If you've introduced a CBCT or you've introduced an OPG machine in your clinics, are you able to get are you able to recover the cost of the machine that is there? And while doing all of this, you have to remember that the ethics of our industry should never be violated. Keeping all of that in view is when you become a successful entrepreneur. 5 ways of that you can think of while transitioning from being just a dentist to a dental entrepreneur. The first one is opting for a co-branded dentistry. Lots of companies tend to, either give you a franchisee of their business. See, in the retail world, all the McDonald's in the world, all the Swiggy, all the KFCs in the world, they're all retail businesses which are franchisee owned. Means that there is one main company in UK or USA which gives you the right to use its name and its processes, right? That is one way to do it. What happens with that is, because it's an established brand, it is an established name, you're able to benefit from that. In dentistry, Clove is one of the largest dental chains. Then you have Sabka Dentist, you have Partha Dental, you have a whole bunch of these new chains that are coming up, right? Some of them do have this option of you wanting, this option of buying being able to use their brand name in order to leverage your own dental wing, or you could become a part of that chain as well, right? So that is what opting for a co-branded dentistry means. It's probably the easiest and the simplest way to become a dental entrepreneur. Over the decade, there are significant changes in the business model of dentistry, from privately owned solo clinics to corporate dental chains. Dentists opting for these two categories of dental clinics. However, both the categories have a fair share of risks and limitations. In solo practices, dentists have to bear the administrative burden as well as the financial burden. On the other hand, a corporate dental chain dentist works as an employee without any shares in the profit. Opting for co-branded dentistry model, where you can own your own dental practice, yet receive administrative infrastructure and support for the non-clinical aspects of your practice, can also be done by the franchisor. Second is understanding the challenges and solutions and coming up with solutions. When you run your own practices, you have to constantly assess what are the challenges that you are facing. What others are facing may not be the same challenge that you are facing. You have to understand what are the challenges you're facing. Is it that the footfall is very less because the look and feel of a clinic, or is it because you don't offer a certain type of treatment plan, that treatment service which maybe the next door dentist offers, or you are exactly the same, you have the same services as the next one, but the next dentist is maybe a little older in age than you are. You have to figure out what your challenges are and come up with solutions for that. For example, introducing a newer type of equipment in the system can help you boost your your monthly income. It can help boost the number of patients who come to you. Having an offer running can sometimes help increase footfall. Doing a camp within your own premises can also help you increase footfall. Lots of things can be done. In this day and age, digital media is a very big leverage. If done correctly, can help in increasing the awareness about your center and increasing footfall as well. Third is the continuing dental education. You have to constantly, and I'm sure all the academic friends that I have here would agree with me, constantly update your knowledge. Just because you're a private practitioner does not mean that you can sit on your laurels or be okay with just the amount of people who are coming to you. If you want to grow, you need to increase your knowledge, your education. You need to know what are the latest trends in the market, what are the latest materials, equipment, treatment modalities that are available, and get yourself trained on them, or have somebody who comes to your clinic who's trained on those modalities for you to grow as a dentist or as a dental entrepreneur. That's what will make you a dental entrepreneur. Otherwise, you'll just stay a dentist. Introducing innovations, things like Botox or use of lasers, use of we've seen a lot of endodontists just now. We've heard a lot of endodontists just now. Use of microscopes. All of that introducing into your system can help boost and leveraging them correctly will help boost your business, plus also bring more footfall in your clinics. Last but not least is bridging the gap, trying to understand the feasibility and implementation of the proven solutions. See, sometimes what is in the box works well. It just needs to be tweaked a little. Thinking outside the box is great. Definitely, that will give you growth. But what is inside the box also holds a lot of value, because it's been handed down from ages. People who've practiced that way have seen the merits of doing that practice and are able to hand that knowledge to you. See where the little gaps are occurring and how do you go back and bridge those gaps to be able to become a successful dental entrepreneur. Beyond these, you also have to understand that financial knowledge and marketing are extremely important tools for being a dental entrepreneur. If you do not understand your balance sheets, what is a balance sheet? A balance sheet is the amount that you're making versus the amount that you spent and what is your profit out of it. If you don't understand that, anybody can take you for a ride. So when you decide to open your own practices or run practices, be sure to be able to understand that. Don't let others run that part of it. If you don't have knowledge or if you don't have a grasp of it, there's small courses available online, offline, everywhere, 2 days, 3 days, 4 days, that give you basic knowledge of being able to understand what your CA is trying to tell you. And this also makes sure that he's not taking you for a ride, right? So financial knowledge is extremely important for you to know while setting up your practices and growing your practices. Same goes for marketing. I'll be sorry to use this colloquial language, but every Tom, Dick, and Harry today offers you marketing. But healthcare marketing is very unique. Be sure that you assess the person enough before you hand your marketing budget to somebody. There are enough and more people out there who will tell you, gee, we do digital marketing, we do WhatsApp marketing, we do this marketing, that marketing. All of that can go down the drain if not done by the right person. Because what works for other industries does not work for our healthcare industry. So you have to be very careful while choosing the right people to partner with as well. So that's what I believe are some of the things that you can do in order to transition from a dentist to an entrepreneur. These guidelines are applicable to all, not just the dental industry. Even the healthcare industry should be able to follow the same guidelines. Healthcare industry is far more organized, considering we have very large hospitals that are there. But the smaller practitioners who also want to grow to that level can look at these small things that I just suggested for you to be successful entrepreneurs. Rest, I am always available to help. If anybody does need that help, any guidance, any help, I'm always available to do that for you guys. Thank you.
Hello. Thank you, ma'am, for enlightening us about how we can be a dental entrepreneur. Thank you, ma'am, for this informative lecture.
Anybody has any questions? I'll be happy to answer. No? All right. Thank you so much for inviting me on this prestigious platform. I'm truly honored to be here.
Ma'am, anybody, if they have any questions, I'll forward it to you and I'll get your answer and then I'll forward to the.
Absolutely. Dr. Anwar, I'm happy to, if you want to share my number with them, I'm happy to answer their calls as well.
Okay, sure. I'll share your number to the group through email and all.
Thank you so much.
Okay. So I'll introduce the next coordinator for the today's conference, Dr. Aparna Dave, ma'am. She's the HOD and the department professor and the head of the department oral pathology of SGT University, Haryana, with almost 20 years of the experience. She has guided numerous projects and has numerous publications to her credit. So over to you, ma'am, for the next sessions of the conference. I hand over the stage to Dr. Aparna, ma'am.
Thank you, Suchita, Dr. Suchita. Good afternoon, all. It's my pleasure that I have a chance again to introduce our next speaker, Dr. Ramya. Dr. Ramya holds a doctorate degree in organotyping, a postgraduate degree in oral pathology and microbiology, and has 15 years of postgraduate teaching experience. She also has a postgraduate diploma in tobacco control from Annamalai University. She was selected for Inspire Scholarship Program for pursuing PhD program by Department of Science and Technology, New Delhi. She is an expert in field of salivonomics, She was the co-investigator in DST TIDE project, which involved development of a novel neuroelectrostimulator for management of salivary secretion in xerostomia in elderly patients, which has been filed for Indian and international patent. She has worked on a project in quantification of human papillomavirus 16 and 18 in oral pre-malignant lesions and oral cancer. She is passionate about phytotherapeutics and is currently working on establishment of in vitro disease models of oral potentially malignant disorders. She is currently working on a joint project with the National Center for Nanoscience and Nanotechnology, University of Madras, on nanoscale flexible hemostat funded by BIRAC, New Delhi. She has numerous publications and has authored many textbooks. She has won international and 13 national patents for her medical device innovations. She is currently employed in Savita Dental College as professor and head of oral biology department. Welcome, ma'am, and over to you for your presentation.
Thank you so much for that very kind words, Dr. Aparna. Thank you, Dr. Nurul, for considering me again for a second opportunity from 2022 to 2023. Shall I share my screen?
Yes, ma'am, please.
Yeah, hope it's visible.
Yes, it's visible.
Yeah, thank you. Fine. So before beginning with this presentation today, Dr. Nurul had asked me to talk about areas which were very interesting to an oral pathologist and a dentist as well. So on that lines, I had actually reshaped this into manuring the untrodden paths in dentistry. I'd really like always to talk about how dentistry is such an interesting profession by itself and how it has actually lost its glory, and it's absolutely in our hands to take it up and make it shine again. And this situation is, I feel, is only there in India. And I feel definitely it is the responsibility and commitment to all of us dentists to nurture the young minds over there, the youngsters, to support them, to motivate them, to identify the beauties behind this wonderful profession by itself. So that is why purposefully I chose this as my topic today. So the manuring the untrodden paths means that when you get a chance to slightly change on to your career paths, something which is related to your profession, how should you handle it? So before going into the details of how to handle such career transitions, I'm here to tell you about what we routinely do and what is done as an alternate path of career. So routinely, this is what an Indian mindset pursuing dentistry does. And this is a list. So the dental practice is what we usually do. And that is what everybody will want to do, of course. But now the trend is slowly changing and everybody wants to try to make it faster and try to make it big, want to make it faster and want to make it big at the earliest. So that is the trend with the 2K kids now. So dental practice option is slightly not being considered nowadays. And then the routine MDS, which were actually very favored during our generation of dentists, is again not there. And taking up government post, you know that the number of government posts has really come down, and looking for a government post may not be viable at this particular point. And this is something which everybody likes to do, masters in public health. So this is considered as an easy way to enter a foreign country, which they think is more economically more interesting, and other overseas opportunities and licensing examinations abroad. So recently I had one of my students who was about to complete almost 7 to 8 years of after post-graduation in oral pathology, choosing an option of being a dental therapist in United Kingdom. The reason which was told is mainly, of course, the financial abundance which those countries give, and the working hours. That is something which is, again, which India needs to definitely reconsider. So the finance, the working hours, and of course, the other reason which he said was, I really want to try what is there on the other side of the world. Okay, so that is how he is like now working as a dental therapist in the United Kingdom with a heavy pay package. So these are all the routine considerations which are given. So that is just to give you an idea of what we do routinely. And these are the other options which are actually considered when you are wanting to take up some job which is very different, when you don't want to invest on a clinic, or when you don't want to wait to take up your NEET exams and so on. So these are options which are actually very, very interesting and would really give you an edge over others when you choose these options. So just to have a quick glimpse on what are these other options are what I'm going to talk about today. So the clinical and experimental dental research is something very, very interesting, which is happening on a great scale now in India. Many, many pharma companies from abroad, all multi-billion pharma companies are all investing in India, mainly for the sake convenience of employability, the infrastructure, and of course, the revenue which it can actually generate, and the investment options are all very easy for them than what is available abroad, even in their home country. So because of these different kind of corporate governance and corporate investments happening in our country, there are huge scope of clinical and experimental dental research which are happening. So to really find out such opportunities, all that you need to do is first to open a LinkedIn account and put up all your skills there. And the companies are just waiting to recruit really skilled and committed workforce. And this would really give you a very good pay package, and especially those who have that creativity in them. This particular option would really give a very, very interesting opportunity. And the next is working on clinical trials as investigators. You can join as an undergraduate or as a postgraduate. So what are clinical trials? And clinical trials are the ones which, when a drug is cleared its FDA clearance, and in India, we have the CDSCO clearance. When it is all done and set, it is taken to the phase 2 clinical trial. So why am I saying phase 2? Phase 1, we already know that phase 1 is already completed, and only then it can actually go for all the licensing and approvals. Once it is all done, the company starts hiring investigators to conduct the clinical trials on a large scale. And conducting clinical trials definitely needs a healthcare person on all categories, right from a doctor, a dentist, and then the nursing person and other supporting paramedical staffs as well. So dentists are considered equivalent to a medical graduate as far as clinical trials are concerned, of course, with due training. And this would actually give you a lot of experience and a very good pay package as well. And it is really very interesting. And if you are really very, very focused and dedicated to the work and involved, definitely the company will keep on hiring you in conducting clinical trials, and you will have a very good workforce under you, and you can be the boss doing wonderful clinical trials. And it just does not stop with that you can actually derive very good publications out of that, and your name would be really garnering a lot of interest worldwide. So that is the administration way. And the hospital administration, of course, this is there for the past 2 decades. To be an hospital administrator, of course, you will have another team which are working. You will have doctors, the medical team, listening to what you are actually planning. You know how many corporate companies are there, corporate hospitals are there, doing excellently well. And after the COVID pandemic, we know how much hospitals, the importance of hospitals have just grown leaps and bounds. Earlier, there was a little snag, and after COVID, things really changed, and the hospital industry just went very bigger. And I don't know whether all of you know, we are from Chennai, and recently there was an outbreak of H1N3 virus strains and so on. So there are so many mutant varieties coming up, and the panic that it causes and so on. So with all that in mind, what happens is hospital administration, if you are an able administrator and if you can actually give in the best of what you can, which would really benefit the company, would really take you places, and this will give you a lot of, again, a lot of popularity, I would say, because the moment you actually prove that you are an able administrator, you would be wanted in many other hospitals as well, because hospital administration is such a crucial area where it is very, very important, and usually it is not taken up, or it is not very much preferred by the medical graduates. So it is up to us, the dental graduates, to go and grab that very, very plum job. It is very challenging, but it offers a lot of satisfaction, and it will again give you a very nice pay package. This is something which I'm very confident in, having published 4 books under an international publisher. Publishing industry is something which is really very, very much happening. Of course, you know that it's all digitalized now. Whether it is going to be print versions or online versions or Kindle versions, you name it, publishing industry is there to last till the time mankind is going to be. And what are we doing to do in publishing industry? The beauty of the dentist being in publishing industry, mainly in medical publishing, and do understand when I say medical publishing, it applies to both the medical and the dental fields as well. When it applies to both medical and dental fields, what happens is, as a dentist, you would be kept as a subject medical expert, or a medical subject expert, or the subject expert. The subject expert are in great demand by the publishing industry. Every now and then, because of my publishing background, I keep getting calls from the publishers asking me to review a book, or to do a proofreading, or to check whether it would really sell and so on. So that is as a, a privilege which an author keeps getting. But there are also very good opportunities for newcomers from dental background who can actually make it really big in publishing industry. Again, it requires a lot of dedicated work, but this also is very, very promising industry, which would actually give you a very solid pay package. And the other thing is about, very frequently you will get junior resident recruitment from the big names like Maulana Azad and AIMS. And you should just see the salary package to believe it. It's such a huge package, and that working in such prestigious universities would make your CV very different, and the experience which you can gather just being in that institute, just that presence in that very powerful environment would make a very big change in yourself. So to tread into all these paths, you have to be in constant touch with platforms like Biotechnica and LinkedIn. And this is again another very interesting area, that is medical transcription. Though it might sound a bit dull, medical transcription has its own advantages, especially if you are a keen listener. If you have that very good auditory senses working in perfect tone than other senses, you are the person for medical transcription, because this again would give you a lot of promising opportunities, especially if you are able to deliver, if you are a listener, very good listener, and if you're able to give the files perfectly, you will be immediately given promotions, and you would very soon achieve managerial positions very fast than what a normal MDS would go into becoming a reader or a associate professor and HOD and so on. So that takes a longer time, all of us know. But medical transcription companies and all if you are a very good performer, you would become a manager within 2 years. I've seen many people achieving that category. And there are other interesting areas which many of my students, both undergraduates and postgraduates, have taken and are doing phenomenally well. And they're really making big money out of it. And I'm really proud to tell at this particular forum that many of them are managers, senior managers, and zonal managers as well. So that is the edge which we have over other professions. So please understand, where did this particular superiority come, or how do we become more smarter than others? Very simple. It's because the dental training and in a dental college, the curriculum which is there to become a dentist actually is very different, and it would actually give you or it will sharpen your focus on all streams, especially your way of thinking, that is cognitive ability, and so many other skills which are very important as a professional. So a wholesome development is possible being in a dental college. So these are the realization which we actually have to nourish and cherish being a dentist. So that particular advantage is what actually makes you shine out, or shine above the rest, or shine up the crowd, and it gives you an edge over others. So your thinking, your perception is very perfect when it comes to taking up positions like this. But is it easy to take such career transitions? Definitely not. When you are actually taking a road less traveled, there are definitely difficulties and challenges. So how do you deal with such difficulties? For suddenly, you get a very plum job with a top corporate company on taking up a clinical trial post, and a job comes with a very high pay package. What are you supposed to do? Quickly enroll for a clinical trial course. There are so many courses out there, online platforms from very prestigious universities like Harvard has edX, and there are many universities like MIT gives a lot of online courses, and then you have Coursera, Udemy, and so on. So take up courses, do them very straight away, and enhance your knowledge about the topic. So to really make it big in career transition, when you're really taking up the path which is less taken or less trodden, then there are definitely challenges than your regular methods or regular career options, where there will be many people giving you so many advices. But when you take different types of options, like ones which I just listed out, you will have to really enhance your skills. You already are a great person. So to enhance it further, you have to become more curious, and becoming more curious is that you'll have to seek more pursuits, look for very interesting people to talk with, learn new things, and that would actually expand your mind and broaden your horizons. Curiosity is very important, and it is very beneficial to your well-being, and especially it nurtures your creativity. The more you are creative, you stand out of the box and you stand out of the others. You are one in a crowd, or you stand out of the crowd. So that's very important, and that is why you have to be curious. And conviction is very important, a very important trait as an individual, as a professional. Very important. You have to be convicted. So how convicted you are, how focused you are, how much you love the job that you're going to do is something which actually will take you places, and it will raise you above others, and would really give you a very important edge over others. And that is very important. So conviction would definitely make you do things better than others, or just leave the others. You will keep performing better than what you were yesterday. So just you can outshine yourself on a day in and day out basis, and every small positive action of yours will be watched, and it will definitely reflect in your annual appraisals and so on, and that will obviously make a difference. So having seen the curiosity and the conviction part, The next thing is commitment to the job which you are taking. So that commitment obviously comes from the level of enthusiasm you show with every task you take. Just be so happy to do every task, even though you may not like that particular task. Start loving it. And moment you start loving what you do, there is nothing called work. It would just be joy and joy ever. So that is what commitment would obviously give, and start loving what you do. And feeling of responsibility towards the goal and mission and vision is very, very important. The goal can be individual, or the goals which your company or the institution which you're working for is actually having their own set of goals. You can have your own set of goals, or just do something which will heighten or which will showcase their goals, their mission and their vision, and that would really make a very big difference. So curiosity, conviction and commitments are the three important and most important formula which is very important to take up any career transitions and become very, very successful, make a very big impact in your profession, come what may, whether you're taking a regular stream of options or whether you're taking a rare stream of options. Always follow this formula. You would become extremely successful in your life. And thank you for that wonderful opportunity. I sincerely thank my mentors in my institution for given me this space to participate and give a lot of lectures like this. And I'm extremely grateful to Dr. Nurul again for considering me repeatedly. And grateful to you, sir, for giving me this wonderful opportunity in such a prestigious platform. Thank you so much, and thank you so much for patient listening.
Thank you, ma'am, for your wonderful presentation. If anybody has any queries, they can just speak up. Thank you, ma'am, for highlighting the other aspects of dentistry and new possible opportunities. And also stressing upon the fact that we need to enhance our knowledge and we need to do different courses. Thank you for being so positive with the new aspects or the new pathways which the students or people like us can follow. Thank you, ma'am.
Yeah, thank you, Dr. Aparna. Thank you.
Yeah, Dr. Aparna, I would like to add, because when we are talking about the other untrodden parts of dentistry and all, I pursued the dental surgery, and then I, somehow left, though I am associated with it. But after that, I did my MBA from BITS Pilani, and I had the opportunity to work in many pharmaceutical companies. I was leading the trainer of, medical representatives. Then I worked in a hospital as a hospital administrator, and I was in a marketing team of tertiary care hospital in Delhi. So yeah, there are opportunities are there. The people who are who have passion and who want to do something apart from general clinical dentistry, there sky is the limit, and they can excel into that. There is an election happened in Northeast. I think there is a one chief minister. He is, I think, a dental surgeon, and there are many people who are from dentistry excelling in other part of life, other walk of life. So yes, since we are working 4.5 hours in our curriculum, and then 1 year in internship, and after that we are preparing for our PGs, MDs, and all. And people are pursuing after PGs, MDs, PhD and all. But still there is a, there is a way where, people want to explore further, so they can, come in this all aspects like, medical administration, in, hospital administration, clinical research and all, which Dr. Ramya have thrown, light on all those streams, which, a dentist can explore, because they are acumen. They are, because dentists have their art as well as the knowledge. They have good, sound knowledge of science, and having, good, negotiation skills. They are interacting with the patients, and also they become, very great resource for, any field they want to obtain. That this is what just I'd like to add on, Dr. Ramya.
Yeah. Thank you, Dr. Nurul. That was like a concluding remark, and it's so inspiring to hear such a the leader for this academy talking about similar experiences. It's like giving a testimony to whatever I spoke. Thank you so much. That was so kind enough. So yeah, definitely I feel instead of just looking into or cribbing about not getting the routine opportunities, it's always better to take up very challenging positions. And first of all, I would definitely always try to reinforce that dentists should be more positive. That positivity is what would actually take them places. And of course, the commitment is one word which they should definitely have in whichever path they are taking. Thank you so much.
There is an issue with the society actually, Dr. Ramya, because while I was pursuing this, it was very against my, family members, my peer, my colleagues, my, known one relatives that what you are doing. You have such a prestigious course you did, you should do practice and all. So this is, the stigma, the social, the blockage, they are not accepting a doctor who are pursuing a clinical practice apart from this. But if you go to the multi-specialty hospitals in Delhi, NCR and other cities and all, whole, the administration is being handled by dentists.
Yeah. So that is definitely, I'm sure there will be lot of societal influences and peer pressure would be very, very heavy. Yes, so that's where again, young minds needs a lot of support. I would say we as professionals and seniors, we should guide them, and they should, if they are really liking to do that job, they should ignore such pressures and move on to their things which they are very passionate about. Thank you, sir.
Dr. Rani, I believe that what you said today is a very positive aspect to what dentistry going forward would be. I'm not saying that we should not be dentists or we should not be practicing or we should be teaching, but in today's day and age, surviving as a standalone has a whole bunch of new challenges that are there. So whether it is the monies, whether it is the location or whatever it is, other opportunities like this gives validation to the work that you've done. When I did my MBA, it was about 20 years ago, 22 years ago, people thought I was an idiot because who did an MBA after doing BDS? But I think that's what has sustained me where I am today.
Wow, that is great, Dr. Aarti. Fantastic. Hearing Dr. Nurul and Dr. Aarti here, their testimonials, it's so heartening to listen to that. And I'm very happy that you had shared your testimonial, Dr. Aarti. Yeah, definitely. I'm sure that 2 decades back, if you would have taken such a very, very daring, I would say, option, you would have definitely had challenges. And I'm sure that you are here because of that change in path which you took up. Is it not, Dr. Aarti?
Absolutely. And truthfully, when I joined Clove Dental as the first employee in that company, we didn't even know what the dental clinic would look like. Today, if we are able to say that Clove has 350 dental centers pan-India, is because we were people like me or somebody else, other doctors who chose to be part of that team, took it to where it is today.
Yeah. Perfect. Wow. It's nice to know that you're part of Clove Dental. Great.
Thank you, doctor. Thank you.
Thank you. Best wishes, ma'am. Best wishes, Dr. Noor.
Same to you, ma'am. Thank you.
Thank you.
So thank you, ma'am, for your wonderful presentation. Now I just hand over the next session to Dr. Nishtha, who is doing MDS in Perio from SGT University, and she will be chairing the next session on opportunities in UK. Over to you, Nishtha.
Thank you so much, ma'am.
Yes, Dr. Nishtha, you are audible and visible. You can start your presentation.
Good evening, everyone, and good morning for people in UK. I'm Dr. Nishtha Singh, and I'm pursuing my master's in periodontology in SGT University. And we have Dr. Naila Nehal and Dr. Subi Arshad over here on this panel. And Dr. Naila Nehal is a dentist, and ma'am is currently working with NHS England. And she, ma'am, has also an experience of training young dentists preparing for UK exams. Ma'am is a specialist in periodontology, and ma'am has very published important articles on the patient's treatments. And before coming to London in 2013, ma'am had completed her BBS from AMU and she's done her master's from Bangalore. Dr. Subihi Arshad, ma'am, she's a general practitioner in UK, and ma'am has completed her BDS from AMU Aligarh. And ma'am has even worked as a lecturer in the Department of Prosthodontics. And ma'am has moved to UK since 2008. And ma'am completed her overseas registration exams in 2009. And since then, ma'am is working as a general practitioner in the UK since 2009. Glad to have you both, ma'am, here on the panel. And I'm looking forward for a very informative session.
Thank you so much for inviting us. It's a great pleasure to see not only some of our senior, but also our teachers on the panel. So it's really a very heartening experience. Thank you so much for inviting us. Hope it's useful for everybody.
Pleasure to have you, ma'am. Pleasure to have you. So, ma'am, if we go on to how the dentistry is in UK, so could you just put some light over what are the reasons that a dentist should look for UK as an option?
Okay.
Hi, Ned. I'm so sorry. I was trying to, hi everyone. I was actually trying to unmute, but I couldn't, find the right buttons. Yeah, and as Naida said, thanks everyone for inviting us to this forum. And we'll share whatever we have kind of gone through, and help you in the best possible way. Shall I take the first question, Naila, or are you?
Yes,
are
yes,
you happy?
please go ahead.
So can you just repeat the question again, please?
Pleasure to have you, ma'am. Ma'am, I was asking ma'am to put some light on what are the reasons that a dentist should consider moving to UK? Like what makes UK as a good place for dentists to have a good future or a bright future ahead?
Yeah. So I think one of the speakers previously, I think she did mention a few things about going over to UK, and she definitely mentioned the financial package. So I think one of the main incentives really is the financial aspect of it, that they're quite well paid in this country. So that's one of the main incentives. The other thing which I have kind of come to realize over the years is that you don't necessarily need to have a master's degree. So here, most of the dentists, they're working as general dental practitioners. They haven't done a master's. Whereas if you compare it to India, I think in the current scenario, it's quite important to have a master's. I think it's quite competitive. So here, you can work with a BDS degree. Of course, you can do a lot of courses to kind of update your skills, and you can perform all these procedures. So the requirement for a master's degree is not absolutely essential in the UK. So that's another advantage. The other thing, how dentistry works in this country, things are really organized as opposed to what we have back home. There is a lot of accountability, a lot of responsibility in how you're treating patients. Patient communication is very, very important. So I suppose that I would say overall the governance and the regulation in this country, and it applies to dentistry as well, it's quite high. So we really have to be careful, how we are doing different procedures and how we are providing our treatments. We have to keep up to date with our continual professional development. So we have some guidelines. You have to complete a certain number of CPD hours, every year. So these are the things that you really have to kind of keep yourself really groomed professionally to be able to deliver a good service. So that's one thing. In terms of, I would definitely like to mention this because this is a women's pink Congress, I would like to say that, and this is a really good thing about this country, that for women, if you know, if they're living alone, they can stay here on their own. It is a very safe place to live, and of course, I mean, all places, you know, they have got some pockets where, you know, the crime rate might be high, or they may be kind of rough areas. But if you look at it, you know, from an overall perspective, it's quite a safe place. And I mean, you know, we hear incidents about, you know, how insecure women feel back in India, unfortunately. And I suppose that that's one of the real advantages, that you can feel safe. You can kind of do things on your own, and you can work here in a safe environment. Some of the other things which I suppose when we come here, you know, for the first time, you are kind of away from family. So that's one thing that people really have to, you know, cope with when they first come here. In terms of cultural barriers, you know, I think it depends on everybody's personality. You know, it kind of varies from one person to the other. Some people might find it, you know, they might be able to mingle very well, but I believe there are some cultural barriers, and you gradually really have to adapt to the life in this country, in how people socialize and how people meet up, you know. So you have to kind of, you know, adapt that lifestyle as well, to some extent, to be a part of the society. So I think really, I mean, this is how I would like kind of, you know, compare to India. I mean, overall, the quality of life is good here. And there's a high demand for dentists, I would say. So that's another, you know, promising aspect of it, that if you manage to clear exams, there's always a high demand for dentists. So once you are on the register and you're qualified, then there is no dearth of jobs at all. I mean, you know, you will have lots of jobs available. So yeah, so I think I'm not really sure, if I'm really honest, about in terms of the employability in India, how the situation is in India at the moment, because I've been away from India for a while now. But currently in the UK, there's a really high demand. So that's good, you know, for anybody who's aspiring to come here. So I think I've tried to keep it short enough, and I'll let you move on to the next question. Thank you.
Thank you, ma'am. That was quite informative. I would like to go ahead, ma'am, as you said that there are subtle changes that might have occurred after since you moved to UK. So I would like you to give a brief idea to us about like what are the actual documents that a person who's already having a BDS degree here in India and wants to go ahead to UK for further office, you know, practice or kind of studies.
Yeah. Of course. I was wondering, Naila, would you like to answer that question? I mean, Naila has, you know, she has, so Dr. Naila has done her exams more recently than myself. I mean, I finished my exams way back in 2009. So yes, there have been changes. So I believe Naila would be able to give you a better idea of that, if that's okay, Naila.
Yeah, of course. From the document side, you need to have first your exams cleared in India as a dental surgeon. So you need to have your BDS degree, you need to have your internship completed, and all the transcript of your mark sheet, all the documents that we actually have from a university are quite handy. We need all of them. Other than that, we need what we call as a good standing certificate from our, like if you're from UP, you need from UP Dental Council. If you're from South, you need it from your university there. And there is one more document, what we call as a NARIC. So NARIC is basically, it equates your degree. So you send your degree, and along with your internship and mark sheets and all things, they are very helpful. They will tell you the list that they want. The idea is that they want to equate your degree to the BDS degree in UK, and then you get a NARIC certificate that it is equivalent, and that makes you, you know, eligible to sit for the exams.
Okay, ma'am. And ma'am, what are basically the visa requirements that we'll be needing pre-exam?
Before exam? Okay, yeah. Ma'am, can go ahead. No, of course, you go ahead. Yeah.
I'll just kind of tell you my part of the story. I mean, because, you know, we both have come here in kind of different scenarios. So for me, I came here, I came to this country on a spouse visa. So if I'm honest with you, you know, I didn't have a lot of problems because yes, you know, my husband he was a British national, so I could get the spouse visa, and that was kind of the pre-exam requirement. So I just came here, and then, you know, on the spouse visa, you can work as well. You've got recourse to public funds as well, so it's okay that way. But if somebody else, I mean, I suppose Naila will tell you about the dependent visa as well. And I think post-exam, currently you can come on a healthcare workers visa. So yeah, Naila, I'll let you mention your part of the story.
Yeah, okay. So basically, if you have nothing, no visa from that somebody can give you from UK, you can come on tourist visa, and which is really quick, and it doesn't cost much. And the validity is for 6 months. So you need to plan your booking on your visa, because visa is can expire in 6 month time. So once you have come, you have to give the exam, and then you can go back, and then again you can prepare for the second part of the, because the exams are in 2 parts. So again you can prepare, again you can come back, but you have to keep applying for the visa. And then once you have cleared the exam, then you have to see somebody who can, give you a work visa. There have been some new changes, but we are not sure if that is implemented. But the most popular thing is that you apply on different sites where they release the positions, and then once it is accepted, the employer is going to give you what we call as a cost certificate, which is like, I'm ready to sponsor you, and then you apply for a work visa. Now, if you want to work in a public sector, that has to be health and care visa. But if you want to go for private, that is called a skilled tier 2 visa. So there are different category of visas, but the first thing will be to clear the exams, actually. Hope this is clear.
Yeah, I think it's very clear. Yeah, that was good, Naila.
Thank you. I can't somehow open my video, so I'm sorry, I'm not trying to hide myself, but I can't open my video.
You just try and click on the video one. Is it not letting you?
No, it's just saying that the.
Good to see you, definitely, yes.
It's saying fail to start the video camera. Please select another video camera and setting. Okay, okay, all right.
I was wondering if Nurul might be able to help.
Just Dr. Naila to open the video, but I think there is some technical issue. Maybe
I think so. That's okay. Yeah.
That's okay. Yeah.
Yeah. Thank you.
Okay, ma'am, that was quite informative. Ma'am, if we move on to some other question, is the basic idea of the exam pattern, and how much the person who's aspiring to be giving that exam should be, keeping things in mind. And what's the basic, like if I have to start from the scratch and have to, go into like this healthcare into UK, and I want to apply for NHS. So what is the basic like starting criteria for that?
Right. Ma'am, do you want to go ahead, or you want me to speak about it?
I think I'll let you answer, Naila. Yeah, you've given your exams recently. I mean, yeah,
right.
we both went through the same exams. It's called the Overseas Registration Examination. And we've got 2 parts to it. It's just that I gave it quite a while back, and Naila has given it a couple of years ago. So I think, yeah, it'll be good to hear Naila on that one. I think that's.
Oh, thank you, ma'am. Definitely. So what you need to do, we have to understand the exams basically. There are 2 types of exams. We both have given ORE exam, which is basically Overseas Registration Examination, which makes you eligible to work here. And there's another kind of exam which we call is LDS exam. We have not given, but almost the pattern is same. The criteria, eligibility criteria, everything is same. It's different regulatory bodies, but both of them make you eligible to work. So the exam basically is in 2 parts. It's a part 1 and part 2. And the part 1 is theoretical, and it has 2. The part 1 will be taken in 2 days. So part 1A, part 1B. A is more of basics like anatomy, physiology, pharmacology, and the second part is more of a clinical. You need to be having in both the papers at least 50% marks to clear the exam. And it is not difficult. It's comparatively easier. So if you have, say, put a couple of hours for 3-4 months, you will be able to crack these exams. And there are some dedicated books that we need to study, especially what we don't read in back country is what we call ethics and consent and these kind of things, which we will find very new. So there are certain documents that you will have to read, But you will know all these things, because if you go to the GDC website, there is a sample of the question paper and exam, and the list of the books that you need to have. Obviously, the list is very extensive, and you don't have to buy and get everything, but there are a few books that you can select from there and be able to give the exam. Yes. And the second part is basically the practical part. So it is more of it is structured in a way that it judges your clinical ability to diagnose the patient, to give a treatment planning, to deal with the patient if there is a medical emergencies, and also your technical ability on a mannequin head, like your cavities and crown and excess opening. So there are some specific exercises. And the second part, I must say, to be very honest, is not an easy one. It's a hard one to crack, and the passing rate is really low. So you have to be really putting your effort into it to clear the exam.
And I would like to just mention, or just kind of, it really came into my mind that, so as Naila mentioned, that in the ORE part 2, there are 4 subparts to it. So, so you have the medical emergency, we have the diagnosis and treatment planning, we have the OSCE, which is the objective structured clinical exam. And then the last one is the mannequin. So, and I just wanted to mention that out of these 4 parts, you have to, as far as I'm aware, you have to clear all those parts in that attempt.
Yes.
So if you don't, if you fail, and that's the difficult part of it, because I knew people years ago when I did the exam who failed just one part. So just as an example, somebody failed, let's say, treatment planning. So it wasn't that they could then reset just that part. They would have to reset all the 4 sub parts.
Yeah, this rule is still in the ORE. Yes.
Because when you're working under, when you are doing these exams, you can get very anxious, and there's a lot of pressure on you. You're very stressed out. So this is one thing which, if I were to change the system, I would really give people the opportunity, like if they failed in let's say treatment planning, I would let them, go and do that again, rather than asking them to reset all the 4 parts. So I think that's one thing which really kind of makes it difficult, and you just have to do all the 4 parts again, and then maybe next time you fail to perform well in something else. So so you really have to kind of simultaneously
give you 100% into the exam.
all of them, to be able to pass. So, and that's one thing I really wanted to highlight. Not to say, but yeah.
There's a small change in the LDS pattern as far as I'm aware. The second part, basically they have divided split it into 2 parts. So the first part has all got the treatment planning and OSCEs and medical emergency. And the later part, once you have cleared it, then you go for the mannequin. So it's kind of made it much easier, to concentrate on one part. And because the mannequin is the toughest part to pass, actually, most of the people fail in the mannequin. So there are some, adjustments, I think, from the LDS examiners. But yeah, that is one for anybody to explore it, what they want to actually do about it, which exam they want to sit.
Very rightly said, ma'am. The day we have exams, we get extra concerned about it, and there's too much of pressure on a person who is appearing exam. And in this case, yes. And even I've heard, like my own sister, she's in the NHS, and she told me when she was clearing her exams about the practical part. She's like, it differs from India in a lot of stones. Like she said that it's the most difficult part. Theory is difficult, but yes, the practical part is at another level.
Definitely.
Yeah, that's rightly so. You really have to, I think it's really important to kind of, let go of what the result would be. I think it's important to kind of stay calm on the day.
100%. You can't be just doing medical work and expecting to pass. You have to be very good so that you do some mistake in the exam and still pass. But you're accepting mistake when you're preparing, you're not going to pass the exam. That's just for definite.
Yeah. So I think for me, the key was really that, you just stay calm and give it all you can. Like just do what you can. Don't worry about the result at the time, because yes, it can be a bit nerve-wracking, when you are in the, especially with the mannequin, you've got certain time and you've got to finish, whatever exercise is being given to you, and the examiners are just kind of lurking around and looking at you. So
definitely. Yeah.
I mean, I kind of go back, and it's not the nicest of memories I have that I would like to go back to, but they weren't very good memories when I did that for part 2. I'm sure Naila is agreeing on that. So,
Yeah, of course, 100%.
Yeah.
So, ma'am, is there any special training that you people took before giving your practicals? Like,
yes, yeah. So basically, there are some. Yes, ma'am, you want to go ahead?
Yeah, I did some trainings, and so I think I attended. There was a course for treatment planning. There was a course for OSCE, the Objective Structured Clinical Exam, and I also did some training for the mannequin. And I think, in my perspective, training is absolutely essential because it gives you a taste of what is coming in the exam. No matter how good you are, even if you're really good hands-on, as a dentist in India, you really need to know what they're looking for. Obviously, especially in the mannequin. And I suppose even in the treatment planning, they want you to kind of lay out the plan in a certain way. So training is really important because it kind of gives you that framework and guidance. What is required, how are you going to kind of put it out when you're doing the exam. So yes, Naila, I think you can add more. You've done.
Yeah, there are so many institute. One of the institute that I have worked before, it was called Samson's Lab. They took exam. They gave training for ORE and for PLAB exam as well. So there are several like that. There are so many, and they keep changing. And it depends upon. Sometimes the one organization perform well, the other time the other. But they are, so just to let the people know that the ORE part 1 can be cleared on your own. If you read the books, you go with that and you do as many questions as you possible. But the second part definitely needs some guidance. And then for the guidance, there are several institute. If you go on Facebook, you will find it. If you just Google, for ORE training, you will find it. And also the past candidates who will just clear the exams, say, and they make a group. And sometimes they're also very good and they're very cost effective. So, but you need it. And as ma'am said that, especially for the mannequin part, they will give you all the guidance criteria when you are going to sit for exam. They will send you all the link and you will be reading it, where it will say these are the desirable characteristics, these are not, which should not be there. So you need somebody who can train you in a specific way and can also judge your work, not only mannequin but other aspect as well. So it's very important. And then nearer to the exam, I know most of them, everybody, they conduct mock exam, which really helps you to prepare for it. But for that, you will be, even if you're on tourist visa, you will have to see which course you want to be, and you must come and actually attend those courses, especially the mock ones, and then give the exam. So that will be my advice to take.
Yeah, and I would like to add, Naila, and that people should bear in mind. So, when we're talking about the challenges, I mean, they should bear in mind that so these training courses, they cost you. Yeah, so they are quite, dear, really. So you really have to kind of have that allowance. And like, if you're planning that you are going to give this exam, you have to then think of the money, that you have some plans, you've put some money aside for the courses. So people should be prepared for that yes, they would have to, spend some money on the courses because they're not very cheap, unfortunately, and that's the way it is. And they also have to buy the mannequin, so that's another expense. So you have to buy like a phantom head, a basic one, and then you have to buy these
instruments
as well to kind of practice on them. So just kind of touching on it from a financial perspective, that
I think it was easier for us because we were here in UK and we could install the mannequin head and everything. But I know people who were in India and they practiced there. They just come and took the courses, they went back, and just before the exam they booked for this mock test, and they were able to clear the exam. So it's not like you can't. But you should know what you can expect, and having said that, the visa have this validity of 6 months, so they can come like 1 month or 2 months before the exam, and then they can do. I mean, it's hassle. It's not very easy for somebody to give exam from there, but it's doable. That's what I want to say. Yep. If that's what was needed from this question, then we can move on to the next one.
Ma'am, next I would like to ask that how many attempts do a candidate have? Like how many attempts there is a specified, or you can give unlimited attempts?
Ma'am, you go ahead.
Okay, so I think as far as I'm aware, it's 4 attempts, and the time period you have is 5 years that you have to clear that. Yeah.
Yeah,
And
and
I think
yeah, your
Yeah.
first attempt within 5 years, you have to clear both the attempts. So bear in mind, if you don't clear the first part, say it's 2023, you gave the exam and you have not cleared the first part, and you give the second part in say 2024, again you have attempted, but your cycle will start from 2023, regardless whether you have cleared or not. So you have to bear that in mind, that you have to be really prepared before you give the exam, because you don't want to waste time.
Okay, ma'am. So we do have a limited time period in which we
Yes,
have to clear
yes.
both the. Okay, ma'am. And ma'am, what is the procedure after a successful exam? Suppose I give the exam and I make it, and then what is the procedure that starts after me clearing the exam?
So you need to first of all register yourself, which is called GDC registration. So they will send you the link with your result. They will guide you that what you need to do further, and the link will take you to the GD site where you have to make some entries and register yourself. In that registration process, they will ask you again for a good standing certificate, because the validity is only 3 months, 3 or 6 months. I think it's 3 months. And if you have English, say IELTS is also needed, English language test. So if it is like more than 2 year old, then you have to give it again. And then you have to submit along with that. And there are not so many documents. These are because you have already, most of the document you have already submitted when you're giving WARI 1 part. So that your account remains there, and you have a temporary number, reference number. So throughout these years until you have clear, you will be communicating with that reference number. So everything is there with them. And that's it. Actually, there's not much needed. Once you have cleared the exam, they will send you the link, and what was your number and what was your exam number and things like that. And it's quite straightforward. It's not like anything new or so. Yeah.
Thank you, ma'am. Thank you for putting some light onto it. Ma'am, I want to even ask that, suppose I've given an exam and I've cleared, and there must be definitely some challenges for me to work in this profession in country absolutely different. So I want you to put some light and, bring ahead the challenges that a person could face living in UK, both professionally as well as in the change of.
I can talk about my struggles actually. So what happened that, because especially I would like to tell all people who have done master's degree, what happened when we do master, I think most of you will agree that you leave your basic dentistry skills for quite some period of time, and then you lose a hang of it. And then when you give exam, you go back to the basics. So that's, you have to be mentally prepared for. And now that there is also a rule that you should be at least having a 3 to 6 months of experience in the last 1 year as a general dentist before you can be offered a place here. So what I did after I cleared my exam, I went back to India to have that experience, and so yeah. And then you will feel, if you have been practicing in India as a general dentist, I think it will make things more easier for you, because you're doing this in and out. And then the second aspect, I think, is to choosing the right practice, because you not only work here, it's not like working in India. You have to sign a contract with them, and there are terms and conditions there. You have to be reading it very carefully. If needed, consult what we call here as indemnity provider, who can go through your contract to see whether you should be accepting or you need to negotiate further to make a better terms and conditions for you. Because it is easier to get into, it is very difficult to come out of it. Very difficult. So you have to be, but saying that, there are really nice practices around as well, but you don't have to rush into it, and you don't have to make a judgment based on, I have to go. Take your time, see properly, read the reviews of those practices. If possible, if somebody has already trained from there, if possible, go and meet the practices and the people around, and then make a decision, because it really affects your to some people it affects their well-being, if I have to say that to that extent, because it is like that. The work here is quite challenging. You have to be doing very good. You are very accountable for whatever you are doing. So you at the end of the day, at least you don't want the hassle from your employer, because you're already in a very challenging and on a tight spot, because you are new to the country. It is a new culture. There could be a communication gap with the patient. You have to do your work very diligently, and you have to do, recording is very important, which is not there in our country. It is very, very important that you record everything, what you're saying, what you're doing, what options you have given, because tomorrow the patient may come and say, I didn't understood anything, you know. So these parts, so you don't want to, I mean, itself will be a bit challenging, at least for initial few years. So you don't want to select a bad practice because you were feeling so pressurized to go somewhere. So it will be helpful if you know people around and they can tell you if they know about these practices, and then you go into, but there could be surprises anyway.
Yeah, I think, yeah, no, Naila is very, very right. And she said about record keeping, that they just say, if it, generally speaking, they say if it wasn't written, it wasn't done. So that's a huge, it's just a very stark change from coming from India and working here. You really have to get into this habit of recording nearly everything that you've done with the patient.
Yeah.
And that's such a pain.
It's a very respectful job here, and you really get paid very well, and your life is quite secure. So initial 2-3 years could be difficult, but after that,
I think you really earn your wage, I would say, because the amount of work that you have to do is tremendous, in terms of note taking and record keeping. It is just, you really have to write everything down, otherwise you can land up in trouble. And I would also like to just mention very briefly about, once you've finished your exam, if you want to work in the National Health Service, the NHS, then you need to have a performer number, because I have seen people who are struggling to get a performer number. So once you finish your exam, you've cleared your exam, that's the most difficult part over, and then you have to do some training, and then once you finish this training with an employer, then you get what you call the performer number. So once you get this performer number, then you can work in the National Health Service anywhere in the country. Whereas if you don't have the performer number, you can only work as a private dentist. So, and some people, they do really struggle to kind of, find a practice who will sponsor them to do this post-exam training, which aims at, getting the performer number. So in the meantime, they can work as a private dentist, but getting the performer number and finding employers who are happy to sponsor you.
And you have to be flexible to area-wise, because you might be getting a position which is very far off from the London. Most people want to be in London and around. So if you're flexible with the,
the location,
area, you can still get it.
If you're happy to go up north, you will get more opportunities. But if you want to come down south, you want to come, near London, then yes, it's very competitive. Yeah. So just some of the the practical aspects of it, really. Yeah.
Naila ma'am, I would like to ask one thing from you, as you mentioned about the specialty. So suppose someone is planning to go ahead to UK after doing masters, like I'm pursuing my masters in periodontology,
right?
And I look forward to go and move to UK. So how is the procedure for me? Like, of course, as you rightly said, that we do get, kind of detached with the general practice and we just focus on our specialty.
Yes,
so for 3 years, dedicating my 3 years into something which I'm specializing in, and to go back to basic exam. So how is that transformation supposed to happen? Do I need to, after my master's, go on for some general practice, or should I directly, take away exams? Like, what should I do? Like, what would be your key and your piece of advice for me?
So I can only speak from my experience. So what, as you said, I wasn't in touch with the general dentistry, and I was just doing, and I love perio. I love the surgical aspect of it. I mean, so yes, when I started working, and even when I was in India, you forget even the cements, what cements you need to put. And so I will advise that before, if you're really planning to come to UK, maybe on weekend, just join a general dental practice so that you don't lose the hang of it. It's a couple of hours, but it will help you. And once you are here, that experience will help you as well, because you will be seen as a more, everybody wants to, generate revenue with less effort. So if you're more better in your work, or it makes things easier for everybody. But I know people who have, like, say, they're not even a specialist, but they have this career gap because of the family, of the children, 7-8 years, and then they go back and they start from zero. So it's not that they can, but if I have known this, I would have prepared myself better, and even, like, I think what you can do, even when I have done, because I'm doing my PLV right now to get my performer number. Once I have it, my next step will be to see that how I can work in my specialty, not for, like, say, 5 days, but maybe few days and few patients, just to keep doing, be able to give the best to the people in both ways, but that's another route and that's another thing to do.
And ma'am, what is the scope of periodontology there, like in UK?
It's good. It's good. To understand what they want you to do is that you can still practice as a dentist with a special interest in perio in a private sector, but you cannot call yourself a periodontist. And you should be having 2-3 things: confidence, competence, and indemnity provider who is ready to cover you. You cannot touch a patient here unless you have an indemnity. And those indemnity provider have their own rules. Some of will say, we can't give you any indemnity cover unless you have finished your PLVE and you have the number. Some of will give you, so you have to choose between them who is ready to give you. And more, there are a lot, and that is not a difficult part. You will get it. And then you can work as a dentist with a special interest. But why I have not started yet? Because I don't want to lag behind in my record keeping. So once I am done with PLVE, I might do some short courses, some CPD, some training. Not because I don't have the skill, but I don't want to tomorrow look back and say, oh, I must have written these things. I must have recorded these things. We know the basic thing. I keep on updating myself. I keep on reading the journals and article, but I am very careful. And people should be careful when they're working here. Now, the second route is, if you want to be considered and called a specialist, you need to write to GDC, and they will send you with the information where they're going to say, you can either take a master's degree here, which I don't think people should take. It's a 3 years and very costly. Or else you go through an assessment route. Now, this assessment route will require a lot of paperwork from you, which will include your thesis, your LD, your PG profile, and so many other papers, which I haven't explored that much till now because I'm quite busy with my PLV thing. But maybe I can look into, but there's nothing stopping me to work as a period, in my specialty as a dentist with a special interest, and I can earn well. So it is something, but if you really want to be called as a specialist, you need to go through that.
Okay, ma'am.
I hope you answered your question.
Yes, ma'am. Thank you so much.
Yeah, I think you gave really good information, Laila. Yeah, it was good here, as you said, with the specialist register. I think it's a long route, but yeah, if somebody is willing.
And very less chance of success. They get rejected a lot rather than being accepted.
Yeah, it's a hard one. You don't come across many specialists. I mean, yeah, they're few and far between, really. Yeah, because it's a long route, and most people, they're not that keen to.
And I have kind of realized this thing, that here it's skill. Once you have registered as a dentist here, its skill matters more than your degrees here.
Yeah, absolutely, yeah.
And there's a really nice courses. They are costly one, like Tipton and Felham, and they really give nice courses. So you can keep on enhancing your skills, and that also increases your employability, because they know these are the nice courses, and they are like 10,000, 6,000. I'm talking like that. But once you start earning, you kind of will be able to, finance yourself towards those training, and keep enhancing your skill. That's the way to look forward. Yeah, that's the thing.
Thank you, ma'am. Thank you. That was such an informative session from your end.
Thank you so much.
Yeah, thanks for inviting us. That was really good, good platform to meet everyone.
And hope we were able to answer some of the question, because when we started, we have zero information. It took me 1 year to get these informations, because I knew nobody. So yeah, so hopefully we were able to give you at least some answer, isn't it, ma'am?
Yeah, and I think things have improved a lot. I think in all these years, because again, is when I started, we didn't have these things like WhatsApp groups and stuff. Now there's a lot of lot of like dentist
Lot of
groups, like
information,
WhatsApp
yeah.
groups, and people can get together. And I remember I used to go to this one group in London and kind of go and get onto the train and go there,
Yeah,
and
it's much easier
talk to
now.
people. And it's because obviously technology has advanced so much, and drastically. It's a lot easier. Like so that way, yes, you can communicate and connect yourself with people who are in the same.
Like the way we are doing today in the Pink Congress,
Like
isn't it?
today, of course, yeah. So yeah, it's not. Yeah, it's made it a lot easier. But of course, you have to put in your hard work. That's undoubtedly, the key to
Requirements, yeah.
Thank you so much, ma'am. Thank you for your valuable time.
Actually, I'm so sorry. I would like to. I was wondering if Afsha ma'am is here. I mean, I was saying to see her.
Yeah, Afsha ma'am and Geeta ma'am. Geeta ma'am is
I am
also
here. Yes.
okay, ma'am.
Very well, I am here. First,
How are you,
after a
Ma'am?
long time, I'm going to see Dr. Subuhi, and Naila is not visible to me, I think.
I don't know, ma'am. I'm not trying to hide, but somehow the camera is not working today.
No, it is a pleasure to see you, ma'am. And obviously, when I joined in, and when Noodle sent the program, and I think it was Dr. Geeta as well. I'm not sure if she's around. Yeah, but it was great to
Nice, nice looking at you, Subuhi. Just whenever
Thank
you
you.
come to Aligarh, just see us in the college or in the.
No, I
in
will
my
do. I will
home.
do, ma'am. Inshallah, yes, indeed, I will do. Yes, thank you. Yeah.
It's a teen year, ma'am, to see Subui, but on virtually on screen.
Thank you.
Thank you so much for giving this opportunity to connect back to our
So I think
the matter as well. So
Nishta is fortunate that she is in hand, information which you're supposed to get, a lot of effort, and also you are getting the information in a one go.
Absolutely, sir.
Yes.
Absolutely. So experienced people, beautiful people, and they have their own experiences. I think experiences that matters more.
Yeah, of course. Yes.
And yes, it's lovely to have you both, ma'am. And it was a very informative session. And I really hope that I can do something out of this information. And I'm able to get.
Good luck to you, and I'm sure Nishta, yeah, good luck. And you can definitely get in touch with Naila, because obviously you belong to the same specialty. So yes, I suppose you can, keep in
No,
touch.
of course, yeah. But I mean, anybody, I would love to
Help them out.
answer this question and help in any way that we can, because that's the whole thing. If you get to know something, and if you can tell somebody and make things easier for at least them, that's the whole idea, isn't it?
Yeah, definitely.
Thank you so much, ma'am. Really honored to be having both of you.
Thank you so much. Yeah. Lovely to be here. Thank you so much.
Thank you, ma'am. Thank you, Subhi, ma'am. Thank you, Naila, ma'am.
Bye. Bye.
Yes, over to Dr. Aparna Dave to conduct further. Aparna ma'am, are you there?
Yeah, I'm there. I hope we have Dr. Rachna.
Yes, so she is by, by Kirti Pandey. I'm just renaming her, name. Dr. Rachna is there, yeah.
Yeah. So let me introduce. Okay. So today I have the privilege to introduce Dr. Rachna Kaushal. Dr. Rachna Kaushal is a professor of human rights in Department of Political Science at Aligarh Muslim University with the experience of teaching and research of more than 20 years. She specializes in human rights and holds a PhD degree. She possesses University Gold Medal in Political Science and has qualified for UGC NET exams conducted by Kurukshetra University. She was awarded Ford Foundation Fellowship to attend workshop of RCSS in Sri Lanka and a workshop in National Law School, University of India in Bangalore in 2003. She was awarded at Nippon Foundation Fellowship to participate in prestigious Saalberg seminar in Austria in 2006 and has participated in International Human Rights Conference in Germany. She has been actively involved in research, having published papers in numerous reputed national and international journals. She has been working on a project funded by ICSSR titled Multiculturalism and Claims of Minorities Within Minority. She has delivered talks and lectures and chaired academic sessions at various national and international conferences and workshops. Presently, she is involved in upgrading the human rights course in department and also is engaged in research focused on issues like women empowerment, consequences of upsurge of right-wing forces around the world. Over to you, ma'am.
Thank you, Dr. Aparna, for such an elaborate introduction of mine. And it's a great opportunity for me and a great honor to, to be part of this conference, and something different also, because as I told in the morning session also that I had been part of a number of conferences, but of course, largely dealing with the social scientist or the social science researcher. It's for the first time that I am interacting with the people with a different background. So this is our panel. I think we have to deal with the legal solution to the problems of, women, solution of women's legal issues. And I think we have number of panelists with a very different background, from non-medical background, or they are not, they are different from the dental background. So I think we have some very eminent lawyers and academicians who are actually dealing with these issues. So as far as I am concerned, I'm not a lawyer, but definitely I have been teaching human rights and particularly gender issues in the Department of Political Science to the students of masters in human rights. And then I'm supervising PhDs also on all such issues pertaining to women and different aspects. Like I have supervisor research on domestic violence way back in 2010. And then we did, we did a field work study on the issues and problems of prostitutes with a case study of Aligarh. Then I also supervised one PhD on the real empowerment of women since 73rd, 74th Amendment, and what the ground realities actually are. And we did a survey in the nearby villages to really know whether the 73rd, 74th Amendment has empowered women or not, and the challenges there. So, I have been associated with all these issues. So although I'm not a lawyer and I won't be able to give a very specific legal, advice or opinion on that, but for that, I think we have two very eminent lawyers on our panel, Dr. Charu and I suppose Dr. Daksha also. And of course, there are many more, but I'm not having the entire detail of all those who are on the panel. So let us start with the, the first thing that emerges.
Sorry to interrupt you, Dr. Rachna.
Yeah.
Dr. KVK Santi, she is from Narsal Law University from
Yeah.
Hyderabad.
Sorry. That's a big
and
mistake.
I have shared their brief profile. You can introduce.
Actually, Dr. Nurul, since I was given this responsibility at a very late stage, and I couldn't do enough of homework.
Let me introduce.
Please. I would request Dr. Nurul, because you are having the portfolio of almost both the panelists. So let us have a elaborate introduction of all. Thank you.
Dr. Charu Mathur is an advocate in record with the Supreme Court of India. She is empaneled as a counsel of Honorable Allahabad High Court Education Institute like Gujarat University, Jodhpur University, BPUT, Odisha, LLU, RMLLU, MLU, Jodhpur Indian Institute of Foreign Trades, and she's also associated with Jodhpur, Jaipur, Ajmer Vidyut Vitran, Rajasthan Road Transport Company, National Fertilizer Corporation. She appeared in large number of matters especially for us, like medical students in NEET matters. She also appears for JSPL and JPL Jindal Group companies. She appears in range of matters ranging from civil, criminal, and constitutional and taxation matters. She is instrumental in directions issued to various states to have document identification number in all GST notices. She appears before various high courts and as a counsel. She is a rare combination of practicing lawyer with activist interest in academia. She is a published author, frequent speaker at national and international forums. In 2017, she has invited by university in the UK and spoke about access to justice and got opportunity to be in keeping with the times, she has developed online course for leading publication houses and consultant to its e-learning division. Then we have Dr. KVK Shanti. She is teaching criminal law since 70 years. And her doctorate thesis is on penal reforms in India. At Osmania University, she is a proctor of the university and takes care of discipline on campus. She has been associated with many projects such as study of the Indian Penal Code and Gender Perspective commissioned by NCW Law in Grievance Redressal in the public offices in AP by Center of Good Governance as coordinator for the project to draft the Amendment Act. And she is also Police Research Development and UGC Major Research Project in Sentencing Perspective in the state of Andhra Pradesh. And she has been a co-investigator of GIGA Global Internet Governance and Advocacy. She has visited Max Planck Research Institute for International Criminal Law, Germany, as part of postdoctoral research program. And then I suppose to introduce Dr. Daksha as well. Let's go on. Dr. Daksha is educational background. She is PhD from Indian Law Institute, New Delhi. She did LLM, Department of Law, University of Pune. Her work affiliation in Indian Law Institute, New Delhi, Sanjeev Goel Association, New Delhi. Important publication research experience, Spectrum Politics, Unveiling the Defense, co-authored with Senior Advocate Mr. Salman Khurshid, former Minister of Law and Justice and former Minister of External Affairs. And she is initiated, she is research assistant in editing the revising Mullah on Law Contracts, published research papers and book reviews in renowned legal journals like Journals of Indian Law Justice, Madras Law Journal, All India Reporter, International Journal of Research and Analysis. Yes, over to you, Dr. Rachna. Dr. Rachna?
Yeah,
Yes.
thank you, Dr. Noor. So I think we are having very eminent panelists out here to give their expert opinion on actually the legal solutions to a number of issues. So let us start with Dr. Charu, and I would like to first let us first discuss what exactly are they, since you are a practicing lawyer and you must be interacting with a number of coming across a number of practical issues and ground realities. So what kind of issues do you really handle, or you really face, or what kind of complaints women come with and approach you? I think that is the first thing that we must know. So क्या common issues हैं जिनको आप ज़्यादातर हम लोग address कर रहे हैं, आप लोग जो हैं as lawyers?
Thank you, Dr. Rachna, for that query. Thank you, Dr. Narul, for the introduction, and good evening to everyone. So as a lawyer, if we are talking about the women issue, there are certain issues that we face. First is the dowry harassment cases that come. Then there are domestic violence cases, both from the daughter-in-law as well as from the mother-in-law, right? Senior citizens also getting harassed. Then if you look at the working women, you do get cases for the posh where there is a sexual harassment, or even there is a touch of sexual harassment that is there. Then coming on to like the previous session I was attending, so we do have the custody matters. So if a person has shifted abroad and the husband doesn't want to move or the wife doesn't want to move, so there are various custody matters that keeps on going. And the new type of a litigation relating to women is coming, where the daughters are coming forward to ask their rightful share in their father's or the ancestral property. So these are the basic cases that we get from the women. And since I pursue a lot of educational law, so we do get a lot of cases relating to entrance exam. Particularly, there is, I don't know why, but there is a lot of litigation regarding the medical education. So we do get a lot of queries, lot of cases regarding the admission to NEET exam. And then we have got this particular problem, like where we have represented female lawyers, say female doctors, saying that for the PG exam, because she is into advanced stage of pregnancy and you have given her a center some 1,000 kilometers away. So we have used that jurisdiction. We have got relief for 3 ladies that they should be given a place for having their to do their examination at wherever is the nearest possible center. So these are some of the cases, the women-centric cases that we get.
Thank you, Dr. Charu. I mean, it's really enlightening because yes, these are a few very important issues that most of the women are facing. So yes, so what happens like when both senior citizens and daughter-in-law are, trying to get some kind of solution for domestic violence? Because recently I came to know about a case because the new Domestic Violence Act of 2005 gives a right to residency to daughter-in-law who is fighting a case regarding domestic violence against her own in-laws. And then there were senior citizens, the in-laws, mother-in-law and the father-in-law. And there was a clash of, interest between these two groups of people fighting on a common issue of domestic violence. But the court said, yes, both will, the court gave right to residence to both of them. Now, if the house belongs to the in-laws, mother-in-law or the father-in-law, how long a daughter-in-law can continue to stay? And if suppose this issue of domestic violence culminates into divorce, then what will be the residency status for the daughter-in-law?
Right. So there have been cases, and particularly in places like Delhi, where the space is very sacred, very scared spaces there. So I have dealt with one particular case where the house was actually divided into 2 parts, where the daughter-in-law and the grandchild was living. So they made an arrangement that she can go to kitchen from such and such time, and other area was cordoned off for the mother-in-law and father-in-law. They had put a CCTV within in the house to ensure that nobody is harassing anybody. As far as your right to residence is concerned, daughter-in-law has an absolute right. In fact, a woman has an absolute right to the residence. So even if it is a residential, if it is a rental accommodation, right? Then also they have to provide. They said, "Hum is ghar mein reh rahe the, rent pe tha." Right? Still, if the girl want to stay there, then they have to provide either a separate residence for her, or a residence, or the same residence they have to continue paying the rent. So right of residence is something that is primarily given, and if she has a young kids, then it is even more that is there. So if you look at the court, generally saying they are more towards the daughter-in-law, young daughter-in-law with a grandkid or kids, right? And there have been cases where the husband has passed away and the daughter-in-law has been turned out of the house. And in those cases, court has come extremely heavily on the in-laws, right? And the second question was, what happens to the status after divorce? After divorce, a woman does not get a right to live in her matrimonial house, but whatever are the terms of settlement, right? She has to negotiate that smart.
Thank you, Dr. Charu. And I would like to have an opinion of other panelists also, like on the issues, because we are having Dr. Daksha also here, and we are having academicians from a very prestigious institutions. So I would request you to just throw a light on as to, these are the issues like dowry harassment, domestic violence, or for that reason, claiming the share in the property rights. It all spoils a woman's relationship with her, say, the nuptial family or the natal family. No, what to do in this situation? Suppose the daughter needs, she's in a financial crunch, and she's claiming a right in her ancestral or parental property. But the brother and the sister and his wife or the family or even the parents are really not very willing to give. And it many times leads to, they sort of pressurize the girl. So look, if you claim if you make a claim in this property, will not be having very conducive or cordial relationship. And many times it leads to finally the end of also, almost end of the relationship. Khatam ho jate hain rishte. So in with a fear of not losing your brothers or parents and your entry to your new natal family, many times girls do not claim their share in the property. That is one reason. They are emotionally, blackmailed. Kehna chahiye. So can we have some opinion from Dr. Daksha, and we are having some academicians also on this issue.
All right. So as far as this issue is concerned, I believe this is more related to the social aspect also, that, how daughters are treated within their families. And if we talk legally, so certainly we have systems like MOUs being drafted and families sitting together and, taking out their points that, how they want their family property to be settled between their, daughters and sons. So I don't think so that we are facing much trouble, in the metros. But yes, as far as if we go into the remote cities, small cities, we are facing this challenge. But as far as the distribution of property itself is concerned, this is the right which is related to the women. If women, if daughters are more towards having their right to have property, so then certainly they should go for it. They should have their voices, and they should sit with the family, have good family arrangement, and then legally settle the things. Despite we have strict legal provisions also, we see that a number of times women are not coming forward to have the property in their father and mother's houses. But what I feel that women are always empowered. It is not that we have to move towards women empowerment. Women are always empowered. It is more about raising their voices, having their right place in the society, and then when they're strongly believing in something, they should stand by it. They should not be blackmailed emotionally or by either of the ways that, no, you are a daughter, you should not have a right in the you should not have the property, this is for your brother. So I think so these are more psychological and social aspects which are coming with this right. But as far as law is concerned, it is quite clear that we have right to equality under Article 14. Everyone is treated equally. So we have this legislation now. Daughters also have the right to property. So it is more related to their willingness, that how they are coming forward, how they are settling the things within their family structure, how they are able to convince others that this is their legal right, and they have to secure this right also. So I think so it is more related to the willingness which is coming from the women. Thank you.
Thank you, Dr. Daksha. I think because you people are practicing lawyers and you are more into practical, things. But I think one way to secure the property rights is the girls should say no to dowry and claim their property rights. Because often in the garb of giving dowry, the parents and the brothers say, look, we have given a huge dowry at the time of your marriage, so there's no need for you to go in for the property rights. So I think one way is girls should better because उसमें उनको ज़्यादा benefit होगा instead of taking dowry, and then we will be discouraging a beautiful tradition which is now turning monstrous. So it's better to say no to dowry and take your property rights. That in my opinion, is a better option for that. Since we have an academician from Malsar and who has a specialization in criminal laws also, I think, ma'am, I would like to highlight one thing, that since the decade of 80s, which is often called as a decade of pro-women legislation, when we amended the anti-rape law for the first time in 1982, and then the Dowry Act of 1961 was amended in 84, and then very quickly in 86, it is often called as a decade of pro-women legislation. And then we are having very good, pieces of legislation like Protection of Women Against Domestic Violence Act. Rape laws are becoming very, very stringent. But the graph of crime, particularly like rape, and is not only rising, but they are becoming more heinous. So what do you think? The law is not having its deterrence value, or law has failed to give, any, to send any kind of message to the perpetrators that, look, even you will be able to escape even after doing such heinous crime. So what is the reason कि हमारे laws जितनी stringent हो रहे हैं, और जितना हम women के छोटे छोटे like sexual harassment पर भी अब हमारे पास act है, we are having such good pieces of law, domestic violence पे हमारे पास बहुत ही अच्छा एक law है, but what is the reason कि जितना हमारे laws stringent हो रहे हैं और ज्यादा बन रहे हैं, उतना ही crime का जो graph है वो that is going up.
Yeah, thank you, ma'am, for this wonderful question and the opportunity given to me to speak in this August gathering. Yeah, ma'am, your question, I hope I'm audible to everyone.
Yes, yes.
If there is any issue, please inform me. Yeah, this is a problem which, as an academician and also as a researcher, it keeps disturbing me. One thing is like the laws are stringent, yes, but why the incidence of sexual assault is only on the rise is a worrisome question to the entire society, more so to the legal academia and also the legal enforcement authorities. One of the reasons I have found in my research, ma'am, because I also teach cyber crimes and also I'm into cyber security issues also. I found that this pornographic content also has something to do with it, because nowadays it's just not a simple rape what's happening with a woman. They are videographing the entire act and then it is put on circulation, and it's appalling to know that some of the live rape videos are on circulation in the Facebook, and upon the repeated requests also, Facebook has refused to remove them from the accounts. And Dr. Aparna Bhatt has filed is a lawyer, filed a writ petition in the Supreme Court with this 2021 new regulations of the central government, which says that every foreign company which operates in the territory of India, like Facebook, Twitter, Instagram, everyone, should have an offshore establishment here, and also with an officer who has to take the liability in case if any offense is committed, would be helping to an extent. But I seriously think that there is a causal connection between this pornographic content, this violent pornographic content, and increasing incidence of the sexual assaults on women, children more so, and the cases of child sexual abuse. Online child sexual abuse also is on the rise. Then a committee is appointed. Dr. Jairam Ramesh headed that committee from Rajya Sabha in 2020. They gave certain guidelines, but none of those guidelines were accepted or even are not rejected, but I could not see them taking the shape of law. So I think this is one of the reasons for increasing of the sexual violence against women. And secondly, the procedural aspect, the procedural law also is somewhat giving lot of opportunity to the accused to sneak from the small loopholes. And it is to fight a criminal case in this country is the most horrendous thing. At least people who are from legal academia and legal law would be knowing this. Starting from filing an FIR, it is not easy. Getting a charge sheet in favor of the victim is not easy. The medical examination also, many times it goes against the victim because the postmortem, the doctor who conducts the postmortem relies on that very infamous two-finger test, which says that if two fingers are admitted into her vagina very easily, it means she is habituated to sexual intercourse. I mean, there are judgments given by the Supreme Court which say that no, we have to do away with this test, but still this test is followed. And then there is a problem with the questioning which happens during the trial. And all of us know that the rape trial is more heinous, more worse than the initial assault. And if I would like to close my remarks with just quoting an incident, what happened in New Delhi. Just after a week or so of Nirbhaya's incident, a 7-year-old girl was found unconscious in a cellar. She was admitted in the hospital, and doctors have removed one 200 ml parachute bottle, few candles, and pencils from her vagina. She survived this sexual assault. And in the scene of offense, some 200 and odd obscene content, pornographic CDs were also seized by the police department, by the investigating officer. It seems these people, after watching those movies, they are trying to experiment with those stories. And this is a serious problem as I foresee it. Thank you so much.
Thank you, ma'am. It's really very painful. I mean, even listening is so painful. I can what to say that all those who undergo all this, you see that because of all this, as ma'am has said rightly, these are the reasons, I suppose, that discourage a woman from even making a complaint or filing an FIR, because all these factors are there. Getting an FIR itself is a very difficult process, then medical examination and everything. And ma'am, this is a question that I'm throwing to the entire panel, that usually all the matters or the crimes related to violence have so much of a stigmatization with it that women really don't want to go to the court. So we are having two eminent lawyers here. I'm not sure whether we are having anyone else also other than Dr. Charu and Dr. Daksha. But, can you just throw light on the fact that why women usually don't take recourse to the legal action? In most of the situation, most of the cases, women don't go out, don't get it registered, don't get the complaint registered, don't go in for the legal, procedure or trial, whatever you may say. And that gives encouragement to the perpetrators that whatever we do, first of all, women will not go out. She will not go to the police. She will not go to the court. And even if they are going, then the processes are so cumbersome that they leave the trial in between. So can we have some opinion on this aspect also?
There is a serious question of empathy, ma'am, lack of empathy from the law enforcement agencies, starting from the police to judges. You might have also that old case reported in 1982, Gurmeet Singh versus State of Punjab. The Sessions Court judge says that a 10th class girl, she enjoyed with 4 men for 1 day, and now she's putting up all this story just to sound virtuous in front of her parents. So a woman, if she comes out of the house and she complains that I've been raped, she is considered as a girl of immoral character. She is a girl of loose morals. A woman who has integrity, even if she is raped, she will not come out of her house. She will not shout like this. This is the understanding of the society. This is the understanding of judiciary also. And I have done a research in state of Madhya Pradesh, wherein I interviewed some 200 judges at all levels, starting from magistrates to sessions judges to chief judicial magistrates up till high courts. 80% of the judges, including women were the, I don't know, they were saying that all these rape cases are fabricated. They are all farzi. Farzi hote hain, and women who come from minority community, they will cause injury in their private parts themselves and come to the court just for that compensation of 25,000 rupees, which is given according to Prevention of CST Atrocities Act. So this is the kind of empathy, lack of empathy from the law enforcement agencies. And in this country, making an allegation that a woman is raped is the most easiest thing, and proving is the most difficult thing. If you see the conviction rate as a whole, in this country, that is somewhere around 16 to 17%. And if you only look at sexual offenses, that could be even far lesser than that, somewhere like 7 to 9%. But NCRB crime clock says that every 14th minute a girl is raped. So this, I think this is one of the reasons we should have special courts to try these cases. We should have a fast track courts to try rape cases. Andhra Pradesh has come up with a law that within 1 week the investigation has to be over, charge sheet has to be submitted. This is a bit over ambitious law. 1 week is too less a time to conduct any genuine investigation. But a time frame has to be given to complete the charge sheet, to complete the investigation, to complete the trial. I think this will help the women, to more women to come out who are victims of this sexual assault.
Thank you, ma'am. Thank you so much. So I believe in, since we have a high literacy rate amongst women, most of the time women lack legal education. They're not familiar with the, what legal protections do they have in most of the situation, I believe. So, since we have two practicing lawyer, ma'am, Dr. Charu and Dr. Daksha, I would like both of you to throw some light on, like, what are the bottlenecks in the way to, a legal justice as far as women are concerned. And then after that, what are the solutions? What quick solutions do we have? Are there any helplines for that purpose? Jahan par women can approach, somebody, some kind of organization. What all do we have in this regard?
Shall we go first?
Yes, ma'am, sure.
Hey, Daksha, you'll go first. This is what I'm saying.
Ma'am, please, you please go ahead.
So
I would first love to learn from you, and then
nothing of those. So thank you, Shanti ma'am. That was very elaborately you have given, and these are the actual problems that we face. So actually, the procedure itself is a trial. The trial, before going to a trial, the person has to pass an arduous journey. Now, look that even if the lady has to go to a court, she will be teased, there will be whistle blows, there will be something rude remark will be made on that, right? So some such type of things can be easily, like after COVID, we have opened to this video conferencing, right? Lawyers are status quo people, but now with COVID, whether it is forced upon us, now we are open to this idea. Yes, we can function even virtually. So one thing is that one procedure that we can make it little less arduous for those women, the victim, is perhaps to go through the video conferencing. It is still there, but not used that frequently, right? That option was there, but it was not used frequently, and most people were not aware that such a option was also there. The second thing is, I agree with Shanti ma'am that the pornography that is being showed, easy access to all these things, the violent videos that is there. Now, whenever you hear a rape, you actually hear about a gang rape only these days, right? It is more of a power struggle. Like I was reading one of the books, they said that why rape happens, what is the cause? And they say they look at it as a power struggle, that women are doing better in the society than men. So they say that how to overcome that, and that is perhaps the only way, that we are physically more strong. And then when they realize that they cannot harm a girl, a single man cannot harm a girl, so they go like a wolf pack. So that is a problem. And then there are people who, whatever they watch on the net, etc. So they try to live that fantasies and harm the person. Now, as far as by law, if you're trying to shut down certain websites, it is not a practical solution, because within a second it mirror site appears, right? There are many petitions which have been filed, there have been lists given that these are the sites, but even if you ask them to shut down, it is practically not possible. Perhaps one thing, like I have been to Gujarat for some time, and I come from Rajasthan basically. So in Rajasthan, it was a big taboo to see a girl and boy talking. But when I went to Gujarat, I found it absolutely normal, a girl and boy talking. There used to be that Garba night, Dandiya night. It was absolutely safe, even in late 90s. I'm talking about 94, 95, 96, 97. That you can roam around on your kinetic Honda at 4:30 in night, nothing will happen. So you need to normalize that also. It is okay if a girl and boy talk, right? And there I won't say that they also they have this problem, but that is of a different level, right? There are cases of teenage pregnancy, etc., more there in the Gujarat because of free mingling. That is there, but you won't find crime against women as such, as I can say, prevalent in the other state. Because what I mean, this is, I may be wrong, but this is what is my experience. You don't get that many rape cases from Gujarat as you get from the Rajasthan. This is one thing, because for us it is absolutely taboo. It is even till date, even in 2023, it is not a normalized thing, right? So that is one aspect, and how to control technology is beyond everyone else. Now with Chat GPT and GPT-4, people can fantasize their own. So you can just write, I want to fantasize this. Draw me a picture with the Wall-E that they have come, this OpenAI. They can even draw the graphic pictures of whatever scene you want to do. So technology, perhaps we cannot stop, but we have to think, probably make people more aware of that this is a normal relationship that a person can have. And then as ma'am talked about people saying that girl was with 4 boys and everything. So here I would just like to highlight that POSCO was a very good law, and it is still a very good law. But recently, what I've been seeing from last 2 or 3 years, it is like teenage love stories going bad, and then you put the boy, you spoil the life of the boy for entire times to come. So you have to relook at that also. So I think we can have the
some laws are prone to misuse and abuse, ma'am. It's true that, but the intention behind making those legislations is laudable. But of course, we need to look at these abuses, and if you can regulate or at least minimize them, then that would be the real success of the enactment. Apart from all this, as Daksha was saying about domestic violence and or some other act, it's a sociological problem also. I have watched, you might have also, that India's daughter documentary. What I've understood from the jailers, the jailer of Tihar jail, he's saying that all those men, they think that they have a right to rape a woman because he's born as a man, and a woman has no right to say no. So this psyche has to change, and women are responsible at home. They have to educate their boys that this is not correct. And they were all uneducated in Nirbhaya's case. Yes, that's true. But even educated families have this kind of people, and educated mothers are also failing in their endeavor. So I would say all mothers have this problem in bringing up their sons. They have to make them sensitive towards this kind of activities which are committed against women. I think so.
Thank you, Santhi ma'am and Charu ma'am. It was really a learning experience for me, when I just listening your views. What I want to say that, here more emphasis should be on awareness coming from the family end, and then at the organizational end where the women are working, if they're stepping outside the home. And then afterwards, it is a social responsibility also with respect to protection of women. So we have constitutional provisions stating that, women has a special status. Article 15 has provided special status to women and child. So certainly I feel that, it is more about awareness, that how aware women are about their rights. And after that, as far as the question was raised with respect to helpline numbers, so we have a couple of helpline numbers, like 1091 women helpline number is there, then 181 for domestic violence. But normally, what I have seen in the consultation cases, that women dial and they rely more on 100 rather than these helpline numbers, because they don't remember these numbers at first place. So certainly, whenever they seek help, as per my experience, they are getting help from the police. If they dial 100, they get immediate call from the police, and then they come and they inquire that, what is wrong here. I think so that it is more related to women's awareness, that which mode they are operating for, and where they want to rely. Suppose sometimes women feel that going back to their matrimonial house is not a safe option in cases of domestic violence, or going to their friend's place is not a safe option. So it's better that they make things legal, and they dial 100 or 1091 as a helpline number to save themselves, to protect themselves. Now, another important challenge which I foresee, especially in the cases of domestic violence, is that sometimes women are not able to identify that they are the victims. Like there are very many forms of domestic violence. Like we have sexual abuse, then we have verbal, mental abuse, psychological abuse, economic abuse. So it's not that domestic violence only includes physical abuse. So we have other types of abuses also which are there in domestic violence itself. Sometimes, like women are treated disgracefully at the family level. So again, I would say that they have to identify, they have to first figure out that yes, this is a sort of abuse which is happening to them. Sometimes it is taught to them right from the very beginning that this is just normal, this happens in every family. You have to adjust, you have to maintain relations, cordial relations with your in-laws, with your husband's family members, with your relatives. So they are not able to identify somehow that this is a form of abuse which is happening. So again, I would like to say that more awareness programs should be created. Women should be involved more in activities wherein they are taught about their rights, wherein they are taught that these are the remedies available if your rights are violated. So I think so with the concerted efforts of legal academia, lawyers coming together, we can make a remarkable change in the society. Thank you.
And Dr.
Yes.
Charu was just a point, ma'am, before we conclude. Dr. Charu was raising a concern about POXO cases also. POXO में problem ये होता है कि the most of the times the assailant is known to the victim. He would be a family member. And in that case, rest of the family members will try to protect him instead of supporting the victim. I mean, that becomes a greater problem with the POXO Act. That is why these cases are generally underreported. So this is also an issue which I have found out. Secondly, these reformatory homes or rehabilitation homes, they are also not working properly, no proper supervision. If some girls, if they are they are rescued from a brothel house and they are sent to rehabilitation homes, after a few weeks, you will find them again in the same brothel house. I have heard this kind of cases. The managers of those rehabilitation homes are selling them back to the same brothel house. I mean, there is one lawyer from Mumbai who worked extensively in this area, Dr. Mehru Daruwala. I mean, she has quoted a number of incidents of this category. I'm just bringing this to your notice. Yes, awareness is required. Knowledge is power. Awareness has to be there with women, children, girl, child also, and also men, as to how sensitively they have to behave with their fellow women. Thank you.
Thank you, Dr. Charu. Thank you, Dr. Shanti and Daksha as well. It's very enlightening. So you see, yes, of course, because I am a social scientist and I'm looking upon the things more from the social dimension rather from the legal. Law is one thing. Yes, if you are fighting against injustice, if the law is there, finally, it's, I mean, one is sure that they will win the battle. But most of the women issues or the crimes related to women are a social problem. That's very true. And, I believe that, it has more to do with the mindsets, like as far as domestic violence is concerned, because we are being brought up in such a patriarchal environment with such patriarchal values, where we start discriminating between the son and the daughter, like you will not go out after 6 and the boy can remain out of the house till 11. My daughter is often getting annoyed with me. She says, why you are not allowing me to go to a nearby market even after 6? And my brother, is coming many times, or you are even sending him at 10 o'clock. So I have no answers virtually. And then I sometimes try to make her understand, look, the society is like this, and Peter, you are more prone to all these things, eve teasing and assaults and blah, blah. But, she's not convinced at this stage because she's 15 years old. So I do understand. And, discrimination takes many, many forms. The biggest reason for malnourishment of most of the women in middle class families who are not financially very unstable financially, they are quite well off, but then we have a tradition that the daughter-in-law will eat in the last. She'll be the last person to eat, and in most of the situation the food is over and she finishes her meal with a very insufficient amount, or with, say, she'll eat paratha with achar or something like that, and she'll not have proper dal and vegetables and salads and everything. This happens in most of the families. So here there's no financial crunch, कोई discrimination बहुत overt नहीं है, but उसके बाद भी काफी हो रहा है. So, and one thing I believe कि बहुत सारी crimes जो हैं, as Shanti ma'am said, a lot of insensitivity, that a woman who has not resisted very strongly is enjoying the rape. A few years back, I heard a senior CBI officer in a public meeting, he was saying that if rape is inevitable, enjoy it. So a lot of criticism, he faced lots of criticism. But then, yes, we do have a mindset that, look, if you have opted for a career, if you have decided to come out of the house and work with us, be ready for all sorts of behaviors. चाहे फिर वो obscene jokes हैं, चाहे वो obscene behaviors हैं, चाहे आपको easily taking for granted है, but आप don't declare it as sexual harassment. In my own department, I fought on the issue of ladies' toilet for 8 long years. It started with finally it was the third vice chancellor who finally addressed the issue. So there were ladies' toilets constructed with special funds from UGC to a central university to construct what? Ladies' toilet. And the moment they were constructed, the male counterpart said, no, it's a staff toilet. It is not ladies' toilet. It is for all the staff. I said, no, it is not for the staff. It is for the girl students also, where they will go. So, the battle continued for 8 long years. And finally, I was taught a lesson in selection committee, and but then I went to the High Court and I brought my promotion from there. So you see that instead of going to sexual harassment cell, I thought of addressing it then and there only. I prefer कि हर चीज के लिए we need not go to the cell and need not go to the court. We should.
Ma'am, I'm sorry that I'm interrupting, but I just wanted to support this point which you have made. Ma'am, I have done a study wherein we have compiled 27,000 cases of rape, me and my students. So one of my students, after tabulating all those cases, she came to me and she said, ma'am, if we construct toilets in all the villages, I think the cases will be minimized.
Yes.
Because they don't have toilet, they go outside, they are vulnerable. In that situation, many people are committed.
Yes, ma'am. Yes. I made this point also, that toilets are such a big necessity. And when the Prime Minister is addressing the country from Lal Killa and saying hey, toilets banaiye, so it is not only a matter of addressing the nature's call. It is a big security issue for a large number of women who go out at say 4 o'clock, 4 a.m. or 3 a.m. अंधेरे में जो निकल के to address the nature's call. So you see that there are so many. I mean, I fully agree that by changing the mindset of the people, we can change so many things. I listened to the acid attack victim Lakshmi, and she said nothing will happen if you ban the sale of acids in shops, because acid lies in your mind. Acid is not in shops. Acid dimago mein hai. So you see that. Another thing that I want to emphasize is the shrinking value base. Yes, we have to, as mothers, as parents, we have to inculcate these values amongst our children, be it a girl or it's a boy. the respect for women, as sensitivity towards women issues. And then we have to inculcate a kind of environment in our family, because state is nothing but individual writ large. State जो कुछ आपको रिफ्लेक्ट हो रहा है लॉस में या जुडिशरी के एटीट्यूड में, वो सब शुरुआत फैमिली से ही हो रही है. So I think by changing the mindset and by strengthening our value base, and shrinking value base is one reason for the growing, graph of the crimes in India. And of course, lack of legal education, lack of resources. Many times, many educated women do not take recourse to the legal action because of the fear of the society, stigmatization. In many cases, women are not even sensitive enough to realize that जो कुछ उनके साथ हो रहा है वो wrong है, it is illegal. In cases of domestic violence, there are large number of working women जो अपने ATM भी operate नहीं करना जानती. Their entire salary is grabbed by their husbands, and they decide where to spend and how to spend, and कितने कपड़े और कब खरीदेगी औरत जो है. And same is with the female feticide also. Mother is hardly given a role, or she hardly has a say in deciding whether to continue with the female fetus or not. But then there, not only the males are responsible, but the society. As mothers and mother-in-laws also, our standards are different for the daughter and for the daughter-in-law. We have different standards for the male child and for the female child. So lots to do with the value base and with the mindset of the people. So one last issue that I would like to, what suggestions you can have to so that we may have better legal education and better access of law, because justice is very expensive nowadays. आप हाई कोर्ट में एक वकील को हायर करें, you need to have say 1 lakh rupees. आप सुप्रीम कोर्ट में एक लॉयर को हायर करना चाहें, you need to have plenty of money. That may not be within the purview of every woman, a common woman. What solutions do you have as lawyers, as academicians, and etc.?
Yeah, ma'am, in my experience, I can say that I'm teaching in a law school. When I just started my career, in a class, we used to have 70% boys and 30, less than even 20% girls. But now it is like reverse. Like 70% girls I'm seeing in some of the classes, and in no case it is lesser than 60%. This is one thing, it's a welcomeable thing. Secondly, Delhi Domestic Working Union Forum case, in this case, Supreme Court has advised to have a list of pro bono lawyers being made available in every police station. Like a rape victim can approach them and they will help them for free. But the quality of these lawyers is always a question. Of course, they won't get a lawyer who is of a stature of Ram Jethmalani or Nani Palkiwala for free. But yes, some lawyer is available who will be able to help them to an extent. Yes, getting justice is not an easy thing here. It is not, it's definitely an expensive task. But this is something which is available as of now. More lawyers from law schools, more women has to come forward to help these women victims who come from poorer strata. This is one thing this is one suggestion I can make.
Thank you, ma'am. Over to Dr. Charu and Dr. Daksha. Any suggestions for improving
just one number I want to share is 112. It is 911 of India. Not many people are aware. It is a combined helpline for your police, fire, as well as for women helpline. And I live in Noida, so I have seen this black color van standing very often. And to my surprise, I found it to be very helpful in the cases of distress. So this is one number which I think should be shared more, though there were some complaints that it was not reachable, but by and large, I found it to be much more responsive than any other helpline. So that is one piece that I wanted to share with you.
Thank you.
And women also should understand that these laws, they have to use them as shields, but not as weapons. If they can understand this, they will there won't be any abuse of law, and we will not have to listen from the Supreme Court also saying that 498A is abused, let us make it compoundable, let us remove it. This kind of things we've been hearing. So women have to be responsible while using these laws, which are made to just protect them.
True, ma'am. True, very true.
In fact, one more suggestion from my end is that, like, though we have this Legal Service Authority Act 1987, because of which we have various legal aid cells working and pro bono cells working within the colleges for helping the victims. Certainly, pro bono help can be extended from the advocates end also. So, our senior advocates always reserve few cases for pro bono litigation. So this is a very welcoming move, wherein, you are taking certain cases on need basis, with no cost. And otherwise also, what we see in colleges when legal aid cells are working, students are very proactive, especially in giving consultations under the supervision of the faculty and the concerned lawyers on the panel. So that system, that model also works, that, at the initial level, you are able to give certain legal counseling to the victims. And then if you find the matter to be serious, you can take it forward to the concerned specialists later on. So this model is also working in the law colleges and law universities. And at the end, I would like to say that, certainly it all relates to the awareness of the women herself, how aware she is about her right, and how willing she is to take this, legal fight onwards. So because, women is not fighting at one end, she's fighting at many fronts. So this is also very important aspect, that, how long she can go in the legal battle to obtain her rights, to have her rights with, her. So with this, I would like to close my remarks. Thank you so much. It was such a learning for me. Thank you to all the senior panelists who are present here. Thanks to National Health Academy for inviting me in this talk, and thanks to our moderator with whom we learned a lot. So, sometimes questions are more knowledgeable because, they are leading towards the discussion. So you were giving such exhaustive questions which compelled us to think more critically on these aspects. Thank you very much.
Absolutely. Many thanks to all the panelists. Thank you, Dr. Charu. Thank you, Dr. Shanti and Dr. Daksha, for your expert opinions. And we really learned a lot from this. Because I am a social scientist, I do look upon all these problems, but from a human rights perspective, I do touch the law, but only an outline of that. I'm not much into the legal intricacies, but yes, as far as the social and economic dimensions are concerned, definitely I'm into that. But it was really a very, very fruitful session for all of us. Thank you so much once again. And with this, we are almost about to close the session. Thank you, Dr. Nurul, for giving us so much of time to discuss such important issues, which matter not only to the professionals, but to a lay person, to every common woman, that whether you are a doctor or not, whether you are a professional or not. But yes, these things are important, and they are enlightening for all the women as such. Thank you so much once again.
Thank you, ma'am.
Thank you.
Dr. Aparna.
Yes. Yes, this has been a wonderful session. It was eye-opener especially for us who are not, don't come across such kind of discussions. And probably we need to listen to more such sessions. So thank you, ma'am, and thank you all on the panel for a wonderful, wonderful session. Thank you.
Thank you so much.
So now, as with this, I would like to now invite Dr. Afshan Bey. Dr. Afshan Bey is from Department of Periodontics and Community Dentistry from Dr. Ziauddin Ahmed Dental College, Aligarh Muslim University. She holds a MDS degree and a PhD degree in periodontology. She has 94 publications to her credit and has guided several MDS theses and co-supervised PhD theses. I invite Dr. Afshan Bey to propose vote of thanks.
Ma'am, you are on mute.
Could you please unmute your microphone, ma'am? Dr. Afshan, could you please unmute your microphone?
Yes. Okay, yes. Now, am I audible?
Yes,
Ma'am, you are audible, yes.
Okay. Assalamu alaikum and good evening, everyone. It has been such an honor to be a part of this wonderful event organized by National Health Academy under Pink Dental Congress. And I would like to extend my heartfelt gratitude to the participants, individuals who invest their time and resources to make sure that everything is perfect. No event can be successful without this. I would like to I would like to thankful to the participants and presenters who have spent some proficient sense of gratefulness to all the participants for sharing with us some of the finest practice. All the participants of this event are inspired by highly sparkling presentations, and with a deep sense of appreciation, I am thankful to speakers Dr. Neena Moitra, Dr. Nandini, Dr. Shaili Mahajan, Dr. Nimfia Pandit, Dr. Sneha, Dr. Indira, Dr. Zainab Chaudhary, Dr. Sonal, Dr. Cheena Singh, Dr. Pavni, Dr. Rachna Kaushal, Dr. Sarmishtha Ghosh, Dr. Aarti Kapila, Dr. Ramya, Dr. Subhuhi Arshad, Dr. Naila, Dr. Charu, Charu Mathur, Dr. Daksha Sharma, Dr. Shanti. And I'm grateful to the moderators who graced the occasion. The names are Dr. Sana Shadab, Dr. Pratibha, Dr. Mansi Mehta, Dr. Suchita Sinha, Dr. Aparna Dave, Dr. Nishitha. I also extend thanks to all the members of this enormous cooperation within the organization of this event. An event like this cannot happen overnight. The wheels start rolling weeks ago. A special thanks to our student, Dr. Nurul Anwar, who always put in an effort, a lot of effort into making and organizing this event. The special thanks to IT team Syed Absar and Israfil Khan, who was side by side with Dr. Nurul Anwar to fix this program and conduct the program proficiently. I am sure that the organizers will continue to get significant provision from diverse groups in the future. Thank you, Dr. Nurul Anwar, for being with us, organizing this event so nicely and confidently. Thank you, Dr. Nurul Anwar.
Thanks, ma'am. Thanks for sparing your time and giving vote of thanks. And I'm really thankful to our seniors, both Dr. Aparna Dave and Dr. Afshan B. They are the senior academicians who spared their time because the Sunday weekend is busy for everybody, but people are watching. Just to let you know that there are only 12 participants in the meeting room, but most of them are watching it either on YouTube or medskill.in channel. We have some 100 participants who have registered with us, and they are watching the program yesterday and today as well. This we have done last year on 7th and 8th of March. This year, because 8th March was holy, so we couldn't do on that day. 8th March is the International Women's Day, so we are organizing this. To next year, we again come up with the same idea, and we'll do the same program with further eminent speakers and all. We are really thankful to all our panelists and all, and especially for those who are from different walk of life, like finance team, like finance experts, like legal experts and all. I'm really thankful to Dr. Rachna as well. She had made this panel discussion very live and very interactive. So as of now, we are signing off for the day, and we'll again connect together in other future programs, and we'll definitely willing to invite all people, all different specialists in our program in future as well. Thanks to everybody. We are signing off for the today.
Thank you.
Okay, have a nice day, and thanks for all. Yeah. Okay, we are closing. Thank you.